A good morning and very warm welcome to everyone to day 2 of Narayana Neuro-Oncology Symposium. So to start off, we have our sixth session. I request Dr. Kiran M., Senior Consultant Neurosurgeon, Narayana Health, Dr. Subramanian Kannan, Senior Consultant Endocrinology, Narayana Health, and Dr. Parthiban, Senior Consultant, Kovai Medical Center, to please chair the next session.
Thank you. Good morning. I think we'll start with the first talk by Dr. Subramanian Kannan on the updates of post-neurosurgery sodium management.
Good morning, everyone, and a sincere thanks to the Department of Neurosurgery for giving me this opportunity. It's always been a pleasure to be working with them for the last 10 years and handling almost all of their complicated post-operative sodium problems. When I began preparing the slides, I first thought, let me just do a few cases and discuss the cases and have an interactive session. But then I thought I only have about 20 minutes, and I told Dr. Amrita, 20 minutes for sodium disorders is just not enough. It's a very complicated topic, and I also will put my shoes of a neurosurgery resident in the middle of the night, getting a call from a nurse saying that the sodium is 120, and at the comfort of my home, I can always look through pathophysiological mechanisms and dream about what kind of hyponatremia is this and all the things. But that resident at that point of time has to make a call. What do you have to do quickly? So what shall we cover today will be very practical. And in fact, these are all points that I have not referred from any books. Of course, I will put in some slides for recent advances and what we have learned. But the total presentation will all be experience gained over the last 8 to 10 years in consistently managing sodium problems post-operatively. Of course, a few patients that we also see after the surgery on discharge. So you can probably call it a little opinionated talk of what I think management should be and how it should be. Of course, I'm willing to disagree if there are significant opinions against it as well. But the things that we will cover today is how to approach hyponatremia from a neurosurgery resident point of view. So that's number one. What are the common causes of hyponatremia in the neurosurgery post-operative context? The 3% saline is the kind of the brahmastra that we all have for managing the hyponatremia. Now, what are the do's and don'ts when you use that? And the tolvaptan, I think you all have now learned it has become a game changer. We've used it quite a bit in the hospital setting, and it really helps us expedite discharges. And of course, how to handle discharge planning, which I think is a very, very important step. You really don't want the patient coming back to the hospital with a bout of recurrent hyponatremia. And probably finish off with a few slides on diabetes insipidus and hypernatremia, which is again a very complicated and a difficult topic, but we'll probably touch upon some of the important pearls and pitfalls there. We'll start with hyponatremia. When there's a call for hyponatremia to the endocrine service, I ask my resident or my registrar, who's giving us the reference? Is it a head and neck surgery who's calling us? Is it a medicine pulmonary resident who's calling us? Or is it a neurosurgery who's calling us? Because hyponatremia and neurosurgery is quite a different ball game compared to other people. Why? These are people who are very susceptible to develop hyponatremia. The clinical manifestations of hyponatremia are not going to be classic. You're not going to be expecting all the classical symptoms of hyponatremia in these patients. And in fact, their symptoms may be amplified by a pre-existing problem that is ongoing in the brain after a surgery. The stakes are very high. You have to make decisions very quickly, because if the hyponatremia worsens very quickly, then the post-operative complications and seizures can really worsen mortality, morbidity, and in fact, at some times, mortality as well. And here is one scenario where the drop will be sharp and fast, and you have to correct it quickly. A lot of times, if you talk to a medicine resident, they're very afraid of 3% saline. They would not want to raise the sodium too quickly. They're really worried about, I'm worried about fast correction. I'm worried about osmotic demyelination. But neurosurgery is one stage where a sharp drop has to be corrected quickly. Otherwise, you're going to lose the chance of complications setting in. And this is probably one department where we very frequently encourage using 3% saline, because it has a good efficacy in terms of correcting the sodium to normal or near normal levels. And then, this is also a state where you cannot just treat the hyponatremia and then walk off saying, all is well, goodbye, call us if there's a problem. You need to have a follow-up plan, and discharge should also be planned. What should be done when the patient goes home? So the stakes are different. Neurosurgery call for hyponatremia is always a little different from other departments. You all know the symptoms and signs, but as I told you, it's very difficult to judge what's going on in somebody who's just had a neurosurgery. I put this mild, moderate, severe just to give that little alert in your mind. The symptoms don't really correlate. Sometimes you may have mild hyponatremia, but the manifestations may be amplified because of an underlying problem. The rapidity of fall of sodium determines the symptoms. Somebody who's had an acute hyponatremia, the sodium drops from 135 to 130, will probably have more symptoms than somebody who's lingering along 125 to 130 without much change in the last few days. So the rapidity of fall is what will determine the symptoms of hyponatremia. But it also is good to have some kind of a judgmental in terms of treatment. What do you want to use? What do you want to use? You want to use fluid restriction? You want to use tolvaptan? You want to use 3% saline, or you want to just observe? Those kind of decisions, it's good to have some ballpark numbers to judge what therapeutic strategy will work in which setting. When you talk to medical residents, the algorithm for hyponatremia is very complex. They will have to look at euvolemia, hypovolemia, hypervolemia. Is it hypertonic, hypotonic? Are your urine sodiums, urine osmolality? This algorithm does not help a neurosurgery resident. I'll give you 3 simple algorithms that you can follow in your practice. If a patient in the post-operative setting, remember we're talking about post-operative setting. We're not talking of somebody who's coming to your OPD with hyponatremia. I'm not talking of that case. We're talking of somebody who's in the post-operative setting, either is in the SICU or is in the MICU or is in the ward, has developed a new onset hyponatremia, has vomiting, disoriented, has become slow, who's not responding to your usual questions and commands, and there is a drop of sodium that has gone down below 130. This is a kind of an emergency. You need to quickly address that. You will start him on therapy first and then decide about evaluating. Here, evaluation takes a second step. Treatment takes the first step. Ask yourself 2 important questions. Does he need steroids? Second, are there drugs in my medicine card that can cause hyponatremia? These 2 questions always in your mind. So, acute symptomatic hyponatremia in a post-operative setting warrants therapy before evaluation. But 2 questions that keeps in your mind: does the patient need steroids? Second, are there drugs in the card which actually worsen the hyponatremia? Second important setting is where you expect hyponatremia to occur. Subarachnoid hemorrhage, if it is particularly an ACOM aneurysm, traumatic brain injury, brain metastasis from a disease, malignant disease, or it's a massive stroke which is requiring surgery or decompression or whatsoever. These are patients in whom inevitably hyponatremia will occur because of a strong stimulus for ADH secretion. And these are patients in whom you should be preemptive in starting medicines at a level of a sodium where things are not too bad. If the sodium is hovering around 130 to 135, you might want to even start tolvaptan and then ask yourself again the same 2 questions that I told you first. Does the patient need steroids, or are there drugs in the card that is causing hyponatremia? So this is important in a setting where hyponatremia will definitely occur in the day 3, day 4, day 5 after the surgery or after the admission. The third important clinical setting where hyponatremia is frequently encountered is when the patients undergo cellular or supracellular surgery, either it's a transphenoidal or a transcranial route, does not matter. Now, you know the complexity involved in these cases. There is initially a polyuric phase, and then an antidiuretic phase, and then may or may not be a permanent diabetes insipidus phase. So you may have either a polyuric followed by a antidiuretic phase, or you may have a straightaway antidiuretic phase. Why it is very important? The day 4 onwards, day 4 after surgery, or sometimes even day 3 after surgery, you start noticing that the sodium starts dropping down. These are patients in whom, if you discharge them by day 7, they will bounce back right away with a severe symptomatic hyponatremia. Sodium falls pretty rapidly, and these patients are very resistant to treatment with fluid restriction or with salt tablets. These will not recover with those medicines. These patients will need aggressive therapy. So it's extremely important. This is one setting where you have to anticipate hyponatremia is almost always going to occur. In fact, over a period of time, you have learned that patients who are stable post-pituitary surgery, we discharge them with a little bit of fluid restriction and have them on very close follow-up post-discharge, so that if they at all drop quickly, we can institute therapy so that they recover quickly and they don't have to come to the hospital for a 3% saline infusion. The last algorithm point of view is if your spine patient develops hyponatremia, you got a vertebral problem, you got hyponatremia, pause. That's not the case where you're going to rush in with 3% saline. That almost always, if a spine patient has developed a hyponatremia, it's very likely drugs are involved. And drugs are the most common cause of hyponatremia in this setting. Hypothyroidism, heart failure, liver disease, all those things are smaller fractions, but the majority of times it is drugs. Diuretics, in our study a few years back, when we looked at in-hospital hyponatremia, thiazide, chlorothalidone diuretics are the most common cause of hyponatremia. Among your anti-epileptics, very luckily, phenytoin is not a cause of hyponatremia. In fact, carbamazepine and oxcarbazepine are common causes of hyponatremia. Antidepressants, particularly sertraline, amitriptyline, venlafaxine, can cause hyponatremia. NSAIDs, PPIs, we commonly prescribe, tramadol, we commonly prescribe for pain control, can worsen hyponatremia. Amiodarone, we've had quite a few patients in the hospital with amiodarone, particularly who have cardiac issues, amiodarone can cause. Patients who are on desmopressin, if you overdose it, or if the patient takes too much of fluids, or if you're giving too much of IV fluids, they can develop hyponatremia as well. So this is what I want you to think about. Is this an acute symptomatic hyponatremia? Is it a patient who's almost always going to develop hyponatremia? What do you do for that? If it's a pituitary patient, timing of the hyponatremia is important and planning of discharge is important. And lastly, if it's a spine patient, think a little differently. Here you're going to deal with medical reasons for hyponatremia. What are the tools we have for investigating hyponatremia? It is always important to get a baseline serum sodium. If you're going to operate somebody for us in the setting of neurosurgery, it's sensible to get a baseline serum sodium. You always want to know, are we starting at 128, or are we starting at 135, or are we starting at 142? So it's good to have a baseline serum sodium. In your preoperative testing, ensure that the sodium is always got. A urine sodium at the time of hyponatremia is very useful. I would encourage that if you have started somebody on 3% saline, you may want to pause it for about half an hour and then collect the sample for urine sodium. A urine sodium that is less than 30 usually and almost always indicates volume depletion. And if the urine sodium is less than 30, you are right enough. Nobody will question you. Nobody will find fault with you to give them patient normal saline. So less than 30 of a urine sodium means that there is significant fluid loss, or patient is quite dehydrated. It's very uncommon to have this setting in a hospitalized post-operative patient. In fact, a lot of patients get fluid. So less than 30 is unlikely to happen. More or less, you will have a urine sodium that is more than 30. But if you have urine sodium less than 30, that is a patient you want to give more fluids. If the patient is on diuretics before, say for example, furosemide, toracimide, metalazone, urine sodium will not help you, because a diuretic is almost always going to enhance urinary sodium excretion. So urine sodium will be high, and that will not tell you if patient is dehydrated or not. Uric acid, Dr. Nair mentioned fraction excretion of urate. Uric acid is a very simple tool to tell you volume status of the patient. If uric acid is low, that means patient's got plenty of fluid in the body. In fact, in the diagnostic criteria of SIADH, one of the entity is a low uric acid. So if you have a low uric acid, it tells you fluid is more, you need to diurese them, give, tolvaptan will work really well. If the uric acid is very high, indicates to you that diuresis have been almost maximally established, you are probably dealing with a dry patient who needs fluids. Urine specific gravity, most of the books will tell you urine osmolality. Most of the labs who do urine osmolality don't do it in the right way, and the reports we get are all confounded and are difficult to interpret. I look at two things. I look at the color of the urine and I look at the urine specific gravity. Urine specific gravity is a reasonably objective way of judging how concentrated or how dilute the urine is. Remember, in SIAD, we don't call it SIADH anymore. We call it SIAD, syndrome of inappropriate AD secretion. You have a concentrated urine. The urine is yellow, the volume is less. So you will have a concentrated urine. When you have a very dilute urine in a setting of hyponatremia, be very careful. Don't push a lot of 3% saline in those cases. Urine output again is a very valuable tool. If the patient is passing a lot of urine, then the hyponatremia is not going to be very severe. In fact, they may recover quickly. Don't be very aggressive in their therapy. If the urine output is very less, you can't do fluid restriction with them. If the patient is passing about 1 liter per day or 1.5 liters per day, you can't put him on 800 ml of fluid restriction. That will not work. That will not improve your serum sodium. So output of the urine is also an important tool. Don't always think it's a lab that is going to help you. Color of the urine and output of the urine is going to be very useful. At a baseline, thyroid function test is useful. Thyroid hormone is important for excreting free water. So that is useful. Cortisol, a random cortisol is also enough. Because when patients are sick, you just can get a random cortisol. You don't need an 8 AM sample. Make sure patient is not on steroids. If patient is on dexamethasone, hydrocortisone, methylprednisolone, don't get a cortisol level. It's not useful. And you have already put the patient on steroids. So that's why the two questions that I asked you to remember is that does the patient need steroids? And are there any drugs causing hyponatremia? So if the patient is not on steroids, get a cortisol level. The last but not the least is how is the sodium responding to your therapy? If you give somebody fluids, if you give somebody 3%, if you give somebody tolvaptan, assess the response to therapy. Response to therapy, in fact, will tell you if you are going in the right direction or not. So monitoring sodiums more than 2 or 3 times a day will actually give you a good clue. That's why we often tell, right, to monitor it 6th hourly, monitor it 4th hourly, monitor it 8th hourly. We tell that because we want to see how is our response to treatment going. And keep in mind, when hyponatremia is multifactorial, your response to treatment will change. A classic example is somebody is on chlorothalidone diuretic, comes to you with post-operative hyponatremia. Initial response therapy will be with fluids. You give them good amount of fluids, they will respond beautifully with them. After some time, you give more and more fluids, the sodium will start dropping down again, where you will have to add either a fluid restriction or a tolvaptan. So response to therapy is in fact a valuable investigative tool in management of hyponatremia. So if you look at the causes of hyponatremia in an admitted neurosurgery patient, first and foremost, and in fact the most common in almost all series published worldwide, is syndrome of inappropriate AD secretion or syndrome of inappropriate antidiuretic hormone secretion. We used to call it SIADH. That H is now removed because it may not be a hypersecretion of ADH, it may be a hyper-responsiveness to the antidiuretic hormone. The sodium will generally be low, the urine sodium will generally be high, you'll have a concentrated urine. Remember the term, the blood will be like water, the urine will be like honey. That is the usual description for a typical SIAD patient. The blood is water and the urine is like honey. Thyroid is normal, cortisol is more than 10. Output will generally not be very brisk. Urine output will be generally less than 2 liters per day. Central adrenal insufficiency, where the pituitary gland is involved or the hypothalamic axis is involved, has been now more and more recognized, particularly in ACOM aneurysms, patients with traumatic brain injury, and in patients who have infarcts that involve the hypothalamic areas and pituitary areas. You will almost always have central adrenal insufficiency. And in these patients, it will mimic almost like SIAD. The only difference is your random cortisol will be less than 5. You may sometimes not recognize this because you are regularly putting somebody on steroids post-operatively. You may not even know that patient was adrenal insufficient, and that's why they recovered from hyponatremia. But it is important to keep this in mind. And if you're going to start somebody on steroids and if they're hyponatremic, send a random cortisol. It is a valuable tool to assess what their adrenal axis is like. And lastly, you have drugs, diuretics. Diuretics are the notorious to cause hyponatremia postoperatively. Here, your urine serum sodium will be low. Urine sodium can be variable depending on the diuretic used and the duration of use. Specific gravity can be variable. Thyroid will be normal. Cortisol will be normal. And output also will be quite brisk here. Unlike SIAD where you actually have less urine output, diuretic-induced hyponatremia usually can have brisk output as well. I added this in the last minute because I have not encountered a convincing case of cerebral salt wasting till date. But there are reports stating that this is an entity that one has to know and keep an eye out for. I'll just put out the important parts. Here again, sodium will be low, urine sodium will be quite high. But the most important thing, you will have a large volume diuresis. So basically, you will have salt and water excretion at a very brisk rate, causing dehydration. Patient will be clinically dehydrated, and most importantly, patient will respond to normal saline. Now, it's very difficult sometimes to judge between cerebral salt wasting and SIAD. Clues are usually uric acid. Uric acid, as I told you, will go high up if patient is dehydrated, and will be low down if it is SIAD. So if you get a uric acid level and it is quite high, try pushing out more fluids, patients will generally recover. If the uric acid is very low, try avoiding fluids. Maybe the patient needs to excrete the water out. Maybe they will do better with tolvaptan. 3% saline. 3% saline is kind of magic bullet we have. It is not important to have a center line for a 3% saline. Studies have come out to state that the thrombophlebitis risk is actually not very high, and you don't need a center line. You don't need to shift the patient to the ICU for a 3% saline management. It is extremely important you monitor the sodium closely when you put a patient on 3%. You cannot start 3% and then walk away. Using rates, the usual rates for starting is the typical formula used is the 0.5 into body weight into anticipated rise. If you keep the sodium rise for 24 hours as 10 millimoles, milliequivalents per liter, that will come at around 0.4 is the anticipated rise of sodium per hour. And that is how you all typically arrive at the formula of 30 ml per hour. You've got 3% saline, 30 ml per hour. The reason why that formula comes is from this little equation. Be very careful when you have crossed 8 to 10 milliequivalents of sodium. Be very careful that you may want to cut off the 3% saline and add supplemental therapy so the sodium does not drop down and you are able to maintain the sodium without much of 3% saline. So additional therapies are very important. Starting off sometimes may not help, and patients may go down back to hyponatremia again. Risk of osmotic demyelination happens when the duration of hyponatremia has been more than 48 to 72 hours. And you all know chronic hyponatremia is one of the commonest culprits, sodium being very low, malnourished, alcohol, liver disease, hypokalemia. A typical alcohol patient who's fallen down comes to either severe SDH or an EDH, and you're operated, and then he's post-operatively hyponatremic. Be careful of that patient. The more thinner the patient, the lesser the BMI of the patient, be slow with the 3% saline. Now, one new thing that is there in the osmotic demyelination syndrome is you can re-lower the sodium. In case you have pushed the sodium too fast, you are afraid that your patient is going for osmotic demyelination, you can actually re-lower it back down using dextrose and vasopressin. And this can be done so that you end up getting the sodium back to around 125 and then wait, and then you decide how aggressive you want to be in terms of correcting the sodium again. So you can do recorrection of or re-lowering of patients' sodium in patients who are at very high risk of developing osmotic demyelination. Fluid restriction is a treatment that is often used in mild to moderate SIADH. The fluids generally have to be kept around 800 to 1.5 liters and less. Keep in mind, it's all fluids, not just water. So anything that is drinkable is to be cut down. The risk of ODS or osmotic demyelination with just fluid restriction is practically zero. That's why it's a very useful tool to use in mild to moderate. But as I told you before, it will not work if the urine output is already less, if the urine is very concentrated. If the urine sodium is greater than serum sodium, your fluid restriction will not work. And it's practically not possible to do it in the ICU, where almost every little drug is given through some fluids. You cannot really put them on fluid restriction. Tolvaptan has become a magic bullet. It helps in cost saving because you're able to discharge patients early. It's an oral AVP antagonist. The dose typically is about 7.5 to 15 milligrams as starting dose, and you can go up to 30 to 45 milligrams. The risk of ODS, osmotic demyelination, is low with tolvaptan, but it is not completely zero. So although, we use it left and right, you have to be careful not to escalate too fast of a correction. Avoid fluid restriction while somebody is on tolvaptan. If somebody is on tolvaptan, don't put them on fluid restriction also. Common side effects include dry mouth, orthostatic hypotension, increased urinary frequency, and it's not effective if you have a creatinine that is more than 3 and you want to avoid it in patients with liver disease. When sodium does not rise with tolvaptan almost always will increase sodium in either it is a hypervolemic hyponatremia or a euvolemic hyponatremia, it will increase it. The only time tolvaptan will not work is when somebody is hypovolemic and that patient needs fluids. So if you have somebody on diuretics and is on significantly dehydrated, then tolvaptan will not really work. Do salt tablets help? Probably it does to some extent. So I don't argue with neurosurgery people when they add soda mint. I tell them it's okay because salt itself will ensure some diuresis. So it will help in patients with SIAD as well. Discharging patients on any of these above entities, I'll quickly go through this because we're running out of time. Sodium discharge, monitoring on discharge at least twice a week, 2 exceptions, post-pituitary surgery and in patients who have diabetes insipidus, we almost ask them for a daily sodiums, but for most of the patients, at least 2 times or 3 times a week, we monitor. Once the sodium crosses 140, we stop the salt tablets and we give them only If the sodium is crossed 140, then you can stop the salt tablets or relax the fluid restriction. If the sodium is consistently more than 140 for about 2 weeks, then you can safely stop the tolvaptan. If the sodium is between 135 to 140, reduce the dose of tolvaptan, don't stop it yet. And if the sodium is less than 135, don't stop the tolvaptan. The underlying SIADH is still continuing and may need a little longer time. Last but not the least, the last few slides on hypernatremia. Polyuria is a common problem in the post-operative setting, usually defined as more than 50 ml per kg per day or 4 ml per kg per hour. Exclude solute-driven diuresis. If it is a hypertonic polyuria, if it is glucose-driven or it is mannitol-driven, or sometimes when they push in a lot of fluids during the intraoperative setting, after the pain settles down, there will be a frank diuresis. So post-operative fluid excretion is also possible. Acromegaly tend to have a lot of fluid excretion because of the subcutaneous buildup of soft tissue as well. And most importantly, if there's a solute-driven polyuria, sodium will generally not go up. Sodium will in fact be normal or low normal. So you don't have to really panic about these polyurias and you don't have to really go rushing to correct these polyurias. In fact, the more fluids you give, the more polyuria will persist. What defines diabetes insipidus is a hypotonic urine. Urine specific gravity is very low. In fact, if you look at the urine bag, it will be like water. There will be polyuria, and the sodium typically will be more than 140. In fact, frank DI will be more than 145. There is one setting when polyuria will not occur in the setting of central DI, that if patient is extremely dehydrated, if sodiums have gone up to 165, 170s, the polyuria may not be as high as what defines polyuria. So don't get fooled when sometimes you correct the dehydration, the polyuria will come back again. I'll skip the copeptine because it's we're running out of time. And then the principles in treatment of DI. The fluid replacement, you have to look at the already lost, what's already lost in terms of fluids, what they're currently losing. And typical fluids are usually half normal saline or dextrose fluids, free water orally or through the NG tube, and an intact thirst from the patient will really help. Reducing the urine output actually helps us in managing some of these patients with diabetes insipidus. In the first 48 hours in the post-operative, particularly if it's a craniopharyngioma patient, rapid correction is warranted because these patients have 3 things. One, they're intubated or just extubated. They cannot have fluids properly. They have a brisk polyuria, so you'll have to judge what they're losing at the current point. Also take into account what they have lost during the surgery. A lot of times the anesthetist may not replace all the fluids that has gone out during the surgery. And sometimes we see one value of urine output of 200 ml. And then we say, okay, let's wait for the next output. And bam, the next sodium is 170. And you lost time. Acute hypernatremia can trigger vasospasm and can cause arterial thrombosis. So brisk infusion of 5% dextrose with vasopressin every 4 to 6 hours is important. Keep in mind, vasopressin comes in a 20 unit per ml solution. If you want to give 5 units or 10 units, you may have to use an insulin syringe to give vasopressin. Now, if you have somebody with an intact thirst, it makes it a lot easier. Allow the patient to regulate fluid balance. Access to water is important. Keep the water near the patient. Oral fluid replacement is the best. Subcutaneous injections of short-acting vasopressin 5 to 10 units. Do not give the next dose of vasopressin until the polyuria has recurred. You don't want to give stacking up dose of vasopressin because you may end up with hyponatremia. And again, do not give vasopressin if the sodium is below 140. Keep in mind the triphasic response. If you are using vasopressin in the acute DI phase in a post-pituitary patient, by day 4, day 5, they will go into the antidiuretic phase. You may worsen hyponatremia. So you have to be careful when you use it in post-pituitary patients. The analog of vasopressin is the DDAVP. The DDAVP is available in 3 forms: the tablet form, the 0.1 milligram tablet. You also have the nasal spray, which is the 10 microgram per dose spray. Now the newer one is a sublingual Minorin, the melt form, which is available as 60 and 120 micrograms. Be careful about writing the dose. The number 1 cause of medico-legal issues abroad with diabetes insipidus is in fact the dosing of desmopressin. So if you're writing desmopressin, be very clear about what you're writing. Of course, they also have desmopressin injections. We don't have desmopressin injections. So, but tablets, the strength of the tablet, the strength of the spray, and the strength of the melt is slightly different. So be careful when you write the dose down. We are using DDAVP, preferably to start as a small dose in the night to prevent the nocturia. And over a times, you have to adjust the dose over a period of time, and you monitor sodium every day. And if patient does not have an intact thirst, we call this an adipsic diabetes insipidus. You fix the DDAVP dose at once a day or twice a day, and then rotate the fluids around it to maintain eunatremia. I'll stop here. Sorry for a little long lecture, but thank you for your attention. I'll be happy to answer questions.
Thank you. Certainly, it's a very big subject, cannot be covered in a very short time, but it has given a good view to the students and also to us neurosurgeons. Thank you very much. I think we'll move on to the, if there is no questions.
Thank you, sir.
Yeah. We're very happy that these are all recorded. So, you know, it is easy to revisit the lectures and know more about it. Now I call Dr.
I think I wanted to ask some questions.
Yeah. Good.
Sorry, chronic hyponatremias, when they come to ER in a drowsy state, like is there a role to give 3% bolus initially?
Bolus therapies have been advocated in many centers and they've used it successfully. What I have found, at least in the personal experience, has been the infusion over a shorter period of time. So you start at 30 ml per hour and you give it over about 3 to 4 hours. And that's it. And you just push them up a little bit higher. More than 120, you are satisfied that they will not have a seizure. And then you can then stabilize them and then discuss what next to be done. But running a 100 ml bag fast over an hour, generally a little risky because the sodium rise is expected to be about 4 to 5 milliequivalents with 100 ml concentrated 3% saline. Whereas if you do it by 30 ml per hour, you have a little leeway of doing it a little slowly. And in case we miss and we do a little overcorrections, it won't be too bad. But so in chronic hyponatremia, come to the ER, you know that their sodiums have been low before. Better to start with 3% at a smaller rate. As I told you, the leaner the patient, the lower the rate. So keep the formula, 0.5 into kg into the desired correction rates. The desired correction rate is typically kept as 0.4, but you can reduce it to 0.3 or 0.2 if you think it's a lean patient. A lean patient, be very careful. They are the ones who will eventually end up getting ODS. And in case you overcorrect, don't be afraid to start D5 or vasopressin, get it down so that the early part of ODS is now thought to be reversible also. So you may be able to reverse certain things quickly if you quickly find that you've overcorrected.
Thank you.
But then, but then how will you assess that 0.4 or 0.3? You said, but people like us,
so that is basically how much of sodium you want to go up in the 24-hour period.
Expected.
So 10 milliequivalents per liter for 24 hours is 0.4. Okay. So if you want to say, I want to only do 6 milliequivalents, I don't want to move on 16, then do 6 by 24. That will be much lesser than 0.4. But keep the body weight in the equation. That will help us in not going too fast.
Thank you. Thank you very much.
Thank you.
Now I call Dr. Kiran. to talk on the functional preservation in surgery for pituitary adenomas.
ಡೈರೆಕ್ಟ್ HDMI ಇದೆಯಲ್ಲ ಆ ಕಡೆ. We'll cover one more important aspect or complications which we encounter most commonly in pituitaries and cellular and supracellular. It's a very good morning, but be ready to encounter some of the not so pleasant things. It's a common thing. When we do a good surgery, you say, I operated very well, facial nerve is preserved and so on and so forth. But when complication occurs, we say it occurs. We never say that we did the complication. We said, oh, ICA got injured and so on and so forth, as if ICA was moving and came to our surgical field. So it is equally important that we look back and recognize our complications. In that way, we learn a lot. In fact, learned wise men say that you learn more from complications, either yours or others, than what you learn from, reading other things. So, pituitary endoscopic endonasal approach has changed the paradigm shift in the approach. It has, and two surgeon or forehand technique, what we call, as decisively pushed towards endoscopic. Yesterday we have, acknowledged and went through some of even head and neck tumors now can be operated endoscopic. That is mainly because of two things. One, because of this forehand technique, we can operate as if we are operating on a microscope. Because we have two surgeon who will be operating inside with his two hand and most important navigation, that is assistant, will be there to guide you. He will say, oh, you are missing somewhere, you be careful, or always that opinion will be there. This is like not a robot, but a human being who will be guiding with you. And before, in a single surgeon technique, we used to have subtotal resections, embarrassments. We say, oh, we have got a very good surgery and other things. And when we do a scan, we find out that 80% of the tumor is left. So such a things have become less. And in fact, if there becomes unexpected bleeding, oozing and other things, using a single hand technique, we used to find a lot of problem. So these two surgeons, as I told, has a better control. The dynamic viewing, this almost gives a 3D vision, and tumor removal is better and mutual feedback, which makes the surgery safer and also more appropriate. So I call this an optimally invasive surgery. So the principles we should all remember, this anatomical corridors must make sense, and exposure always should allow bimanual. Even if we are planning to do initially, if it is a small pituitary tumor, we may operate, majority of this by a single thing, but we should always keep this axis ready in case of, I'll come to it why. And adherence to micro neurosurgical tumor resection principles, such as margin, as much as possible, complete resection is a must, especially in functional tumors, such as growth hormone, which can be a macroadenoma, unlike cortisol secreting, which usually will be microadenoma. Excision complete makes a large difference, and we should always plan with reconstruction beforehand. And current possibilities We know sagittal plane all the way from cribriform to clivus we can operate, and even up to C2 we can reach. And whereas in horizontal plane we can start with from petrous apex up to infratemporal fossa we can go. Yesterday we have covered most of this. And our learning should always be in a stepwise manner. Like just because we have studied a little bit of endoscopic doesn't mean that you operate everything. So initially we should start with a sinonasal surgery assisting CSF leaks, go on to pituitary, and maybe later on intradural and other things. Always the surgical principles, the anatomy and the functional paradigm have to be kept in mind. We should not compromise in any stage, because just because we have a new tool doesn't mean that, okay, I will try endoscopy and things like that. Nowhere we should always compromise on the neural integrity. That should be always paramount importance. And we can divide into 4 stages. And first stage is the nasal stage. Usually there will be a flaps, septostomy, and sphenopalatine artery is one artery which we should carefully watch out at this stage. And usually what we encountered, Dr. Kannan also will notice during follow-up, is that quite a significant amount patients, number of patients used to complain of anosmia in the follow-up. So what we decided was that instead of doing a large flap, we do a tailored flap. So instead of going all the way to the cribriform, we now reduce the flap at the level of middle turbinate, and then if needed we go inferiorly near the palate if we need to take a bigger flap. This has helped us in reducing the incidence of the anosmia. And as you saw, the important landmark first issue is we should open the sphenoid ostium. So once we open the sphenoid ostium, we know exactly the reference where exactly and what is the lay of the sella and this sphenoid. Based on that, we can alter the flap. Otherwise, straight away, if we start taking the flap, we will end up taking a very big flap, which is not needed and may cause anosmia. This is one important technique which we learned. And also the one more opposite flap will be there, that we can cut it short instead of keeping a bigger flap, so that we can roll it over to the septum. So this will reduce crusting a lot. So this is next most important is sphenoid stage. To reach itself is depending on the lie of the sphenoid, what type of sphenoid we'll have. So at the end of the sphenoid gel stage, the sella or the floor should be very clearly visible like this. Otherwise, we will land up in trouble. Always, if not, we can see everything, at least few of the landmarks, that is the clival carotid, OCRs medial and lateral, one of them should be seen. That will be a very important landmark. If it is not there, you be very, very, very careful. So this stage, why I'll tell you. This was a small pituitary tumor which we were operating, and then as you are seeing the lay of it, it was not as beautiful as it used to be. It should be in the previous diagram. And what was an innocuous and simple surgery almost led into a nightmare. So this was a carotid injury. And mind you, most of the carotid injuries in a pituitary case occurs with smaller tumor and not bigger tumors. And you will have a different phase, initially a stage of chaos, and then followed by a stage of damage control. You will think, oh, why did I operate patient? Then you will go into why I took up medicine and why was I born. All these 3 phases you will encounter while operating. Then, I think video is not running. Yeah, the most important, we should forget and suppress all those thinking and back up our resources, call for help. This is what the most important thing we should do. We should we call for the help. We should think of the strategies, what to do, accept that the injury has occurred. Most of the time, oh, it is not a carotid injury, it is some other small vessel, it is bleeding, BP is high, and so on and so forth, we will be telling. So most important, we should accept that IC injury has occurred. And next is, once we pack or bleeding is controlled, in case of IC injury, we should avoid the temptation to remove the pack. Many times we do it. Once unusual bleeding occurs in a pituitary or sella, we should have a backup plan and then take it up. Like how we did in this case, we called for a neuro intervention. We told them such a thing has happened. The suite was, kept vacant. We immediately shifted the patient. We did an angiogram. We saw the IC injury, and luckily the collaterals were good. And then we had to sacrifice that by putting coils into the ICA, and the patient did well. And this was a small pituitary and not a big or microadenomas. So this is how it is. He had a good circulation and it was blocked. So let us study. We went back and did what exactly we went wrong. The ICA injury, it is not always because, surgeons, of course, ultimately is responsible. They can have anatomical variation, the surgical difficulty, and of course, surgical mistakes. The important point is bony wall overlying the ICA can be sometimes very thin. And in fact, there may not be any bony covering at all. It can be, that's why we should avoid, using too much monopolar at this stage, in the sphenoidal stage. And it can be dehiscent also. And in what is called as kissing carotid, the ICAs can come and almost touch each other. That is why it is very important. And in 71%, we found it can be as low as 4 mm. So we went back and studied the CT scans of normal patient. We did a study of 50 patients, the degree of pneumatization, whether what type concha, precellar, etc., and the septations to see any clue we got. And we found the cellular type of pneumatization was most common, and precellar was about 28%. And what happens here is, in cellular type, there will be a multiple septations. Usually, there won't be one, there will be multiple septations. It can be vertical, horizontal, oblique, or combination. And at least 1 or 2 of the septations will directly lead to carotid. This is very important. So we should, that's why I told in the first thing that before opening the cellular floor, ensure that all the septums are removed, and then it should be as neat as a football field. And then we should see at least 1 or 2 of the landmarks. Navigation sometimes may not be reliable. 1 or 2 landmarks like a clival carotid or opticocarotid recess, one of these we should see and open in the midline. And Vomer is also there. Vomer is also not a reliable midline indicator, but we should take all these references and open from midline and go laterally. That should be our aim. And this is all our pictures where we see, this is a precellular type. Usually there will be a midline septum. And here you see, this is cellular type. One of that is the right side septum directly is going into carotid. And this is one more where the left one is going to carotid. And similar to these are multiple septations are there. And that is how it is. This is a paramedian septum. One of these, this is a onodi cell, but one of your septum is leading to carotid. Videos are not working. Okay. Yeah, this is, you see the initially where how many septums are there in the sphenoid. So we need to drill everything meticulously and then open. So the ICA predisposing factors, it can be surgical difficulty like previous surgery, or it can be scarring, or there can be loss of anatomical landmarks. And previous surgery, especially, they can have pseudoaneurysms and medial displacement. These are the different possibilities which can predisposing factors. And surgical mistakes, puncture of the thick sphenoidal wall, surgical approach which deviates from the midline, aggressive curettage, this is during the tumor removal, all these. So there is a curette which is available. One is a blunt ring type and another is a sharp one. So using that sharp one, especially if you are going laterally in a large, can predispose to bleeding. So now we have changed to the blunt ring, round smooth one. So that is how all these factors, and too much of monopolar, or in fact monopolar should be avoided in most of the stages after nasal stage. And this is the algorithm or how it need to be managed. And these are adjuncts which we can keep. Of course, in most of these, I have found out in IC injury is not useful, but you can keep it as a standby in case of other smaller vessel injuries. Now, for the tumor excision stage. So this is a large pituitary tumor. This is a tumor which apoplexy. Why it's not working? Yeah. So then, so we always should open as much as possible from the midline, and also when you are opening even laterally, you should try and come towards the midline and not go towards laterally. Our incision should not extend too much laterally until we are sure that we are nowhere close to the cavernous sinus. And then, of course, some people can open flap, but I find it always comes in the suctioning. So we will try to remove it. So this is the apoplexy which we have excised. So what happens is earlier, sometimes if you are not very careful, the superior arachnoid always descends. So that's why we need to be very careful. So this is a post-operative. This is the advantage of using two-hand technique. We don't do, random curettage. We could see and preserve using the suction and delicate dissection. We can preserve the normal pituitary. And that is how we have found out, our own analysis have found that up to 60 to 70% of the people by 6 months, they will have hormonal, they'll be off hormonal dependence. Even steroid, thyroid, many of them are able to, we are able to get them off it because of this technique. So it is not that, you do extended or, this kind of technique, the incidence of hypopituitarism is more. And here also you can see the preservation of the stalk and the normal pituitary. And the arrow mark shows the vascularized flap which is there. 6 months is not on any hormone replacement. So this is what another important concept or to maintain the functional integrity is the preservation of or avoidance of CSF leak. We found that while opening earlier in the stage, the superior arachnoid falls off. So we have to be very careful with this. And then if needed, we can put a cotton patty and push it up and keep it. And at the end of the surgery, we should ensure that there is no leak from this end. So this is one important see, this is hardly half I've reached and already the arachnoid has fallen into the field. So we should be very careful in these cases and always make it a point to reposition it by using fat or any other materials which we like and a flap if there is CSF leak. Otherwise, we'll miss this. And also these phenoid edges, the cellular floor should be rounded and smooth. If we using upcut and removing, if there is a sharp edge, that can cause CSF leak later, even though it is not there during surgery. So CSF leaks, we find that it can be there as high as 50% before, especially this missed CSF leak. So these are the different reconstructions, causes and failure. One is it can be high flow, there can be increased pressure, inadequate reconstructive material, etc. So high flow, it is patient can have hydrocephalus or obesity or emergence from anesthesia, coughs and buckle, those kind of things also can cause. And second is inadequate graft. We don't plan before what exactly should be the reconstructive material, whether we need any external material like fascia lata. I personally don't use artificial materials too much. So, but we should always have in hand fat, fascia, graft, everything, because we can't rely on one always. And sometimes in Cushing ward people, the fat will not be of good quality, in which case you may need to buttress with something. Then inadequate placement, that is if it is under tension, it can cause migration, or sometimes it can turn and get curled. Because of that, their vascularity will be affected. And if it is under tension, all these have to be considered. So we always bridge the pedicle flap. So sometimes the disruption at that while removing the packing, the pack may be stuck to the flap. So we have to be adequately irrigate and then gently remove it. In a cases where you have used large flap, it is better to do removal under endoscopic guidance. And sometimes there can be a negative suction effect. So these are the things how to prevent it. We should always anticipate whether we need extra reconstructive materials. We could buttress yesterday, day before also, we did a head and neck case where we had put a large flap. We had to buttress it using the Foley's bulb inflated. So that is how we can use it. And these are the arachnoid which I spoke. And to prevent crusting, we can put the other small flap over the septum. This is another patient who was acromegalic and high grade, and after surgery he is doing well. This is how we maintain the functional integrity of the thing. This is one more patient where there was a patient after surgery. This is acromegalic with extension into cavernous sinus. We removed well, but after the surgery, patient developed oculomotor paresis. So this is because of over-enthusiastic packing of the gel form there. After a few days, it became okay. These are the things we should avoid. And these are the delayed complications. It can occur. We have seen multiple. That is why even at discharge, we normally make it a point to call them at 10 to 15 days for evaluation under endoscopy, because they can have epistaxis and sometimes delayed CSF leak. These all can occur. And sometimes when you put fat, the fat also can grow. That is why we need to avoid too much of fat inside the cella, inside the area of the operator. It should be like a bath plug, so off, in and out, or a thin layer is fine. So this is one more where there is a mechanical compression of ICA by apoplexy. These are in literature. That's why we should be all careful. Even if there is a bleeding post-operative little bit, that can cause mechanical compression in the large tumors which we have operated. And of course, surgery in elderly is not, different outcome we have found. And I will avoid our outcome analysis because of want of time. So we should use all the adjuncts necessary. Most of it, this will be there in our, and most important, I feel, is CT scan. We should always get a CT scan in all pituitary cases, and carotid Doppler. These are the two instruments which we all who is doing pituitary surgery should have in their armamentarium. And of course, we all pass through this phase, and we shouldn't be embarrassed about it. And in summary, clival carotid provides an important landmark in our experience. Anosmia can be avoided by a tailored flap. Superior arachnoid flap we should keep fold, which we should keep in mind to avoid CSF leak. Gentle dissection and recognizing pituitary gland decreases the post-op hypopituitarism. Not having an ENT surgeon is not an excuse for not knowing anatomy. Often we leave it to ENT surgeon. It's not always. We should, as a neurosurgeon, now this endoscopy has come into our field, just like our microscope has come about 20, 30 years ago. So there is no way that we should say that, okay, the endoscopy is there, it is a realm of ENT. No. And the learning has to be structured, principled, and continuous. And we should always record our videos and look back where we should do, because the anatomy in this area is totally different from what we are used to it. And we should always learn, expand our horizon, but we should know our limits. And we should not indulge in something like this and cut a sorry figure like Pan Masala had, which these people did. So know our things, know our limit, and stay within this. Thank you very much.
Thank you, Kiran. Very nice topic, and actually, Professor Nair.
Thank you, sir.
The carotid injury, just you told that you sacrifice the carotid after seeing good cross.
Yes, sir.
Presence of cross circulation doesn't always mean that you can sacrifice carotid. It is just, simultaneous filling of the veins. That is important. If there is a delay in venous filling on the opposite side, even if cross circulation is there, they can develop
Delayed deficits. Yes.
And you trap the carotid or you just occluded the carotid?
We occluded using the coil only, sir, end of intervention, which just around the area where that leak was.
Okay. Otherwise, you do proximally, you occlude, then it doesn't guarantee any surety.
No, some backflow can be there, yeah. That's
You have
right.
to trap it also.
Yeah.
I just want to ask you one thing, because how did you manage that period of time between, because the hospitals which have a interventional facility
Yeah.
can, but then in case if this happens in a place where there is no interventional facility, what other suggestions you can give for this?
Yeah,
Injury.
of course, in the present, as sir has told, there are two options. One is, here I will show because that video didn't run, but I think now it will run without. It's a good. So this we saw. So once what we did is most of the bleeding, including aorta, we stopped with packing. So one of the main thing we did was we could pack it. Then once the packing was done, in this case we removed and saw. But that's how the lesson we learned is after the packing stops the bleeding, don't open it. Then you think what exactly to do, what resources you have. As sir has pointed out, if at all you don't have a facility for at least most hospitals will have a facility to do an angiogram. So you should do an angiogram and then try to see the cross circulation others. If it is there, you can try whether either you can do trapping or endoscopic coiling, or nowadays stenting is available. That can, because it was done in an emergency basis, the stent was not available. We could not use it. Otherwise, stent is other options which we can see. This is how the different techniques we can use. There are other ways which are available, like you can use muscle graft and you can use flow seal, that is the hemostatic agents which come. But these are all difficult scenarios to use in endoscopic, and I'm not sure whether it will be comfortable. We see in some videos which will show as soon as you put the flow seal, the bleeding stops. It will stop with other arteries, but I'm not sure whether this will stop, bleeding will be stopping. But whatever you do in packing, if the bleeding has stopped, don't remove it.
Yeah, the one more suggestion given was bone wax. The two things happen. One, in my experience, when the when the vertebral artery was dissected and there was a bleed on a C1, C2 case, my residents were just looking what it was bleeding in. I learned this bone wax packing from a cardiothoracic surgeon. So what it does is about the bone wax, not a small piece,
Round and
large
push
one.
it, yeah.
You push it and keep it there for some time, and then put the gauze packs. So that holds on very well until you shift the patient.
Correct. Yeah.
I'm not very sure about the gauze packs, but the bone wax, it helps. Because in carotid here, in this region, it is well packed. Carotid has not much space to move.
Space to go.
So it will hold out rather than a free vessel, which is difficult.
Thank you.
Thank you. Thank you, Kiran. I think we can move on to the next topic, sir.
The next topic is on the neuroendocrine issues in pediatric brain tumors. I welcome Dr. Purna Kurkure for this talk. Thank you.
Thank you, Dr. Kannan, Dr. Parthiban, Dr. Kiran for chairing this session. The next session is on the pediatric neuro-oncology. We have Dr. Purna Kurkure, President ISNO, and she's the Chief of the Collegium of Oncology Services of Narayana Health. She's with us today. I request her to be in the panel along with Dr. Shibu Pillai and Dr. Sunil Bhatt.
Why is not? I'm not able to. Do you want? You want? I have it on my pen drive also. Can you? This. Is it? It's okay. You can do this. Good morning, and I must thank Neurosurgical Department of Narayana Health, Bangalore, for hosting this very informative symposium in association with Oncology Collegium. As you can see, we have a very good learning session, surgical, and now I'm going to talk about other aspects, particularly in pediatric brain tumors, because the pediatric oncology being my domain, I would just try to highlight certain issues, neuroendocrine, and stage is already set by my previous speakers as to how to manage the sodium or how you can have a very restricted surgical approach to avoid certain complications in suprasellar region. So that makes my talk more relevant after that. And we all know that multidisciplinary approach in pediatric malignancies have led to good 5-year survival rate in excess of 80% for most of the hematolymphoid malignancies. And amongst the pediatric solid tumors, brain tumors are the most common, and they constitute almost 25% of the total oncology burden in any given center. We all know pediatric oncology equivalent of only leukemia and lymphomas, and we forget CNS tumors, but that is not the case, because that is the most common pediatric solid tumors that we come across. But it remains in the domain of mainly the neurosurgeons and radiation oncologists, But pediatric oncologists also have now entered the arena, and this multidisciplinary approach has led to a very significant improvement in the survival. And as you can see, it is in excess of 70% in pediatric brain tumor. And thus, as the cure rates improve, quality of survival becomes more significant. Complete cure and not just the freedom from cancer is a goal in child who has a whole life ahead of it. And thus, the risk of treatment modality that we use to achieve this survival has to be balanced against the contribution of each component of therapy towards the cure. So you have to have the balancing act of the components of therapy that you use and what can it contribute to the late problems leading to hampering the quality of survival. So these balances are very must. And in the cancer control continuum, as we look at as an oncologist, it starts with prevention, early detection, diagnosis, early diagnosis and appropriate treatment, which is always the multidisciplinary approach in most of the pediatric tumors. And this leads to a very good survival, and the survivorship also, long-term follow-up and survivorship also has become a very important component of this continuum. And in those situations where the patients have come late or the disease recurs, equally is the importance of end-of-life care and the palliative care. So this problem of late effects and the associated issues are not hypothetical, but they are very large volume of data available, and particularly in USA, where this movement of looking after the survivors and long-term follow-up started. And they have the data to say that by the year 2020, which has gone by, the pediatric cancer survivors will be in excess of 500,000 in USA, and one of every 530 young adults between the age of 20 to 39 moving on in the society will be the survivor of childhood cancer. So it's a big number and very significant population that we have to handle. In India, we have no such estimates, but we estimate that there are 60,000 new cases of childhood cancers annually. And a conservative estimate of 20% survival also if you keep, because of the heterogeneity of the cancer care that has been available throughout the country, we almost add 10 to 12,000 survivors each year to the population. And there are definite differences between acute toxicity and late effects. Acute toxicities of the therapies are well documented, can usually be anticipated, and you can be prepared for it, and it is often offset by periods of good health. Like between the two chemotherapy cycles, child generally recovers. While the late effects are recently identified, information is incomplete, and many could not have been anticipated and can compromise the health over an entire lifespan. And the late effects are determined. It's not a cause and effect relationship, but it is an interplay of host factors, tumor factors, and treatment factors, which decide the ultimate development of late effect. Host factors are genetics and pre-morbid condition, existing condition, age, gender, and health behaviors of the patient. Site, tumor factors are where is the site, what is the histology, what is the biology and outcome, and treatment is what combinations have you used and how aggressive it has been, which decides the late effect. And thus, you cannot say that a given treatment will lead to definitely this late effects. It may lead in one, but may not lead into another patient with the same problem. And the consequence of cancer survival is basically physical, anatomical, or functional changes, as you can see in many of the organs, amputees or other organ sacrifice, enucleation, organ toxicity and morbidities that lead to premature onset of chronic illnesses, as we have documented it for the cardiovascular problems early setting in after radiation, psychological disturbances and cognitive function disturbances, and socioeconomic burdens. And this population is at increased risk of second malignancies as they go by. In a childhood cancer survivor study, which is the largest cohort in the world, where they have accumulated all the cancer survivors in United States, 14,290 cohort of 14,290 5-year survivors of childhood cancer, and median 32 years at last follow-up. So they have all reached the adulthood. The cumulative incidence and prevalence increased across the lifespan. So as you go by, the problems of late effects, they keep on increasing. Risk is significantly higher with high-risk therapies for primary hypothyroidism is a hazard ratio of 6.6. Hyperthyroidism hazard ratio is 1.8. Thyroid nodules, thyroid cancer, growth hormone deficiency, obesity, and diabetes mellitus. There is a higher prevalence of premature ovarian insufficiency and testosterone insufficiency. Survivors are always increased risk for all thyroid disorders and diabetes mellitus, regardless of treatment exposures as compared to the siblings. So this study has thrown a big light on what kind of endocrine problems you can face. As you can see here, growth hormone deficiency tops the list, and primary hypothyroidism, central hypothyroidism, and so on and so forth. All sequelae in survivors of brain tumor depends on the sex, age, and pubertal stage. Also, the tumor location, anatomical location, and treatment exposures are very important contributing factor. There is a distinct profile of endocrinopathies based on these above considerations, and therefore a targeted endocrine monitoring should be done. Like everybody should not undergo all the investigations, but the physical examination and looking out for the target endocrine sequelae based on the treatment exposure is very important. Endocrine treatment should be supervised by an experienced endocrinologist, and thus again there is a multidisciplinary approach here. And fertility preservation and infertility issues and sexual dysfunction are often overlooked in the young adults, which are of prime importance. Adult survivor of childhood and adolescent cancers require multidisciplinary long-term screening, prevention, and intervention. As you can see here, it's a little busy slide, but what to expect and how to monitor. And as you would see here, growth hormone deficiency, central precocious puberties, luteinizing hormone FSH deficiency, central hypothyroidism, ACTH deficiency, or hyperprolactinemia. The risk factors are the same, and growth hormone deficiency, that is the most sensitive hormone, and at low radiation dose of even 1800 it can manifest. And the importance is given to history and physical examination by maintaining the growth charts in terms of height, weight, weight for height, growth rate means velocity of growth, sitting height, and tenure staging. So the history and physical examination annually is the most important aspect of this monitoring. And whenever indicated, then you go for the laboratory test and find out about, and then more specific tests like GS stimulation test before you consider GSG placement. So is the case with all other endocrine late effects. So the importance is of a follow-up physical examination, which is very, very important before we order the any specific endocrine investigations. There is a relative proportions and overlap among anterior pituitary deficiency following cranial radiotherapy. And what I'm trying to highlight here is a growth hormone deficiency occurs even at a low dose of 1800 or 18 gray. and it is the highest risk is at 30 gray. So it is a very sensitive hormone, and so is the case with FSH, LH. At a lower dose, it can cause precocious puberty, and at a higher dose, generally it causes a deficiency. And other hormones like ACTH and TSH and prolactin, they are more in terms of a deficiency. So this is a whole spectrum of pituitary deficiencies that you can come across depending on the dose of the radiation. And in brain tumors in particular, the late effects may start early, like you don't have to wait like many other late effects on a long-term follow-up. 22% of childhood brain tumor survivors had at least one endocrine disorder within the first 5 years after diagnosis. So you have at hand one issue of following up for the active disease, and you also have to simultaneously manage the endocrine problems. Growth hormone deficiency in 12.5%, central precocious puberty in 12.2%. So as you can see here, the whole variety of endocrine problems may emerge early, because in most of the other late effects, we go by the rule of 5 years from diagnosis and disease-free. And that is the point when we start looking out for the late effects. But so is not the case with brain tumor, because 5 years, most of the problems set in quite early, and you cannot afford to lose this important time in a growing child. So we have to look at the endocrine problems even during this 5 years when the child is at risk for even disease recurrence. So simultaneous attendance to both disease and endocrine problems should be carried out. So in our at Tata Hospital where I was before, we had a ACT clinic, and this is a documentation from the embryonal brain tumors. Even in our own setting, we have seen that how early we can have various problems of growth hormone deficiency, hypothyroidism, and so on. So just to illustrate, this is a case of medulloblastoma who comes on a regular follow-up, was diagnosed at 3 years with surgery, CSI and chemotherapy, and has now developed the poor growth velocity, as you can see here on follow-up, and that warrants, that makes you alert to the situation. One has to look at the endocrine profile now and find out what is the cause for this deviation from the growth velocity. And there are many considerations that how and when would you start the growth hormone. Preferably if the child's age and puberty status is very, very important. The child should have a potential to grow, so the bone age has to be estimated, and the potential to growth has to be documented. Remission status is very important. Disease should be under control, because there is a concern about growth of the disease or recurrence of the disease on growth hormone. But in a large series involving 15 studies and more than 15,000 survivors, they've documented that if the right patient is selected and given growth hormone, the chance of disease coming back is almost non-existent. So it's a selection of the right patient where the disease is under control and there is a need and there is a potential to grow, child is pubertal. When do you stop growth hormone? People say that you should continue as long as there is no fusion, but we also have to remember the access to this costly drug, access and affordability in our setup, and optimize the use of growth hormone to get the maximum benefit with a minimum exposure. And as I have told earlier, that growth hormone generally is first to be affected, and this is in pituitary adenoma. Growth hormone deficiency can be also seen in adults, and untreated growth hormone deficiencies can lead to decreased muscle mass and exercise tolerance. Untreated LH, FSH deficiency can cause hypertension, dyslipidemia, low BMD, and slow walking. And both abdominal obesity, low energy expenditure and muscle weakness, when both are together, and they can benefit by recombinant growth hormone replacement. In a second patient that I will try to illustrate is that there is an existing problem even before we start the treatment in a 60-year-old female who presented with polyuria, polydipsia, weight loss and blurred vision for 1 month, bilateral temporal hemianopia, and MRI brain showed supracellular lesion compressing the optic chiasma. And blood test has revealed a sodium, hypernatremia, and urine specific gravity of 1.010. Patient was thirsty and drinking around 6 liters per day of water. The serum AFP and beta HCG revealed that beta HCG is high, and CSF beta HCG also was high, suggestive of intracranial germinoma. And this child underwent craniotomy and lost total resection, and she was started on all the supplements, hormonal supplements, and also received chemotherapy and whole ventricular radiotherapy. Now, there is a difference between the two patients, one where it is a sequelae and the other which has come with the problems upfront because of the anatomical location. And particularly in this germ cell tumor where we use chemotherapy, we face this problem of hyperhydration which goes along with the chemotherapy, which includes cisplatinum and ifosfamide, both requiring hyperhydration. So it's a very tricky situation for a pediatric oncologist to manage hyperhydration, use of DD, APB, maintain the sodium balance, and give the chemotherapy which is very much needed. Newer RT techniques, I'm sure yesterday I could not attend the meeting because I was busy with the Indian Academy of Pediatrics board meeting, but I'm sure people have highlighted this various technology now being in use, but one has to remember that the anatomical location which is there of the tumor, you cannot take away the endocrinopathies when it is located in those areas completely. You can minimize it, and the bystander effects can be minimized, like cranial spinal irradiation by giving by photon will not decrease the problem, but it can definitely decrease the problems being created by exit dose, like secondarily affecting the thyroid. So such things can be utilized to minimize the problem, but it cannot take away totally the endocrinopathies. In a growth delay in children with non-CNS cancer also exists, and one has to remember this also in mind, that child's growth and development has to be followed up even in non-brain tumors cases for growth and development. Referring to endocrinologist at the right time is very, very important. CNS tumors and other high-risk exposure, at least once within 2 years of treatment completion, they should be evaluated. And earlier, if growth velocity is less than 4 centimeters per year or 8 centimeters during the pubertal spot. Excessive weight gain, early or delayed puberty, less than 8 years in female and less than 9 years in male. Primary and secondary amenorrhea or any endocrine abnormality being detected on clinical evaluation. So the most important thing is a clinical evaluation on a regular follow-up, which should alert a pediatric oncologist to take help of the endocrinologist. So advances in treatment and improved outcome in patients with brain tumors have resulted in increasing numbers of survivors of brain tumors. Neuroendocrine complications due to treatments delivered or the tumor itself by its location are prevalent in survivors of brain tumor. Early recognition and appropriate management of neuroendocrine sequelae using a multidisciplinary approach are key to reducing the potential morbidity and mortality associated with neuroendocrine complications, and development of less invasive or more tumor-directed therapies by way of safe surgery or more precision radiotherapy can lead to decrease in neuroendocrine problems. A long-term follow-up program is a must for any pediatric oncology units, and this is where you switch off your active management and concentrate on the long-term follow-up And clinical and evaluation and monitoring this child for growth and development is very, very important indicator to a pediatric oncologist as to when to do all specialized tests. And for this, we start this after completion of therapy or ACT clinic, where actions are required beyond therapy to achieve cure. And this we had started in data in 1991, and now it has, with the definite objectives of monitoring these children for late effects of therapy and psychosocial rehabilitation. And it is, as you see, it's a multidisciplinary team, pediatric oncologist interacting with array of healthcare professionals like endocrinologists for managing these long-term effects. They are evaluated in these clinics, and psychosocial evaluation forms a very important aspect of these follow-ups, and their grading of the late effects are also available, and they are graded and acted upon accordingly. There is a plan, care plan, which is given to the patient or a survivor who has to carry it, because that population is very mobile and can be anywhere, not under the care of the pediatric oncologist alone, and they should know how to handle any medical situation. So it provides internal and external physicians as well as the patient with information related to cancer treatment, late effects which are present or expected, preventive care recommendations, psychosocial concern, and recommended referrals whenever needed. And thus this is also again a multidisciplinary approach which you follow at this late effect clinic. And not only the medical aspects, but societal aspects also come into play. And we have a model which we have created of medical and societal issues through an NGO like Indian Cancer Society, where we try to optimize the survivorship program. Not only we started off in Mumbai, but now we are trying to facilitate, not create, but facilitate this survivorship movement at all the busy pediatric cancer unit. And I'm very happy to say that Dr. Sunil Bhatt has taken initiative to do it at our health city, along with Indian Cancer Society, and there are many partners across the country where we try to follow up these patients very judiciously to have a complete rehabilitation and comprehensive care. Thank you.
Thank you, Dr. Kurkure, for that very interesting talk highlighting a problem which I think most neurosurgeons probably don't pay attention to. Neuroendocrine disabilities following childhood cancer. When the tumor is not in the suprasellar region, we tend to ignore these kind of problems, I think. But it's a good thing it's slowly getting highlighted and getting picked up and treated nowadays. Any questions? Dr. Kannan, want to?
The ma'am had very nicely put out the importance of the growth chart. I think the majority of endocrine issues will get picked up if a properly maintained growth chart is done. If you, whether it's precautious puberty or it's a growth delay, or for that matter, even hypothyroidism, the first thing to go down will be the growth velocity. So a properly maintained growth chart will actually pick up a lot. You don't need a lot of testing at this point. All that requires is a proper growth chart. And if there's a growth problem, then a bone age to supplement that will help us. The controversy was with growth hormone therapy. And there are various views on it. There are two important complications that one worries about when we initiate growth hormone is whether are we increasing the risk of a second cancer. Ultimately, IGF-1 levels will be high when you give growth hormone, and IGF-1 from a scientific point of view is a mitogenic factor. So you're concerned about whether are you going to worsen the primary problem or are you going to cause a second new problem. But studies have again and again reassured us that growth hormone therapy in that setting, if the patient has been proven to have growth hormone deficiency, is safe. We generally wait for about a year to ensure that everything is stable. They've had radiation and they've had treatments and things have been stable, and repeat imaging has shown stabilization of the disease or reduction of the disease. Then we initiate growth hormone therapy. The second risk that one is concerned when we start growth hormone therapy is about risk of stroke, particularly vascular events, particularly subarachnoid hemorrhage. Again, that is another risk that one is concerned about. So we don't do it in the immediate post therapy or post RT time. We generally give about 12 months to 18 months to stabilize. One area where probably we are not doing enough is probably fertility preservation. So where either the oocyte retrieval at a young age or sperm banking at a young age is not enough effectively done. So when we see patients come later on in their phase where we are not offering ability to offer therapy, it becomes very lesser and lesser. So I think those are three important points that I want to highlight. Thank you.
Thank you, Karnan. Sunil. Thank you, ma'am.
Thank you.
I'll now invite Dr. Sunil Bhatt to speak about the role of chemotherapy and stem cell transplant in medulloblastoma. So Sunil is our dynamic pediatric oncologist at the Narayana Hospital who's developing a lot of new things. And this stem cell transplant for associated with chemotherapy is something which he's been taking forward quite aggressively.
A very good morning, everyone. And first of all, I should thank and congratulate Professor Dr. Thimmappa Hegde, Komal, and rest of the team of Narayana Neurosurgery team to get us all together. I'm aware it's a predominantly neurosurgical audience. Yeah, I don't think, there will be too much of interest in chemotherapy, but I would probably, what we'll try to do is in the next 15-20 minutes is that I will just take through the journey of how chemotherapy has evolved in medulloblastoma, and also try to, highlight the role of what we call as high dose chemotherapy with stem cell rescues, and also touch upon the infant ALLs or infant medulloblastomas or the young medulloblastomas, and what are the nuances in the management of those patients, and also what is the current development in the field of management of medulloblastomas as far as the chemotherapy goes. So this is just a revision. I think we discussed it a little bit yesterday, and that is, the histological categories of medulloblastomas. We know there are 4 or 5 broad categories of neuroblastoma histopathology, and they had quite a significant role earlier on to determine what the prognosis of a particular patient is going to be. However, with the recent sub-classification of the molecular subgroup of medulloblastoma, we know that it's not one disease. It's basically a heterogeneous group of disorders, and we have the 4 subgroups: the WNT, the SSH, and the group 3 and group 4. And it's very important because as I'll show you later on, the treatment as well as the pathophysiology, the pathogenesis, as well as the outcomes of these will be so much dependent. This just to highlight in this picture here that how the 4 subgroups differ so much. The pie chart shows us the prevalence of these different subgroups in different population, but also shows us the survivals as well as in both in the localized and the metastatic settings in different subgroup of medulloblastoma patients. And this I think this is important because this as I'll show you later on is helping us to now devise treatments, some of which are targeted to optimize the outcomes, especially in the metastatic and the young patient group. So getting onto the staging and risk stratification, which is probably the core of how we manage these patients with medulloblastoma. Of course, MRIs are important, both pre-op and post-op MRI, and CSF analysis, which should be done either before surgery, ideally, and if it's done after surgery, we should have at least 2 weeks of time duration after the surgery resection has been done. And sometimes we also require bone marrow aspirations to see whether the tumor has spread into the bone marrow. This was the original Chang classification, which was predominantly based on the location of the tumor and as well as the measurements of the tumor, on the imaging. It was basically, T1 to T4, and as I said, was predominantly based on the tumor location, which has lost a little bit of significance in current treatment scenario. And however, the modified Chang staging, which is a little more relevant, is something which we follow nowadays. So which basically is whether the tumor is localized to the brain, its brain parenchyma, there is no spread. If there's a microscopic spread to CSF, it will be M1. If it's a gross spread, it will be M2. If there is, nodular seeding in the spinal subarachnoid space, it will be M3. And if there's extraneural metastasis, especially to the bone marrow or the bones, that would be what's called as the M4. And this is something which is more prevalent and more commonly used. And based on the staging, modified Chang staging, as well as some other risk factors, we classify medulloblastomas into risk, standard risk, which are the patients more than 3 years and also have a small residual tumor, which is less than 1.5 into 1.5 centimeters square. So very important, the quality of surgery is very important here, because that will determine our risk stratification post-surgery, post-surgery for further treatment. And if there's no leptomeningeal spread, that's M0 status, that will be classified as what we call a standard risk medulloblastoma. Important because they will have more than 80% event-free survival. The patients who are high risk, that is the patients who are less than 3 years of age, those who have residual tumor of more than 1 into 1 centimeters square. If they have metastatic disease, M1 to M4, they will be classified as high risk. And anyone who has got diffuse anaplasia on the histopathology also would be considered as high risk from the treatment point of view. Now, once we have staged these tumors and we have also risk stratified these tumors, we would want now to treat them, and the treatment would be, of course, surgery being the initial treatment modality offered for all of them. And what we attempt and aim for is gross total or subtotal resection, because that's I showed you the staging is very important to have a disease which is either completely cleared off or less than 1.5 centimeters square. Post that, there will be radiation offered, which is craniospinal irradiation, plus there is a posterior fossa boost, and then that's followed by chemotherapy, which we will discuss a little bit more detail. However, in children who are less than 3 to 5 years of age, of course, always less than 3, but some groups have taken up to 5 years of age as well. Those are the ones who will not receive radiation, and for the obvious reasons, and those are the ones who will have surgery followed by chemotherapy. Now, this is how the chemotherapy, chemotherapy wasn't used in the management of, medulloblastomas up till late 1960s, and this was basically, I would say, accidental discovery. There was group in North America, which we know Roger Packer and his contribution to the management of medulloblastomas and his contribution to develop the chemotherapy in medulloblastomas. What he discovered was that the high risk patients used to do pathetically. Even after surgery and radiation, they were not doing very well. So what he did is that in this subgroup of patients, that is the high risk patients, those who have residual disease or those who are metastatic, he, after radiation, added some chemotherapy, which was basically cisplatin, lomustine, and vincristine. And what he observed was a very, very interesting phenomena. He observed that these patients had a progression-free survival of 85%. And that was even better than the standard risk patients treated by the same group during the same time. That was 52%. So, a contradictory observation, high risk patients doing better just with the introduction of chemotherapy than the patients who were standard risk and should have otherwise done better, of course. But with the introduction of chemotherapy, he saw some 30% survival advantage in the patients with high risk medulloblastoma. So that kind of paved the way of introduction of chemotherapy in medulloblastoma patients. And this was again from the same group. The next phase of their analysis was to add chemotherapy to even the standard risk patients. After getting surgery and radiation, they added chemotherapy to the standard risk patients as well. And to the surprise, what happened is that the cure rates went up to about 80 to 90%. And when they compared this with, I'm sorry, the pointer doesn't work, but when they compared this with the historical cohort, which is the graph which is shown below, that's a historical cohort which was treated at the same center before introduction of chemotherapy in the standard risk group, and they could see there was almost 50 to 60% survival advantage and improvement in the outcomes in the patients for the standard risk group as well. So hence, for both for standard risk as well as for high risk medulloblastoma patients, chemotherapy became standard of care post radiation. At the same time, CCG, which is currently the children oncology group in US, they also studied whether with this introduction of this chemotherapy, whether survival advantage has been achieved and the outcomes are improved so much, can we reduce the dose of radiation at least in the standard risk patients? And that's what exactly they did in the study, where they used chemotherapy after giving them lesser dose of radiation, which used to be 36 grays. They reduced the craniospinal radiation to 23.4 grays and added chemotherapy post that in the average risk disease. And to their surprise, the survival advantage, the survival benefit was maintained, and they could still get around 80% event-free survival even after reduction of radiation in the standard risk group. So that was another, kind of progress in the field, where with some success you could reduce the dose of craniospinal radiation from 36 to 23.4. Now the second question, which was asked around the same time, was whether we should give this chemotherapy before radiation or after radiation. This is because from the concept of treating many other malignancies which we do in pediatric practice, and that is use of radiation is mostly given after neoadjuvant chemotherapy in most of the other pediatric solid tumors. So in that context, it was tried to explore whether using a sandwich chemotherapy protocol, that means after surgery, give chemotherapy and then radiation after that, whether that is something which can improve the outcomes or will have some impact in the tumor control. So this was exactly studied in Germany, and these are the famous HIT trials which were done in Germany. What they did is that they had randomization of the patient into two groups. One group got radiation followed by the standard chemotherapy, which we discussed the previous slides, and the second group, they received chemotherapy which was given before the radiation, and what they showed, which was surprising, that the patients who got sandwich chemotherapy, the EFS was 60%. So that means introduction of chemotherapy prior to radiation, outcomes are inferior to the group of patients whose chemotherapy was given after the radiation, which was 87%. The difference was more than 25%. So that hence kind of rested this debate forever, that there's probably no role of giving chemotherapy prior to radiation in medulloblastomas. It should be always given after the radiation is over. The other question which was tried to be asked that time was the lomustine, cisplatin, and vincristine. These were the three standard doses, three standard chemotherapies which were initially experimented, and they continue to be given for the next almost 2 decades. So there was a question whether the use of a different chemotherapy protocol, cisplatin, vincristine, and cyclophosphamide instead of lomustine, does it give a better tumor control or a better survival advantage over the standard chemotherapy arm? And this was again studied by the group from Roger Packer. And what they showed is that the EFS as well as OS wasn't different in the two groups, and the lomustine arm still was probably the standard of care. And of course, I don't want to get details of that, but the cyclophosphamide arm had a little bit more side effects, especially in the context of neutropenias and infections. So hence, the lomustine, vincristine, and cisplatin arm remain the standard of care, of course, even today. Now, switching gears, and there was another concept which was experimental and trialed in from the St. Jude's Neuro-Oncology group, and this was basically pioneered by Amar Gajar, who basically tried to look at these medulloblastoma patients and see whether we can use high dose of chemotherapy with stem cell rescue. This was basically a risk-adapted approach. What they did is that for the patients who are standard risk, they will have surgery. Post-surgery, they will have stem cell collection. After that, they have radiation, and after radiation, they will have 4 doses of high risk chemotherapy or high dose chemotherapy followed by autologous stem cell rescue. This was one group of patients. And these group of patients were the standard risk group of patients. They tried to give lesser radiation, it was 23.4 CSI. Then this high risk group of patients, they were the patients who received after surgery, stem cell collection, radiation, which was 36 grays to the CSI, and of course, post-exposure boost, and plus that after that 4 cycles of high dose chemotherapy stem cell rescue. This was done 6 weeks after the finishing radiations. After 6 weeks of completion of radiation, they used to get these 4 cycles of high risk or high dose chemotherapy stem cell rescue. This is the protocol it looks like. So you basically start from day -4 and give cisplatin and cyclophosphamide at pretty good doses, which is pretty myeloablative, and give them this infused cells, which were the stem cells which have been collected and stored on day 0, and then give GCSF on day +1, and then wait. There's one more dose of vincristine at day +6, and then you wait for them to recover, and then repeat this cycle every 28 days, and that means in 4 months you're done with the treatment. So what they showed in this St. Jude's protocol, which was used, that in high-risk patients they could achieve a cure rate of about 70%. And in the average risk group, it was about 80–85%. So this was, proof of the principle that with this high dose chemotherapy and stem cell rescue, you can cure a good proportion of patients, both in the high risk as well as average risk category. How this difference, when we'll discuss this later on, when we look at the different histological categories in this St. Jude's cohort, classics did the better than, and decimal artists is better than the large anaplastic, which is kind of expected. And the ones who had Wnt pathway, almost everyone was surviving, 100% survival in the Wnt pathway, and others, of course, had around 70% survival. This was a little earlier kind of experience in St. Jude's Meadow-Blast protocol. At that point of time, molecular subgroups was not very prevalent in clinical practice, but this is their analysis of some of these patients in retrospect, and they showed that how the histology and the molecular subtyping can make an impact in the outcomes. Now, what is it now? How do we compare these two? The standard risk chemotherapy, which is 8 cycles of Packer's protocol every 6 weeks, and it goes for almost 14 to 15 months. That is after you have done surgery, radiation, and a gap of 6 weeks, and you start chemotherapy. That chemotherapy goes for 14 to 16 months. The whole treatment, of course, of neuroblastoma in a standard kind of format would be approximately 18 to 20 months, which is a pretty long time. If we use the cycle of the high dose chemotherapy plus the stem cell rescues, it's over in 4 weeks' time. So we are looking at the treatment 16 weeks versus 48 weeks, which is pretty, I would say, something to think upon, and that is kind of true for both average risk as well as high risk patients. Now, do we also have lesser side effects with the shorter 4 cycles of chemotherapy, which are high dose, but only 4 cycles? Probably yes. We don't have enough data yet to support that, but I personally feel probably yes, because we're reducing vincristine dose from 32 to only 8 doses. We are giving cisplatin, which is 50% of the dose was expected to be given. So probably less ototoxicity and other side effects of cisplatin, and at the same time, less doses of vincristine, and at the same time, radiation doses remain the same in the 2 groups. So some interesting idea, I would say, is to consider high dose chemotherapy as one of the options for medulloblastomas. Now, is it possible in Indian settings? Because some of the things which we always argue is that can we administer it in our setting? We did a small, case series compilation of it's been a couple of years ago. This was done. I think we have added some more cases. This was about 13 odd patients which we had on high risk medulloblastomas. So median age of around 72 months, 8 males and 5 females, and most of these patients had gross total and near total resection. Only one patient had a subtotal resection, but most of the patients almost had a gross total near total resection. This is, after the surgery, they were referred to us. We did the stem cell collection, referred back to radiation where the radiation was given, and after the radiation was over 6 weeks after that, we gave them high doses of chemotherapy with the stem cell boost, which was collected before the start of radiation, and at day +1, we give them 1 dose of GCS and discharge them. So it's a 4 to 5 days of hospitalization, and as I said, all these patients, 13 of these patients were high-risk medulloblastomas. 10 patients were basically high risk in upfront high risk, either because of the residual disease or metastatic disease, and the 3 patients were recurrent medulloblastomas or with a relapse, either in the tumor bed or one patient had a spinal metastasis as well, where radiation was not an option. So these patients received these 4 tandem transplants, 13 of them with a cell dose, what we call a stem cell dose of 3 million. And we saw that all of these patients, they had a very brisk neutrophil engraftment. Around day 10, they recover their blood counts and are ready for the next cycle in the next 4 weeks. Most of the common side effects, as we expect with chemotherapy in these group of patients, was vomiting and nausea, and some developed mucositis, and there were some episodes of fever and neutropenia, which was managed, but there has been no transplant-related mortality. So there's no one who has died because of the treatment with this high dose of chemotherapy. So just to highlight here, that's pretty safe and as easy to handle as any other chemotherapy which we do in pediatric oncology. This is the event-free survival of this group of patients, 13 patients. As I said earlier, this is a very, very high-risk group of patients. And if we see 72% event-free survival at 2 years of median follow-up, overall survival of 83% and at 2 years, which is pretty decent and at comparable with what I showed you from the Western data. So that was our older patients, how the treatment evolved and how we manage them. Now, what about patients who are younger? Younger, as I said, young definition is different from different groups. Some patients take it, some groups 3 years, some 5 years, but I think the concept is the same, that we want to avoid radiation to this younger population because of the reasons which has been highlighted in the previous talk, whether there are neuroendocrine, leukoencephalopathy, learning and attention abnormalities, also all of that, what we have discussed in the previous talk applies in the patients who are young. So less than 3, of course, always, but Canadians are a little more conservative and they usually take patients less than 5 years as infants and young children. Now, if you see this again, the molecular subgrouping here, infants. I use the word infants for these patients less than 3 to 5. So these patients, younger children, they will have a different subgroup classification. Most of them fall in SSH and the group 3 category, and that is something which is unique. And if I show you the next slide here, when you look at the subgroup distribution, almost none of the patients who are young, less than 3, are in Wnt pathway, and that could explain why the outcomes in Wnt pathway is so good. I showed you 100% from St. Jude's medulloblastoma protocol. Infants, most of them belong to SSH and group 3, and that's why probably one of the reasons that the outcomes are not that optimum. This is the outcomes for the patients who are less than 4 years of age. If you see the outcomes here, group 3 pathetic, around 35, at the most, followed by group 4 and SSH, of course, being the better, but not as good as probably the older children. And when you look at the histology, again, their outcomes are suboptimal as compared to older patients who are more than 4 years of age. Now, how do we treat them? I know one of the important things which we have learned that we don't want to give them radiation because of the obvious reasons. And when we cut down the radiation for medulloblastoma patients, we have removed one of the most important effective treatment modalities from their management. So how do we deal with them? So there were a couple of, a lot of strategies, but the ones which have been tried, tested, and been probably shown to be the most successful have come from the Head Start protocols 1 and 2. What they did is that once the patients, these younger patients less than 3 to 5 years of age, when they had surgery, after surgery, these patients were given chemotherapy cycles, 5 chemotherapy cycles based on cyclophosphamide, etoposide, cisplatin, vincristine. That was hit on Head Start 1. In Head Start 2, they added high-dose methotrexate also, especially if you have a disseminated medulloblastoma. That is a high-risk patient, they added methotrexate as well. They give 5 of these cycles. After 5 cycles, it's very important if you can do a relook surgery, because if you have not been able to achieve a gross total or a near total resection at the time of diagnosis, it's better that go in again and see if we can have another excision done at this point of time. And once that is done, then these patients would get one autologous transplant. The same thing which I showed in the previous slides, but a little bit different conditioning, little different medications used here. It is based on thiotepa, carboplatin, etoposide. And once that is done, you give them autologous cells after this chemotherapy has been done. And that is how the treatment kind of, protocol was evolved with this Head Start 1 and Head Start 2. And with this, strategy, they could, I just wanted to focus on the right table here and the lower part of it. If it's less than 2 years of age, around 60% EFS, 80% overall survival. In 2 to 3 years of age, 67% EFS, 83% overall survival. So these are probably one of the excellent outcomes you can imagine in an infant, in a young child, where radiation has been omitted. But how was it possible? It was possible by giving them 5 good decent doses of chemotherapy, relux surgery, and then follow that up with one autologous transplant with stem cell rescue. These are the graphs for the same cohort of patients. And the left one is basically for the overall and the event-free survival, and then the radiation-free survival also about 50%. So I know 50% of the patients, they didn't get radiation. So 50% of the patients had radiation-free survival. And what was the most promising outcome out of this Head Start 1 and 2 was that the patients, these young patients less than 3 years of age, when they followed up, they had both quality of life as well as social, emotional, and behavioral functioning was within normal limits as compared to the healthy peers. So this was one of the achievements of this study, because no radiation was done and they could develop and grow in a normal fashion as compared to the peers. So that was that led to the way of how to manage the patients with medulloblastoma who are younger. There are various other protocols. I don't want to get the details of that, but I think there are a few others which have been tried and experimented. But Head Start remains the gold standard of how we manage patients with age less than 3 to 5 years. Now, Head Start did another study, which was Head Start 3, and what they did in this was that they changed a little bit the chemotherapy protocols. They used 3 cycles of the previous chemotherapy, which I showed in the previous slide. I think I'll go through this one. They used the 3 cycles, 1, 3, and 5 of the previous chemotherapy cycles, but they added in cycle 2 and 4 a couple of new drugs, which was temozolomide, oral temozolomide to their chemotherapy backbone, again followed by second look surgery, and after that, one autologous transplant. What they also added here, which was a little bit different from the previous Head Start, and that is to add radiation at end of autologous transplant plus minus. That means if you have a residual tumor and you can probably give them a focal radiation to that area, which was not done in the previous Head Start 1 and 2. And the concept here is this, that, once you start a treatment, from treatment to the end of 5 cycles of chemotherapy and autologous transplant, you will have almost 6 to 7 months. And some of the children may have at least gone beyond the age of 2 and 3. And if there's a residual tumor, just with focalized or local radiation, you can probably consolidate their outcomes, and that's what exactly they showed in their cohort. They showed that EFS and OS was in the range of 89-93%. So this is one of the best outcomes which has been ever published for infant or medulloblastoma in younger children. And they also showed that the outcomes were, of course, better if it was localized, and metastatic also they could achieve at least outcome of about 80-85%. And this is basically high risk, young children being treated. So this was one of the best outcomes, as I said, and they could avoid radiation in most of the patients, especially upfront, and have excellent outcomes. Now, what is current, what is new, and what we're heading towards? This was all history and what we have achieved till now. I showed some of the data earlier on. If you look at the Wnt pathway, somehow the pediatric patients who have Wnt pathway subgrouping, they do excellent, almost 100% survival. Adults do not do as well for whatever reasons. If we look at the SSH pathway, of course, metastatic ones do pathetically bad. Even the localized ones are somewhere in the range of 70 to 80%. If we look at the group 3, again, the differences there between metastatic and the localized. And the group 4, you can see 3 different graphs. one for child, that is, younger children, infants less than 3 do pathetically bad, and adults. So kind of, if you look at this now 4 subgroups, there are in the subgroups themselves, there are now further subgroups. And, this is the current understanding of molecular subgroups of medulloblastoma. It's not enough nowadays to know what molecular subgroup you have. I think you have to go beyond that. And WNT, for example, because adults and children do so differently, so adults are to be treated separately and children to be treated separately. If you look at the SHH pathway, if you have got a P53 mutation or if you've got an NMIC amplification, it determines your outcome and risk stratify them based on that. If you've got in group 3 NMIC amplification, you risk stratify them accordingly. And in group 4, chromosome 10 and chromosome 17 gain, these will determine what risk stratification you belong to. So it's become even more complex now, more refined, I would say, but more complex. And based on this information, based on subgroup classification, based on the outcomes in subgroup classification in different subgroups, this is what St. Joe's is doing now. Very, very, very complex, very, very elaborate way of looking at it. So they have every disease submolecular subgroup has been subdivided into few categories, and they treat them into different treatment protocols, which is called a stratum, approach. And they have got few stratum approach in these various subgroups. Some of the subgroups are also studying the role of targeted therapies like sonic hedgehog, inhibitors in the SHH subgroup. So this is, I think, this is something which is the current where the field is, and I think will be, we should wait for another couple of years to have some results out from this very interesting study, and that will help us even further to refine the treatments in medulloblastoma. So to conclude, older children, those who have low-risk medulloblastomas, will have probably similar outcomes, whether you use standard chemotherapy or high-dose chemotherapy. Probably there's not much difference. But in high-risk medulloblastomas, we see some survival advantage with high-dose chemotherapy. Infants and young children, those who are less than 3 to 5 years of age, of course, we have to avoid radiation in them, and outcomes seem to be better with the high-dose chemotherapy. All the protocols, Head Start 1 to 3, have demonstrated that high-dose chemotherapy with stem cell rescue is probably the way to go with them. We can avoid radiation in this group of patients in more than 50% of the patients, and they will, of course, will have better neurocognitive outcomes. So with high-dose chemotherapy, as I showed you, treatment is probably shorter. We have got lesser exposure to cisplatin. Cost is a concern, but I think that can be offset to a certain extent by the shorter duration of the treatment, and it can be delivered in the normal ward settings, what we have demonstrated in our setting as well, and does come with acceptable toxicity with no mortality whatsoever because of the chemotherapy they have got. So thank you very much for your attention, and I can take any questions if you have. Thank you.
Thank you, Sunil, for that wonderful overview of chemotherapy in medulloblastoma patients. Any questions from the audience? Professor Nair.
Yes, sir.
Long back, while I was training, long back, the people they used to take a small biopsy from a kid who has posterior fossa tumor, and the diagnosis is medulloblastoma. They used to send for chemo only, and just chemo, no radiation, and they used to string like that. And then my question to you these days, we can diagnose medulloblastoma with good imaging. Like it is one of the very few tumors which is hyperdense on CT scan. Hyperdense lesion, posterior fossa tumor, it is medulloblastoma for a kid. Like that, T2 will show hypointensity, diffusion restriction. You can, without doing biopsy itself, you can tell it is a medullo. So such a kid less than 3 years, can we just give chemo?
So no, sir. You can't cure any medulloblastoma with chemo only. It's an adjuvant treatment, and surgery. I don't have the time. I didn't show that much, but there are a number of papers which have showed that gross total, near total resection, how important that is for outcomes in medulloblastomas. Even if you have a residue of 1.5 centimeters square and plus, that adversely affects the outcomes. That has been challenged a little bit now with the better molecular subgroups like WNT pathways, and if you have got a desmoid histopathology, then you may argue that you may not need a very aggressive surgery to have less than 1.5 centimeters square or a near total resection, but that is still under I would say in the gray area at the moment. But you cannot to answer your question, you cannot cure any medulloblastomas with chemotherapy. Of course, you'll see some reduction, you will see some reduction in the size of the disease of the tumor, but it's not enough to cure. Now, there's an interesting concept which comes from your question, and that is that can we do neoadjuvant chemotherapy to these patients, especially the patients who are inoperable, or who, we know that we won't get a good near total or gross resection, whether we can use a neoadjuvant setting and then operate after that. I think the answer to that question probably difficult to give, because it needs a very brave, heart to conceive such kind of a surgery when you're achieving 80-90% cure rates to attempt that. So, but that palliation, of course, we can do, but not from the curative point of view. So that would be an interesting question to do, but honest, from a standard care point of view, surgery is still the backbone, followed by radiation and chemotherapy adjuvant treatment to these two treatments.
Why P53 mutation has no relevance for Wind pathway, while it is significantly, it has.
So P53 hasn't been seen in Wind at all, sir. Hardly in some patients will have Wind53 mutation. It's like, which molecular pathway is stronger than others. We see it very, very commonly in liquid malignancies like leukemias, where you have multiple mutations, but the mutation, which is a stronger mutation, takes over. So I think a similar concept probably applies here as well. It's not very clear, but we know that the ones who are in SHH, for example, and have P53, they do poorly. And
just a comment on this neoadjuvant chemotherapy. This has been the very interesting concept from the day one, because in pediatric solid tumors, we are all used to NSCT, neoadjuvant chemotherapy, followed by loco-regional. But neurosurgeons, and we also know now clinically that in posterior fossa, we do get surprises. And the other extreme is meningiomas or ependymomas, which are very chemo-resistant. So it is good to have the upfront surgery for a definitive diagnosis, for molecular classification, which is so very important now in medulloblastoma, to give a very specific therapy. Only one addition to the high risk medulloblastomas in older children. You have shown beautifully the high dose chemotherapy concept with autologous transplant, but there is also a very big attempt in our settings where we cannot do such 4 tandem transplants because of the cost consideration. We have done that trial at Tata also, giving concurrent chemo and radiation. Followed by standard chemotherapy for 6 cycles, and that has given a good result. So that is also another doable approach in our setting.
Sir, hello, sir. Yeah, so first question I want to ask is are we doing this molecular studies for all patients? And second is whether, if at all we find that they are SSH or non-SSH, non-Wnt pathway, should we consider high dose chemotherapy in those patients?
So to answer the first question, yes, we do molecular subgroup for all the patients. However, the second strata, which I showed you, for example, you got SSH. Now, will you be able to do P53 in all of them? That's something which we are still not able to do for most of the patients, which is the second layer of sub classification, I would say. The second question is that patients who are not doing well, the SSH subgroup of SSH patients who have P53, group 3 patients who are not doing well, can we do high dose chemotherapy? Will that have an advantage over standard risk chemotherapy? I think we don't have the answer to that question based on the data. What I showed you from the experience from St. Joe's or from our own experience from our center, our high-risk patients, metastatic patients, and the ones who had recurrence did better, as compared to probably to the standard risk chemotherapy. But I don't think on the subgroup or the molecular classification on that level, we have data to suggest either of the two.
And second thing is more of a message, because there's a lot of neurosurgeons here, is the timing of starting treatment post surgery. I think you should mention that.
That's very important. I think I should have touched based on that. Of course, neurosurgeons majority being here. So I think one of the important message I want to convey is that as soon as done with surgery, please refer them for the further treatment to the radiation and the oncologist. for various reasons. One is that CSF sometimes are missed, and that's very important in our classification and management. That is one. And second is that if we want to take them for example, for this high-dose chemotherapy, so we need to collect the stem cells before the radiation is given. Once the radiation is given, because it irradiates the craniospinal, and our stem cell collections after that is very, very difficult to get. So we want to do the stem cell collections beforehand, which takes around 5 to 6 days of the process. And then ideally, not ideally, I think this is a crime to get radiation delayed more than 28 to 30 days after surgery has been done, unless and until, there is a medical reason for that. So I think all of this takes time. So it's the best is that once you're done, immediate post-op care is being provided. It's better to, get them.
That brings us to the foyer or in the center, the need for joint neuro-oncological meetings, where a neurosurgeon, a pediatric oncologist, or a medical oncologist and radiation oncologist decide the next line of management. And that is very, very important to have this JNMOs. And also neuro-rehabilitation, which I had stressed before, it can start in the immediate post-op period itself. Like one of the complications of a surgery in posterior fossa is posterior fossa syndrome, which requires a very vigorous neuro-rehabilitation, and that should not delay the oncological management. So they should go parallel. And all this can come up, this complicated management can come up very well if we have a joint discussions, getting everybody on board.
Sir, since you mentioned CSF, I think we should also stress the point that CSF intraoperatively collected is not admissible. You have to collect it post-surgery before the treatment.
Either pre-surgery at the time of imaging or at least 2 weeks post-surgery. So those are the 2 time points where the CSF has to be done.
Thank you.
No, sir, it won't pick your M1s. M1 is microscopic disease and won't be picked on MR. Thank you.
Thank you, Dr. Sunil, for that wonderful this deliberation on the journey of medulloblastoma treatment. And now we have with us Dr. Shibu Pillai, who is a neurosurgeon from MSMC in Narayana Health. And he is going to tell us about management of posterior fossa ependymoma in children. Dr. Shibu.
Morning, everybody. Thank you for that introduction. I'll be addressing this mainly to the residents. So everybody sitting at the back, wake up. So it's a simple talk. How do we manage ependymomas in children, posterior fossa ependymomas? So yesterday, Dr. Vani highlighted the different types of ependymomas in the new WHO classification. And this cartoon here shows the types which are in the posterior fossa. Doesn't work, right? Okay, so here you can see there are 4 types highlighted, but amongst them, only 2 of them are actually important in children. Yeah, okay, this works. So these 3 are what we're going to address because the subependymomas are predominantly in adults. So between these 2, the main thing which differentiates is the H3PK27 ME mutation. So if there is a loss of that in the tumor nuclei, then it becomes posterior fossa A. If it is present, then it's posterior fossa B. And of course, they also do a correlation with the methylation profile to identify the posterior fossa B. But basically, this is what it is. The studies have shown that the outcome in posterior fossa ependymoma A is very bad, whereas it's much better in posterior fossa B. So apart from the molecular typing, what are the factors which influence outcome? Central to all this is what you have done, surgical resection. How good a resection, how complete a resection has been done, that is key to outcome. Apart from that, whether metastasis is present or absent. So drop metastasis, spinal metastasis, that's very important. And the third thing which will influence your management is the age of presentation. So less than 18 or less than 12 will change the kind of approach you have. 18 months will change the approach you're going to take. So now I'll discuss a few cases to highlight how you're going to manage different situations. So here you've got a 4-year-old child who's come to us in 2016 with symptoms of headache and vomiting. This was the MRI picture. We did a suboccipital craniotomy and excision of the tumor. At that time, we got a report as anaplastic ependymoma. Today, they'll probably call it a posterior fossa ependymoma, NOS grade 3. So for grade 3 tumors, what do you do after that? First, of course, we have to do the MRI. Post-op MRI showed there was no residual. MRI of the spine showed no deposits. LP-CSF, as Dr. Sunil was highlighting, showed that was clear, so no mets. The child had a poor gag reflex and started on RT feeds. So at this point, how do we go about it? Some of the questions that come up is, do we need adjuvant treatment or have we successfully cured the child with surgery? If adjuvant treatment, what should we give RT? What is the dose of RT? What is the margin of RT? And does the grade influence your treatment? Being grade 3, does it make a difference? Or if it was grade 2, would it have been different? So the current consensus is that you need to give radiation therapy. So the dose varies slightly, 54 to 59.4 gray is the standard of care. The margins of about 1 centimeter is enough. You don't need to go beyond that. And the type of treatment does not depend on the grade. So whether it's grade 2 or grade 3, you give the same treatment. So what we did was focal IMRT in 2016. Now in 22, he's asymptomatic, no neurodeficits, studying in the 6th grade, and MRI is going well. So once surgery and treatment is done, how do you follow up these kids? How is it only clinical? Do they just need to come to the OPD? Do you need to do regular MRIs? And if you're doing MRIs, how frequently and for how long? So those are questions which have been addressed. And this study found that when tumors recur, if the patient is symptomatic versus if the recurrence has been picked up on a surveillance MRI, the ones who do worse are the ones who are symptomatic. So you need to do regular surveillance MRIs and not wait for doing the MRI till the child becomes symptomatic. That's the important lesson. Second thing is for how long. So if you look at this, there's drop in survival even beyond 5 years, 5, 10 years. So this continues to drop. So you can't stop the surveillance MRIs. You need to continue evaluating them. So currently the preferred approach is during the first 2 to 3 years, you need to follow them up with serial MRIs every 3 to 4 months. After that, every 6 months till about 5 years of age, and then annually is adequate. So summarizing what we have discussed about this, most important is first step, operate, get a complete excision if you can, do that safely. After surgery, you need to do an MRI, document the status of excision. If it is incomplete and you can repeat surgery, then you should do that to try and complete the excision. Subsequently, spinal MRI, spinal CSF at about 2 to 3 weeks, and after that, radiation therapy. So that's standard of care at present. And as I said, follow-up has to be done in all children on a regular basis. Now, this is the next child, 4-year-old girl who came to us with headache, vomiting, and ataxia with neck tilt. This was a tumor. Again, same kind of approach, suboccipital craniotomy and near total resection. So in this child, along the medulla, it was too adherent and we couldn't get a complete resection. So post-op MRI showed a small residue along the medulla. The spine and the CSF were clear. The child was in a tracheostomy and had a PEG because of swallowing difficulties, obviously related to the medullary handling probably. And this was a small residue which was seen. So at this point, what do we do about this? Should we go in and try and excise even that. So general consensus is if during your first surgery you felt it's difficult to take out and there are limitations to further surgery, then better not to try to do that, even if it's going to improve outcome, because you might worsen the function. So that's what we did. We directly proceeded with the adjuvant RT, and that small residual disease continued to be there, although there was no diffusion restriction in the subsequent scans. And at 6-year follow-up, she has no deficits and she's doing well. We'll have to, of course, continue following her up regularly, and you can't stop doing that. The next situation is a recurrent ependymoma. So this child is now 5 years old. Initial diagnosis was post fossa anaplastic ependymoma. From the age of 2 years, the child has already undergone 3 surgeries and completed RT previously. And now this is a situation. So you have a residual tumor near the brainstem and along the brainstem. So what can we do? One of the options is chemotherapy. What about radiosurgery? And what about radiotherapy? Can we operate again? That again may be difficult. So one of the trials which is looking not at recurrent tumors, but primary tumors itself, is whether we can give chemotherapy at the point of subtotal resection to see what is the response to chemotherapy. So 2 cycles of chemotherapy to see if the tumor shrinks and becomes more resectable, so that you can have a second look surgery. And if resectable at that point, then that's much better. If it's unresectable, then of course you go ahead with radiotherapy. The other aspect is what kind of radiation should we deliver at this point? And what's been seen is that when there is a recurrence, if you give craniospinal irradiation as part of the repeat radiation, there's a much better outcome. Both progression-free survival as well as overall survival improve if you give craniospinal irradiation at the time of re-irradiation. What else can we do? So this trial, which again is for primary tumors, was looking at the role of maintenance chemotherapy. And some of the early results from that trial now seem to suggest that maintenance chemotherapy also improves outcomes. So perhaps that's also something we can use in these kind of recurrent tumors. Of course, the final analysis and details are still awaited, and what its role in recurrent tumors will be, we still have to study. The other thing is stereotactic radiosurgery or maybe proton therapy. These are things which are being evaluated. They seem to be showing good results, but as of now, they've not been formally evaluated in a proper trial setting. But they probably have some role, especially in focal treatments. But then what do you do about craniospinal irradiation? Do you add it to this? Those things have to still be evaluated. Because in this study, for example, with gamma knife, although overall progression-free survival improved, 22 of these 87 patients had additional recurrent ependymomas in the craniospinal axis. So it raises the question whether focal treatment alone is enough or not. In today's age, where we have immunohistochemistry, which we can differentiate ependymoma A from B, and we know that A has a worse prognosis and B has a good prognosis, can we think about escalating treatment for the type A and de-escalating for the type B? So could we consider avoiding radiation therapy for the Bs? That's something, again, which we may have to study, or perhaps the results, genetic studies from the ongoing trials will give us some idea about that. So on the whole, to summarize, gross total excision is the absolute crux of management. WHO grade 2 and 3 needs similar management. Age, if it's less than about 18 months, you may have to change the approach slightly. Maybe only chemotherapy initially and subsequently give radiation therapy. If there's subtotal resection, we have to consider the option of redo surgery or perhaps give some chemotherapy and then redo surgery. These are things which are still being evaluated. At all times, Make sure excision is a safe surgical excision. Don't be over aggressive, although maximizing surgery. Surveillance, MRIs are essential and should be continued throughout the child's life. CSI is useful, craniospinal irradiation is useful during recurrences and should be given. For late recurrences, we still have to evolve appropriate strategies, and strategies based on the molecular subtyping, perhaps targeted therapy. These are evolving things. Thank you. Any questions?
Yeah, can I ask? Very good
Sure,
question. But can you just highlight, one thing probably you missed is, the type FNA, they are more in the research, lateral research. Type B, they are more in the middle. And then what the question I want to ask is, suppose, there is no 1P gain or 6Q loss, or there is no M3 gain to 57 mutation. And that you told we can be de-escalate.
Correct.
But what the madam told that they don't respond to radiation. I think she made a comment. So why burn all this then?
So,
Radiation.
yeah.
They don't respond very well.
That was for chemotherapy, sir, chemotherapy.
No, radiations are quite.
Okay. Anything else, residents?
But what's the chemotherapy we give for FNA? You like Medilo, what is that? Do you have any recipe?
So it's, pediatric chemotherapy regimens are based on 4 or 5 drugs, and we shuffle and reshuffle them and put them in different packages. On a serious note, it is usually etoposide cyclophosphamide based for ependymomas. And we have in fact a couple of patients now who are getting this maintenance, what was suggested here. They had received radiation and treatment elsewhere, and now we are planning them, we're following them under maintenance. So we'll see, as Dr. Pillai suggested, that the results are not out yet of these couple of trials which are trying it as a maintenance, and also for subtotal resections to debulk them further, so that you can either do a relook surgery later on, or you buy some time, especially the kids who are less than 1 year of age. You buy some time, and then when they crossed 1 year, then you give focal, IMRT to the tumor bed. So both these concepts are being studied, but I think it's too early for us to make any comments on that.
I am just interested because spinal ependymoma. Do you, because we take it out in daughter, in terms of the tumor, we can pluck out that. Should we again give them radiation, or can we hold on?
So I feel, this is my personal this thing, but I think ma'am and Dr. Shibu can probably expand. Ependymoma surgery is the most critical thing. Okay, and yeah, so surgery is the most important thing in ependymomas. Complete resection is the mantra, and of course radiation is also very effective and is the standard of care. These are the 2 standard of care treatments. But in spinal cord, I'm not very sure, depending on where the location is, if you have done a complete resection, if there's a impending, I would say, a risk of nerve injury, then probably you may not. Otherwise, I think that would also be a standard of care. You want to say something, Saurabh, on that spinal ependymoma radiation?
That kind of a dose in the spinal cord, because spinal cord as such is only what we can maximum hit a dose of 45 gray around the cord.
I never used to take it out. It's like a redo surgery. I never used to spinal.
Is there a data sort of on ependymoma spinal which is only operated, not radiated? Is there any data on that? I'm not very aware of that upfront, but I think that's something may have to look at.
I'll also have to look into it.
And basically today you will be guided mainly by the type, molecular typing that we do, whether we should go ahead even despite complete excision. So that will be very helpful factor now to decide whether in an objective way, whether you need a radiation or no. And most of them would land up with a radiation, and whatever is maximum tolerated dose, which Dr. Saurav said for 45 gray, we can consider giving that, because recurrence in any solid tumor is always a very difficult game to manage. So. No, me can, some indicators may be there which may justify, otherwise you can.
The other interesting thing in the new classification is they have made the myxopapillary ependymomas as grade 2 because they have seen recurrences. Okay, we'll move on to the next.
Thank you to all the three speakers for a wonderful session. We would like to take this opportunity to felicitate Dr. Purna Kurkure, who's the president of ISNO, chairman of Clinical Collegium for Oncology Services in Narayana. I invite Dr. Timmappa Hegde, director of Neurosciences, NH, Dr. Uthappa, group chief medical director, NH, and Dr. Shobha B, senior consultant, pediatric hemato-oncology and bone marrow transplantation, to please join the honorable chairpersons in felicitating ma'am.
Thank you so much. It's my NH family only which is felicitating me. It's a good gesture, and I'm really thankful to all of them.
Sunil Bhatt. Huh? Got it.
I now invite the chairpersons for the next session, Dr. Sailesh A.V. Rao and Dr. Krishan Yadav, to please take their places on the stage. Next.
We continue with the next session. The next session, the first talk is by Dr. Parthiban. Spinal tumors, we all love to do them, but they have their own problems. Dr. Parthiban, with his own experience and others, he will now guide us and tell us and throw some light on various adjuncts and tips for surgery of the spinal IDMs and intramedullary tumors. Dr. Parthiban, please.
Thank you, Chairpersons, and my friends. Thank you for inviting. It's more of a surgical technique subject which I have chosen, and it's very interesting to operate on spinal cord and spine, tumors in the spine. Basically, it is very interesting. One basic thing is that spinal cord is, by consistency, it is harder than the brain. So that gives a liberty. So it is very difficult to produce a neurological deficit in spinal cord surgery. Thank you for your kind invitation. As you all know that, majority of this extradural and also the classical intramedullary tumors, the intramedullary tumors is just a very, very low 5%, and extramedullary, that is intradural, is 40%. So those are the sectors which the neurosurgeons come across quite often. The most important is about the technique, that we all know that majority of this is done by the basic laminectomy. We all know this for years together. Laminectomy has been done to remove most of the spinal cord and also the IDEM cases. Anything can be done through laminectomy. But then over a period of time, there is a shift in laminectomy because it is too large, too much of muscles are being exposed. And so the neurosurgeons start understanding about the biomechanics and started reducing the dissections less and less. So that's more important. But when we start reducing our exposure, in fact, that we try to do like something like a pituitary surgery, as Kiran was showing it, and endoscopic surgeries. So majority of the thing can be done through microsurgery, and but only thing is the conventional laminectomy is now replaced with hemilaminotomies. In fact, that hemilaminotomy was first introduced by Yasser-Gill in 1991. We had a personal communication with him about this, and he used to offer the so-called the over-the-top surgery decompression, which is now the present generation spine surgeons are talking about through a tubular retractors to do a decompression from one side and to the other side through a laminotomy, smaller over the top. These are the new names are being coined, but this was already done by surgeons like Yasser-Gill in 1990s and before that itself. And there are some papers also on that. So heavy laminotomy has become more something like a minimal access techniques. And this can be done with a microsurgical technique with a conventional hook retractors, or you can use a tubular retractor if you have very much used tubular retractors. But the idea is that to go through a small laminotomy and do the tumor excisions. So here is a case where you find a reasonably large size anterolateral foramen magnum tumor, and also it's very close to C1. It's a meningioma, obviously, but what it's nicely seeing is that you can see a beautiful angle where you can reach this tumor very nicely. So you don't need a laminectomy, huge laminectomy. You can do a hemilaminotomy. Just do a hemilaminotomy, and then you can excise the tumor completely. Now you can watch it. This surgical exposures will tell you the complete technique. A small dural opening in the upper cervical at C1, and C2 is not even involved. It's just one C1 laminotomy. And in fact, though we did suboccipital craniotomy, What needed, we do not know. Actually, it is not needed in this case. So through hemilaminotomy, we can do, you can see the nerve roots there, and the arachnoid is peeled out. The spinal cord is seen far away. So you have an excellent area. So this area you need to assess in the MRI. I always used to say that two eras in tumor surgeries. Number one is pre-CUSA and post-CUSA. I personally feel that I was just wondering about what we were doing pre-CUSA era. It was more of cutting, curating, scooping, slightly pulling. But now, after the CUSA has come, it is extremely easy to operate on a tumor like this. The spinal cord, we're not even using anything to retract or nothing. Just do the CUSA does most of the work. Only thing is that you have to be meticulous. As we all neurosurgeons, we are definitely meticulous. Meningiomas, particularly, you can see that they are, the dural adherence attachment is very large. Sometimes you can see the dura is calcified. So the dura is calcified there. There were a lot of difference of opinion whether to remove the dura or not. You can see that that's what I was seeing. It was slightly calcified. Now, probably with the recent these bone scans, bone ultrasound, I think probably we can remove that also. In the cervical spine region, excising the dura, it produces a very severe extradural bleed. So I'm not doing in much of the cases, but I thoroughly remove the tumor as much as possible. So you can see the spinal cord very lax. In fact, that it has made its own stretch to give you enough space for you to operate. And then you can do the closure meticulously. And that is the post-operative picture. And another case, I'm just showing only the most difficult cases, not the straight one which is seen posterior approach. This is the dorsal spine. In the dorsal spine, we know the lamina is very small. The lamina is very small. So you may have to drill out a bit of the pedicle. So here you have to be very careful because when you drill out the pedicle, you may have to reconstruct the spine. So this is the technique here. Far lateral approach, transpedicular, unilateral laminotomy approach. You can do the same thing on other side. You preserve everything, muscle, musculatures, and everything. Because when you do a laminotomy, believe me that if you follow, majority of the patients go in for a kyphosis over a period of time. Unless you follow them, you may miss, particularly on young patients. Here also you can see the spinal cord gives a lot, but though here the spinal cord is not lax, you just have to retract it and then pull out this is a neurofibroma, very easy. You just decompress and then see the nerve root meticulously and excise it. So all these things can be, if you see the diameter, the width of the laminotomy is just about 10 millimeters. But if you excise the pedicle, you get more space. You can go far laterally. And then, of course, you can reconstruct this with the pedicle screws, one above and one below, as I have done here. And so it is very easy. IDM is very easy and very pleasant to operate. In fact, more interesting, and you are very happy. This is so you must, as a neurosurgeon, and you must know how to put pedicle screws and also fix the spine. This is one thing which makes us a total neurospinal surgeons. We don't need to call for another specialist to do this. But the goals of the intramedullary tumor is slightly different because here there is a more challenge here. Ultimately, we need to have a safe resection of the tumor. The best final result we have to achieve, and we preserve whatever the neurological status is there. So this is another interesting topic which Dr. Suresh Nair was talking about it. Here is an ependymoma, which spreads between C2 to C5 intramedullary spinal cord tumor. Patient was clinically had numbness in upper limb, but patient was walking and no neurological, other neurological deficits. She was very comfortable from abroad. And this was the MRI I could able to get at that point of time in 2012. And This tumor was excised totally with microsurgical. Here we have to do laminectomy. No choice. Some surgeons prefer a laminotomy. Microsurgical excision was done and the total excision is done. Here the pia mater, I always stitch it to the dura because when you excise it, the spinal cord try to come up, put the suction particularly. In this case, we were not having a CUSA at that point of time when I was practicing in 2012. So, and there was no IONM also here. So it was very tough and I had a tough time thinking about it, but absolutely fine. Then we can close back after excising the ependymoma, you can close back the spinal cord, which is very important. This is very important because some surgeons just leave it and that is not good for the spinal cord and it is not good because you can have problems associated with this. This is the post-operative MRI. And this patient went on very well. And actually, in fact, that in 2020, this patient met me and we did the Dr. Suresh Nair, sir, this is your answer for this. 2012, we operated. This is 2020. There's no recurrence, nothing. She just comes for follow-up. She's somewhere from abroad. She comes for follow-up and she's good. So there is always a dilemma whether to irradiate these patients or not. Majority of the patients, if you feel that totally excised, I do not. I have discussed with my radio oncologists also. They also said you wait and watch. Here is another case of an ependymoma, which was there in upper dorsal region. And this is not very well defined lesion. This lesion is not well defined. And this is where you don't know where to enter in and where to come out. But this also, I excised it totally. You can see that as a post-operative after a few years, and this is immediate post-op, and this is post-op few years. And it's a very nicely excised. That means there is no recurrence also. But only difficulty is that this is my diagrams, is my own feeling, and it is not in the textbooks. Surgical, if you have a tumor like this, it is very easy to excise. So I call it simple. This is simple. This is simple, but this one is not simple. It's complex. Why means when you start operating, when you start excising it, the spinal cord tends to come, it comes closer. In spite that you put your pial stitches. The moment you start resecting out, slowly this part start coming out, particularly when you go more anterior. You look as if that you are transecting the spinal cord, but you are within the tumor. You just have to stay within the tumor. That is the goal. And this is another of my diagram only. And basically, I'm also an artist. So here I use that the forehand technique. You use the forehand technique. Your assistant must be very good. When you dissect after a cavity is made, when you dissect, your assistant must just have to keep the a small any patch, a small micro instrument to keep the spinal cord so that it does not fall. It does not suck along with that. Even with CUSA, sometimes it will come out. So meticulously you can excise it. Then came the era of these IONMs, which is very necessary because we want to do better and better. And here we need to know, we need to learn a little bit more. I'm also a learner in this as far as I cannot say that I'm mastering this. In fact, that I send my technician to NIMHANS for, this is a girl I think Dwarakanath must be knowing. She helps me a lot in the past 5 years. Is this MEP, SSCP, and D waves? These are all helping us. And not only that, you can do the dorsal column mapping, intramedullary motor mapping. That is direct stimulation when you are operating. And also trigger stimulation, direct stimulation can also be done if you are in suspect that you are going very close or you are damaging the tissues. So there was a lot of questions about whether IONM is really needed or not. I'm just reconsidering myself, and when we have 30 years of now doing neurosurgery. Past 5 years only we are using IONM. So 25 years we have been doing without that, but it was good only. So basically, you should be a good microneurosurgeon. That's what my personal feeling. But let me see what my recent cases are like this. So much of wires. It's all done by these technicians. The important thing is about getting these results, whether you get a true negative, true positive, or false positive and false negative. If it is true negative means there is no warning sign and you don't have any deficit. which is true positive means you have a warning sign and you find the patient has neurological deficit. False positive is very worst because they say that there is an indication, there is an alarm, then you try to stop it. Would you like to stop your surgery or would you like to go ahead with the surgery? In those days, we would have gone, whatever said and done, we would have tried to excise the lesion. But when the false positive comes, the surgeons start thinking, would you like to go forward or you want to wait for some time, put some warm saline, wait for some time, and then re-get the boost, or you want to do a wake-up surgery, you can do a wake-up surgery and then continue. False negative is again worst because nothing is being given and finally you find the patient in a very bad shape. Fortunately, so far it has not happened to us, but then it can happen. It can happen in many places. Here is a cervical ependymoma. Now showing it's a very large lesion from C2 to C7. It was looking more of cystic and also solid component. This is a very long laminectomy we have to do. You can see the dorsal veins and enlarged part. Nerve roots are very nicely exposed. You do a meticulous midline approach. Usually I go through the most expanded place. The most expanded, go through the midline approach, try to keep the veins as much as possible, and then do the PIA, stitch it to the dura nicely, so that that will hold the spinal cord very nicely. And then you start dissecting it with CUSA and without CUSA, as Dr. Suresh was telling, and that you can just pull it out. Actually, you have to dissect it very nicely. You see the spinal cord in yellowish color. And so there may not be much problem at all surgically. You can excise it as long as possible. I just wanted to show you, you can see a skip. I was trying to do some skip work here. Long years ago, there was one publication present that you can do skip opening, and then you can excise ependymomas. But then it is total. You can lift the tumor gently, microsurgical, forehand technique, but at the end, at the edges, sometimes you have some adherence very close. So there I use the CUSA and then we can excise it at the edges. Pulling is very difficult and you may not do. So CUSA helps very much for a satisfactory tumor removal. And here you can see the MEPs. You can see the MEP in the upper limb was not there before surgery, and it started coming up after that. So that means that your job is good. Your SSCP was not disturbed, so you're good. And there was a trigger EMG just we did to see where we are. So patient had, however, this patient had a mild neurological weakness, and that positive electrophysiological finding helps us to feel that the patient is going to improve. This patient improved very well post-operatively, and this is the post-op MRI of this long lesion excised. And later on, we fixed the lateral mass fixation for the whole laminectomy because we don't want it to go in for kyphosis. So after this, we did the cervical spine stabilization as well. Now, another case with this kind of neuroenteric cyst, it was a very chaotic tumor, baby, and it was done in November 20, and we excised this lesion. It was more or less like engine oil color the cyst was, and the solid part was also excised. Here also, I could able to get a good positive findings from here, because you can see we are not getting any signs here, but here the amplitude start coming. So it shows positive. It shows positive. We also use D wave, and D wave was good. Never the D wave get dislocated. I mean dislodged. So this gives us some confidence when you're operating, because this lesion, this baby, we were not getting where the spinal cord was, because you can see within the. So I always have the habit of staying within the tumor. Stay within the tumor. So don't try to see the spinal cord. Stay within the tumor, and that is the postoperative picture. Postoperative. Another case, something like a cystic lesion came. This patient came with quadriparesis. In fact, was not treated, was taking some native treatment, and We tried to do through a laminotomy and did the cystic evacuation. The D wave was good. Here, that is the cystic evacuation. After this, you can find the spinal cord became pretty lax. So here, again, the MEP was, you can see the MEP here. Here the MEP, it was not coming much. And SSCP was the same. In fact, SSCP was maintaining the same. This patient had one plus point is the D wave was helping us here. The D wave was improving. So that's what I tell my technologists, and please, you keep doing it and you tell me. I am doing it. If there is any disturbance, you stop me. And then finally, you see during resection, after resection, and then little bit later on, that is before completely everything is done, then we again to the D wave was improving, and this patient, in fact, improved post-operatively. So that was helping. So we are able to predict some outcomes. Similarly, some of the lesions at the cauda equina and the conus region is a little bit tough, but I find it a little bit tough because I'm not able to excise completely many of the lesions, but I have to leave here in this case, I have to leave a small lesion because, do the trigger EMG here, trigger, sometimes when I don't get a proper positive sign, I usually leave. I don't want to pull in this region. So this patient came out well. And this is electrophysiological studies. Here also, this patient showed a positive response. This was done by another technician. So he does superadded. There is one wave over another wave. So the first preoperative wave will be flap, and then the post later on, you find when you put that, you can find the waves coming out. So that means that you have not done any damage to the cord. Your microsurgical technique. This is another lesion like myxopapillary ependymoma at the epiconus region. And this was like this. It was very mixed, you can see here. Very mixed. Don't know where the tumor and which is spinal cord. So it's mostly it is, again, this was excised except leaving this small residual lesion. I had to be honest that, some of the things I cannot remove this because I had a doubt in the electrophysiology. It stopped me there. So this is a lipoma. A lipoma is another most difficult thing, which as far as I'm concerned, particularly some lipomas, this lipoma to me, it looked more easier. You can see that lesion, and after excision, it came out very well surgically. I was very happy because I follow this white line excision, very important. White line is most important, and you can correlate that with your neuromonitoring. So this is the conclusion of my talk. And finally, I have to say that IONM is some sort of an essential tool in the present day neurosurgery. In majority, it is policing the surgical procedure. It polices, it controls you. Earlier days, we were bold, but now some kind of a control is there and has improved the extent of surgical resection to an extent in some areas, particularly in the cauda equina regions. It is a great tool for the young surgeons to self-assess and improve the surgical technique. The young surgeons must start with this so that they know better, and certainly will reduce complications in spite of low percentage of uncertainty, because there is uncertainty in electrophysiology. It is yet not, the consensus is not very clear. Though intramedullary spinal cord tumors need to be done with IONM in present day, but if you have a good microsurgical technique and a good hand and composed mind, I think you can do a good outcome. Thank you very much.
Thank you, Dr. Parthiban. The topic is open for discussion.
Excellent job, Parthiban.
Thank you, sir.
One small message to everybody. More important than having IONM is having the technicians or doctors getting trained for interpreting that. Like he has done rightly to NIMANS to train them, because a poor monitoring is worse than no monitoring.
Yes.
It is better not to monitor. if it is a poor monitoring. Another thing, what is told, if MEP is lost, patients will definitely develop some deficit. But if your D wave is above 50% baseline, that is temporary, it will come. So you can still, so even if MEP is lost, you can still continue with dissection. As long as your D wave is above 50%. But if it is reaching around 50%, stop it. But other thing is this becomes useless if you are doing a hemangioblastoma. And you cannot stop and come, you cannot decore also. So they are pile-based tumors, but there you do this monitoring. I don't think it's of great help. And Coda-Equine also, I beg to differ. I don't think it is required.
Yeah.
Coda-Equine.
Yeah, I also felt, because I'm always confused with I don't know, I need to know about from others. The Coda-Equine, I know somehow, I'm not very happy when I'm operating. So
for Coda-Equine, sorry, for Coda-Equine and this one, generally anal sphincter monitoring is quite good. I mean, it might not help you with prognostication, but probably helps you in identifying the roots.
Yes.
Where you are dissecting away.
Yeah.
That is what is important.
That's the same thing I do. What I do is in cardiac and epiconus, the cardiac lesions, I use it for the identifying the nerve roots, because you sling it up and do a trigger, and then the staff can say, "Sir, this is this nerve root, and this is the then you can be more cautious at that place. Surgically, you can be more cautious."
How useful have you found it for monitoring bladder functions?
Yeah.
IONM?
Yeah, bladder functions are a bit difficult. So far, only sphincters we put only. Yeah. But there are methods to do the bladder functions, please.
So between MEP and SSCP, I thought, I would give more weightage to MEPs. SSCP would probably help you to make an incision, but after that, invariably there will be some drop in SSCP because you're going to handle the posterior cord in most of the intramedullary tumors.
That's why
Did
now.
you find it useful in SSCP?
Yeah, see that. No, what I'm now doing is, first initially we were very restricted. Now I'm doing multimodal. I put that girl to do everything. In fact, they may feel that I'm very cumbersome surgeon of all other guys. You put this, you do. Have you done MEP? Have you done SSCP? Then you put the D wave, and then you have a triggers and everything. It's like it's a hardship, but then when you combine it, you can, as Suresh sir was telling, when the D wave is going well, that means you are going well. Even the MEP drops. So if you have 2 or 3 modalities which are right time, so SSCP keeps going on, and MEP and SSCP, she can always tell me if there is anything wrong. But D wave is one thing which I feel, because it is a direct, it's a descending, reflex. So you can always monitor what is happening distal to the cord where you are operating. Yes.
The important thing is repeatedly stressed what it means is the monitoring is not going to tell you where the tumor ends and where the cord is coming. That is, you decide. It only is indicating how you are handling the cord. That's where you stop and proceed. It is not going to stop a surgeon if you have decided to excise the lesion, which has to be excised like an ependymoma. Sometimes, certain astrocytomas you leave behind, lipomas you leave behind. It doesn't really matter. But your decision is not based upon that. Your decision is wait, it comes back, or you are handling it wrong way. And as Dr. Suresh was telling next to me, this is one surgery where you don't ask your assistant only to observe, not to do anything. Because there will be a traction on 2 sides. Absolutely correct. In one surgery where assistants should not walk there. They get this see about yours.
Yeah.
Because if they run walk to the car, they're all monitoring.
Yeah. Suresh, see, I have trained my assistants like nice trained dogs. So you just have to hold. I have to tell them this is how you have to touch the other side of the cord. So when I'm working on the tumor, you just have to see the cord does not come in. Many times I've seen when you suck, the suction control, but of course with Q-side is very comfortable. But if you don't have a Q-side, then it's very problematic.
find that immediate post-op, final stop, or even a one for radical excision. Pre-monitoring errors or post-monitoring errors. That is the element difference.
Yeah. One thing is, sir, very honestly, that not much of worsening has happened to drastically, except few cases. The last case which I showed, that long case, the long ependymoma which I operated, I was a bit worried. Everything was going on well, but why there is a more weakness this patient had. But believe me, it recurred. It recovered in about 2 days' time. Slowly he came back. And then I realized that, okay, probably the electrophysiology study was helping me that, okay, this man will come back. But in case it has gone, MEP had gone, and then the deficit was there, it would have been more worse, maybe irrecoverable. So the before earlier days, we have no choice. We just sort of.
We have been hearing for the last 2 decades. Monitoring has helped you or not helped you. It does help.
Yeah.
You can't neglect it just saying that
Yeah.
they're not going to stop. But your immediate outcome in terms of how you manage the part, it does really matter. You're not able to separate out the neural tissue from the tumor, then that is totally different. Nobody's going to help you.
Yeah, absolutely.
That's why you do not neglect once you have the monitor, just telling that your monitor will fix you stupid signals. The common comment is here.
No, I'm very, very clear. And this, particularly the young surgeons must start working with ION. Then only you know there is a police who is controlling and your surgical technique improves more and more. Thank you.
Thank you, Dr. Parthiban. Yeah. We move on to the next talk by Dr. Dwarkanath, meningioma, clinical implications of tumor classification.
Thank you, Dr. Komal and Kiran and Dr. Shibu for inviting me. So it's not on. I bet if I were to take a poll of the neurosurgeons here, meningiomas probably would be some of our favorite tumors to operate. The outcomes have been very good, and but the question is, what are the prognostic implications of meningiomas and how do you manage? And meningiomas, as we know, are actually the most common primary intracranial tumors. There have been association with hormone receptors, ionizing radiation, smoking, NF2, Gorin syndrome, families with germline defects, and there have been important predictor. What has been believed over the past decades has been that the predictor has been the histological appearance, and hence an important factor in planning the management. So in this presentation, what I will do is I will go around the newer classification system and its implications in management, and also discuss a little bit about the controversies in management. So if you see the Central Brain Registry of the United States, meningiomas are among the most common tumors. And even the study from our institute by Dr. Vani et al., meningiomas are among the most common. So, I mean, they were more common than gliomas in the adult population. So how has the classification evolved? From the 79 first edition to the 93, several types were added. The hemangioblastic and the hemangioparasitic were removed or moved. Then rhabdoid was added in 2000. Atypical anaplastic got defined. Then in 2007, WHO's grade 1 and grade 2 were defined. Then in 2016, the criteria of brain invasion was added to grade 2. But there were some problems, and this was the WHO 2016 classification in which the grade 1s were defined. The grade 2s were defined, the criteria for grade 2 were defined, grade 3 was defined, and the criteria for grade 3 were defined. But this was purely on histological features. There were no molecular markers added, and it was prone to subjectivity. And this perhaps has been the biggest flaw in classification of meningioma, the subjectivity of the person who's doing the slide review. And among all of us, I'm sure that we have had many tumors in which we have been very happy with the extent of excision and kept the patient on follow-up. And to our surprise, the patient comes after some time with a huge recurrence. And they keep on recurring. And we have been unable to predict as to how a type 1 meningioma could behave like this. And why is this important? Because the importance is that the WHO grade 1 has a very good overall survival as well as a progression-free survival, while the WHO grade 3 has a very poor overall survival as well as a progression-free survival. And like I said, WHO 2016 classification, there were many drawbacks. One was there were variations in recurrence patterns. There was a paucity of evidence to identify the subgroups of meningiomas that behaved aggressively. And the question arose that were there any additional markers to predict prognosis in such tumors? And there have been quite a few studies which went on from, say, around 2010 to 2020 to incorporate identify any new markers which could be used for prognostication. So initially with the proliferative markers, the Ki67, P53, I mean, most of them have been carryovers from glioma studies, EGFR labeling index, whether these were useful in defining and predicting how these two meningiomas behaved. So these are some of the studies which use Ki67, Smith, Korshunov, Amartya, huge studies, which did show a difference between the benign grade 1 versus grade 3 meningiomas. But the question was, were they predictive? And we did our own study with Majid thesis, where we studied atypical and prognostic implication of clinical pathological studies. And we found that proliferative markers do correlate with clinical outcome, but have no advantage over mitosis count. And a mitosis count of greater than 8 can be considered as a cutoff value for a high risk of recurrence in a patient with atypical meningiomas. So this was further subdividing atypical meningiomas based on the mitotic count. And these had a higher recurrence rate, and with shorter progression-free survival was the weakness as presenting symptom, and mitotic counts greater than 8 were found to have a good prognostication. And a low Ki67 also had a better progression-free survival. Then the question arose, but what about chromosomal aberrations? I mean, there have been significant studies on gliomas, but does it apply to meningiomas? So there were studies on monosomy of chromosome 22, which were frequently studied to show any predictive pattern. High-grade meningiomas did show losses on various alleles. There have been multiple studies. Pascal did on LOH and chromosome 22 and 1, Weber, Feistel, within multiple studies. And they did find that the high-grade meningiomas had much higher rate of allelic loss when compared to type 1 meningiomas. This was a study which we published in 2015 on where we did a fish analysis of deletions in 22q, 18p, 1p32, and 14q32, and we did found that there was a statistically increased significant number of deletions in the recurrent lesions. The 18p lesions occurred in a younger population, and 22q deletions were associated with hypercellular tumors. And 1p, 14q, and 1p, 14q co-deletion had a significant associate with mitosis greater than 7. And in fact, this paper was awarded the best paper in 2016 NSI, or sorry, 2014 NSI. And what we did found that recurrent tumors and tumors with tendency to recur have a higher frequency of deletions. So these were the chromosomal studies. Now, what about the molecular risk stratification? So it was found that a growing number of individual molecular genetic alterations have been identified, but which of these actually have a more aggressive biology and worse outcomes? So what was studied were the TERT promoter regions, the CDKN2A deletions, and the loss of trimethylation of lysine 27 on histone 3. So the TERT came up in a big way in 2015 onwards, and there was this beautiful paper on the TERT promoter mutations and risk of recurrence in meningiomas, and they found that TERT promoter mutations were statistically significant compared and a had a shorter time to progression when compared to wild type TERTs. And so this led to an explosion in TERT studies. And there were multiple papers which said that TERT gene alterations is independent of the WHO classification. And those who are TERT positive have a much poorer prognosis when compared to the TERT wild type. So this was a study of 679 patients, meta-analysis. They found that the TERT mutations were 5, 8, and 15% in WHO grade 1, grade 2, and grade 3 tumors respectively. And if you see the recurrence-free survival, they were much higher with TERT wild type tumors when compared with the TERT mutated tumors. So when you are TERT positive, you had a shorter time to recurrence as well as a shorter survival rate. See, the other was the CDK N2A deletions. Deletion of CDK was identified exclusively in grade 2 and grade 3 tumors, 27 and 73%. And those who were this deletion was positive had a shorter median time to progression. That is 8 versus 101 months. So this led to the WHO 21 and update which was issued. And what has changed in this? The meningioma classification has changed. The essential diagnostic criteria has changed a little, but not much. WHO grade 2, the 4 to 19 mitotic figures stayed, brain invasion stayed, choroid and clear cell stayed. But what did change was the cellularity, small cells, prominent nuclear sheeting and foci spontaneous necrosis. But what was said was rhabdoid and papillary types should be graded on histological features of ATP alone and should not be classified on morphology alone. But what did change significantly was in grade 3 meningiomas, in which the high-risk molecular factors or the TERT promoter mutations or the CDK and 2A deletions were included in the classification for the first time. And if these were positive, they were considered to be as grade 3. So we just finished our study on 71 patients of WHO grade 1 and grade 2 meningiomas. We found TERT mutations in 5 patients, and all the patients who had TERT mutations in our study, the recurrence rate was 100%. And the relative risk of recurrence in the mutant group was 5.5 times that of the wild type. And this is, if you can see, the wild type is this is the wild type, and this is the recurrence pattern. All the patients with TERT mutations came positive, and they had a shorter time to progression. Similarly, molecular classification on H3K27Me has also been studied, and it has been found in varying grades in various types of tumors. And the loss was predictive of decreased recurrence-free survival, which was independent of sex, extent of resection, tumor grade, and proliferation index. So the new, what are the new things which are coming? One is DNA methylation studies or the DNA RNA profiling, and where they have been classed based on the methylation-based classification. Even though this has been a proposed molecular grade, this has not come up in a big way and it's not been included in the present classification, but in the future, we might see it as to how these meningiomas are being classified. So now what are the controversies of management? I think surgery is the mainstay of treatment. There's no doubt about it. The Simpson's grade of excision is a predictor of recurrence. There's no doubt about it. In our own study of 699 patients, the risk of recurrence was much higher in grade 2 and grade 3 when compared to grade 1, depending upon the Simpson's grade. This has been a consistent finding in all studies, and the aim for surgery should be complete excision whenever possible. The question is, when do we do adjuvant radiotherapy? So the adjuvant radiotherapy has a well-established role in grade 3, irrespective of the grade of excision. The 5-year recurrence rate and the overall survival improve when postoperative radiotherapy is given to grade 3 meningiomas, and it decreases the recurrence rate by approximately 50% and improves the 5-year survival. The question is, what about grade 2 meningiomas? And this has been the source of controversy over the years, because grade 3, generally, most of us follow the principle of giving radiotherapy, and grade 1, we generally do SRS or gamma knife. The grade 2 have been the gray area of management of meningiomas. So what do we do with them? One is the incompletely resected tumors. The recurrence rate has been 60 to 100%. Here, local RT improves local control, decreases the rate of recurrence, and may improve survival. And this is the graph which was produced by Wong et al., which shows that the recurrence as well as the progression-free survival is better when radiation is given. Now the question is, what about grade 2 atypical meningiomas who have undergone GTR? So probably the consensus is reaching in those who have not undergone GTR and the significant residue in grade 2, it's preferable to give SRT or gamma knife or SRS. But what about grade 2 meningiomas who have undergone gross total resection? This has been controversial because there is a thought which says that let us look, we have done a good excision and let us wait and watch, while other people believe in giving upfront radiotherapy. This has been controversial. There have been multi-center studies going on. There is no randomized data available. The potential benefits of radiotherapy in terms of preventing or delaying tumor recurrence should be balanced with the risk and side effects of radiotherapy. So what are the studies in support of adjuvant therapy? This is the Rogers, the RTOG 0539 study, which studied 52 patients with atypical meningiomas. And they said that those who received radiotherapy had a progression-free survival of 94% versus 70% of historical control. So there was a study by Lee et al., a retrospective single institution cohort study of 230 patients. Here again, the patients who had undergone radiotherapy in spite of complete excision had a better progression-free survival when radiotherapy was given at both 5 years and 10 years. So what are the ongoing studies? We have the EORC 2242 study and the NRG and the ROME study, which probably will give us a better idea of whether radiotherapy is actually needed. So coming to I'll be concluding. So what are the prognostications? Extent of resection has been the most important factor for predicting recurrence. WHO grade 1 has a much better outcomes than WHO grade 3. Mutational alterations of AKT, TRAF, and SMO mutations have a benign clinical course, while third promoter mutations, irrespective of the WHO grade, have a poor outcome. Methylation classes MC123 have a good outcome. INT-A has a fair outcome. INT-B has a fair or a poor outcome, while MCML has a poor outcome. So I would like to conclude by saying that molecular risk stratification is helpful for prognosticating tumors, helps in choosing adjuvant despite a benign histopathology, especially the presence of TERT mutations and the deletions. Methylation profiling can have a better predictive potential compared to pure histopathological grading. This can actually mitigate the problem of subjectivity in histopathology, and thus it helps in identifying meningiomas with aggressive potential irrespective of the grade and to tailor the management accordingly, and could offer up new avenues for research such as molecular targeting. So molecular stratification probably is going to come in a big way over the next few years, and perhaps will improve the overall survival as well as progression-free survival. So I would like to end here and invite you to the first NIMHANS neurosurgical oration, the Professor Verma oration and the Professor Narayana Reddy oration. We have Professor Laligam Shekhar and Dr. Timappa who are going to give the orations, and Professor Laligam Shekhar will also be doing the operative microneurosurgical workshop on the 3rd. All are invited. The website is down, the nimhansoration.com. Thank you.
A very wonderful talk. Yesterday, Anand sir, after we are still grappling with this new classification. Yesterday, Dr. Anand made it easy for us to understand the clinical implications in glamour. And today, Dr. Dwarkanath has made it easy for us to understand the meningiomas in relation. So the paper is now, the presentation is over and it's open for discussion and comments, please.
Mike.
With margins. The SRT, SRS will go only for grade 1, residue or upfront.
No, I actually with the new gamma knife, we can actually fractionate the radiation.
No, the
So you
point
can
is-
actually take a margin and then you fractionate it.
Yeah, margin is essential.
Yeah.
SRT also, a fractionated SRT is a possibility because lot of times we see a large cavity and a large this one. So you end up giving a large volume which is not feasible with SRT or SRS.
I think that's precisely been the source of confusion in grade 2 atypical meningiomas have been completely resected. The question whether to give RT or not. Because you'll never be, I mean, whether we are going to predict the behavior is something which we don't know. And I was talking to the oncologist in Kidwai, and he said we wait for some time, then take the margins, the supposed margins, and then give SRT. So they do the cavity radiation as well as the margin. So, I mean, I don't know how you do it, but this is what the Kidwai people do. But the question is whether actually they need it or not. I mean, it's not clear in meningioma. So probably the molecular markings will help us actually prognosticate whether they need or we can just observe and wait and watch.
If there are no other questions, we'll wind up. Thank you, Dr. Dwarkanath.
Thank you, sir.
Thank you.
Now we shall move into the oration. And I would request Dr. Timappa Hegde, Dr. K.N. Krishna, and Dr. Ravi Gopal Verma to please take their places on the stage as chairpersons. I request Dr. Timappa Hegde to please take the podium and welcome sir and say a few words.
We come to the highlight of the Narayana Neuro-Oncology Symposium with the oration. We're extremely happy to have Dr. Suresh Nair as the orator. All of us have seen him as a source of inspiration, an eminent microneurosurgeon, an academician, and a teacher for so many decades, and so many brilliant neurosurgeons all over the world directly and indirectly have benefited from him. And so many of our students have been through him as his examiners, and he's been as a teacher also during the examination. I'm also happy to have two of the outstanding alumni of Sri Chitra, who were at one time in some way students of Dr. Suresh Nair. Dr. K.N. Krishna was the first resident from Chitra. And by the time he was finishing, that's when I think Dr. Suresh Nair, you joined at 86, I think, and you must have finished at 87 or 88. Of course, Dr. Ravi Varma was also his student. I will request Dr. Komal Prasad to formally introduce Dr. Suresh Nair.
Another student of Professor Suresh Nair, who have spread all around the globe now. I'm very happy to introduce orator of the day, Professor Suresh Nair. It's NVSS Oration 2022 by Professor Suresh Nair, acknowledging his contributions in education and transforming lives. The second NVSS Oration is happening today. The first one was by Professor Shlome Constantini. That was in 2 years ago, in 2019. Past President, Neurological Society of India, former Dean and Professor of Neurosurgery, Sri Chitra Tirunal Institute for Medical Sciences and Technology, Trivandrum. President-elect of International Meningioma Society. So this is how his visiting card would look like. So for most of us, it's enough if we hear the name Professor Suresh Nair. Huge personality. We can't make it anything brief, like his CV runs into many pages. And this is just to recapitulate his life history. Born on 9/6/1952, twins, Dr. Suresh Nair and Dr. Ramesh Nair. I just asked him who is who, and he says the right side is him and left is his brother. He is an eminent physician and diabetologist at Kottayam, present president of API Kerala chapter. Early schooling was in Trivandrum, studied later in Government Medical College Trivandrum, then at Cochin, and then as a registrar in neurosurgery at Trivandrum, then did MCH from Madurai Medical College, Madurai. Hardcore academician and skilled microneurosurgeon. He's a neurosurgical teacher in the true sense of the word, right to the day. Even day before, he took classes to Niman's residents as well as our residents. Whole day he was with us, with the residents, teaching. So this is our alma mater and the place where Professor Suresh Nair worked for 31 years, July 1986 to June 2017. And during his tenure, he trained 101 residents who are accomplished surgeons all over India and abroad. So he was past president of Neurological Society of India in 2018, president of Skull-Base Surgery Society of India 2015, holds number of important positions in world neurosurgery, served as professor at All India Institute of Bhopal recently in November 2018 for 15 months. So during his tenure, this article from Neurology India recapitulates his contribution to Sri Chitra, in which how the department grew over years, where the international renowned, the big names of neurosurgery were invited as faculty and as visiting surgeons. And his short CV itself goes to 3 pages. So President-elect of International Meningioma Society, Secretary World Federation of Skull-Base Societies, Member Nominating Committee of World Federation of Skull-Base Societies, Professor of Neurosurgery at AIIMS Bhopal, former Dean at Sri Chitra Tirunal Institute, former Professor and Head Department of Neurosurgery for 31 years and Head as 11 years, President NSI, President Skull-Base Surgery Society of India, Nominating Committee of WFNS, International Review Board of Neurosurgery, WFNS Skull-Base Surgery Committee, Anatomy Committee, Asian Oceanian Skull-Base Surgery Committee, Joint Educational Neurosurgery Committee of ACNS, Asian Journal of Neurosurgery. He is editor for multiple journals, invited faculty to numerous national and international meetings, and guest faculty to various universities in Japan, USA, and Morocco. Examiner to various Indian universities, including our Narayana. For DNB, he has come as examiner. Many of our alumni have passed through his rigorous examination process. PhD examiner at NIMHANS and PGH Chandigarh. 149 articles in various journals, 1644 citations, and some 37 textbook articles, more than 300 papers, and trained over 101 neurosurgeons till date. So this he's been made the president-elect of International Meningioma Society, and he will take over as the president in next meeting. So any group photo from Chitra will show various people who have accomplished in their own sphere in various parts of India and abroad. So this is the Chitra family, Professor Raut, and who is who of world neurosurgery over in the last 3-4 decades. Last but not the least, family man. His wife, Dr. Vinita Nair, headed the medical division of ISRO at Trivandrum. His son, Dr. Anirudh Nair, is a ENT surgeon. He works in Bangalore now in Trustwell Hospitals. Best examiner ever. Anybody who has gone through his examination process will vouch for that it's more of a teaching than examination. He's an astute observer. He can make out the worth of the examinee in an instant, and then from then on it will be teaching even at the moment of examination. Great teacher and fantastic human being, Professor Suresh Nair. This is, we will see him live here. He spoke something about resident. He says he can smell every resident. He remembers everybody when they joined, when they left, what they are doing. And our examiners from Narayana Hridayalaya, Narayana Health, he asked who all got through his examination process, and I could locate 7 of them, everybody doing very well. I sent him the list, and they are doing in various different, they are in 5 continents at present. And this is day before yesterday, very curious, very interested in anything academic activity. He visited our Translational Research Center, interacted with the basic scientists. Whole of the yesterday, he interacted with the molecular biologists and asked questions, noted notes. And this was his interaction, case discussion. For whole day he took, day before yesterday at our Mazumdar Shah Center. And this was him yesterday. And for most of the 10 hours of academic deliberation yesterday, he was keenly observing and taking notes and making videos. So I cordially invite Professor Suresh Nair to deliver the oration. Thank you very much, sir.
That generous introduction. I was so unkind to him while he was at training at Chitra. And he always used, whenever I used to go to the ward, I used to go very early. So residents used to come at 6 o'clock, 6:30, because I can appear any time between 6, 6:15, 6:30. Not because my wife wanted to throw me out of the house, but I used to go early. And poor Komal, he got the brunt of my firing in my heydays there. And very recently there was a meeting at Indore, the skull-based interim meeting. So many of Chitra residents had come. And then one resident was telling, I said, how was the training at Chitra? He said, it was like commando training. So neurosurgery was the commando training only. So at the outset, let me thank my dear friend, Timmappa, for inviting me as a orator for this great event which you are conducting for the last 2 days. And Timmappa and myself, we studied almost at the same time. We have so many things in common. And not only Timmappa, all these big giants sitting here. And I thank them for giving me this opportunity. And my friend and student Komal, and here you can see Kiran, a skull-based surgeon, and great person Shibu. All the giants are in this picture. And not that, I am indebted to Narayana because, and this person, Devi Shetty, not because he is a CEO of your institute. He actually looked after my wife when she got operated at Narayana 10 years back. She had valve surgery here. And P.V. Rao, I don't know whether he's around. P.V. Rao did that surgery, valve replacement surgery, great institute, humble beginnings, something common between Devi Shetty and my initial director at Chitra, Professor Velliyathan. They are visionaries. And no doubt, second visionary I am seeing after a long time, after Professor Velliyathan, is Devi Shetty and the great institute and the institute which Narayana, now they have neurosciences wing. And this is not that I was examiner to some of your students. So whenever this selection process comes, people start asking me, which place should my son, or I know so many people who have got admission interested in neurosurgery. I said, Narayana Hridayalaya is as good as any national institute. You just ask them to join. And if they are not getting in All India Institute, Nimmans, or because they are the first choices, or Chitra, then I said, just go and join Narayana Hridayalaya. Just don't go for MCH to some lesser places, just go blindly join, because it's a great institute. Students are also very good. I think I have given distinction to some of the students who appeared for DNB, and they were so good. I was wondering, and day before yesterday when I went to take class, excellent presentation. I could not even pin them down. I was worried whether they will pin me down, but they were very good. And look, let me go to my oration. This is, whole my lifetime I spent that institute in Chitra. We have very focused work, because that was the time from when we started. I was doing CV Junction for 10 years. Gradually, when my seniors, they went out, I took over this area of CP angle. I could do close to more than 1,000 cases of CP angle tumors and close to 835 vestibular schwannomas. I have no conflict of interest. Komal showed these pictures. Chitra has 3 arms. It has a hospital wing where Ravi Gopal Verma, Komal, and Krishna, they all studied it. We have a biomedical technology wing, which is again a flagship of thing of our institute, and we have a health sciences wing also. And this is the first professor at Chitra Tirunal Institute. He never liked me, always used to fire me. At that time I was a houseman only, but later he became one of my great friends only. I should tell, he became a great friend of mine. And this person who is in the middle, I don't know, this thing will work or not work. This is Professor Raut, who was professor to Krishna and all, and it's very difficult to work under. He's very tough man, and I survived the Professor Raut's firing and all for many, many years. And many of you know him also. And this is my real mentor. If you ask me who gave me inspiration to take up the CP angle, this is Basant Misra. He is at Hinduja Hospital, Bombay. We worked together at Chitra Tirunal Institute for a long time. And then he moved over to Mumbai. And this picture, shows all the big time. This is Professor Raut here, Dr. Bhattacharya, who was heading the department before me, myself, Misra, and all the friends, Dr. Ravi Mohan Rao, so Girish Menon, they were all there in this photograph when we had a meeting at Chitra Tirunal Institute. And these are some of the students, just to show, this is Panikar, he was also our resident there, myself, Bhattacharya, Ravi Mohan, Rajanish, all good students. Fartado, he is working in Bangalore only. Let me see, any Bangalore people are there? Nobody here in Bangalore. This is there. Prakash is also in Bangalore. So we have provided Bangalore with so many residents, and this is a departmental photo. This is my wife and others. This is the colleagues who were with me when I joined Chitra in 1986. We 4 were the junior faculty, Misra, Raji Sharma, Rohatgi, and myself. We were the junior faculty at Chitra Tirunal Institute, and all of us have aged. And these were my right and left hands at Chitra Tirunal Institute when I was heading the department. Ravi Mohan is in Bangalore only, and Girish Menon. And this is yet another equally good successor. He was head of the department at Chitra. Now we have that rotation. Is Matthew Abraham, one of the excellent surgeons. He was also our student. And another great student, and he is Prakash, he helped me with this, putting up this presentation. He is a very good endoscopic surgeon. And you should always have some mentors abroad for you to come up in neurosurgery. And this man is Professor Kono. Nobody taught me how to preserve the 7th nerve. Even my friend Misra, who is a great vestibular schwannoma surgeon, never taught me. Every time I said, I am not seeing any 7th nerve. People are telling 7, they are preserving all grade 1, 2. I said, what I am doing for the last so many cases, I am not seeing 7th nerve. This is the person, Kono from Tokyo University. He told, I will show you what he taught me and how I started preserving 7th nerve. And then this is, you require a real world mentor to promote you. This man probably you may not have seen. Youngsters is Professor Kabase. Because of him, I could come up in world neurosurgery. And our institute was recognized as an education center like NIMHANS.
And I could come to all this big committee because of this man. I am somewhere in this committee also. Skull-based committee, somewhere there I must be standing. All big guns, Lalingam Sekhar. These are the think tank of neurosurgery. Even now, many of them are very big people. So now let me go to my oration. So I have operated 835 cases in my tenure at that is not assisting somebody. This is I have done 835. Prior to that, I would have assisted some case. And Chitrarenal Institute is a large national institute. It's just like All India Institute of Medical Science, PGI. At some point of time, there were only 3 institutes of national importance. Recognized with that national institutes of national importance by act of parliament means we are all statutory universities. So at some point of time, all the IITs, Chitrarenal Institute, PGI and All India Institute were the medical institutes of national importance, then IIT, then there were some other few institutes also. Much later, some 20 years later only, Nimhans all could get that national. What is this statutory university means? You know, you are university by ourselves. So we can award our degrees. We don't have to depend on anybody. And it is a big thing. And I really want Narayana Hridayalaya to become a institute of national importance. What they have, I'm amazed at what work they're doing. And I think really they should become not deemed university. They should become a statutory university. And this is what I am going to talk of, vestibular schwannoma. And this was my, all I used to breathe, eat, sleep, everything with vestibular schwannoma. So it's a benign tumor, which is arising from the vestibular cochlear nerve, vestibular part of the cochlear nerve. It can arise anywhere along the course of the vestibular nerve, but the thing is, like it can arise, most of the time it arises inside the canal, but it can arise outside the canal also. Usually it arises from the Obersteiner Rutledge zone, where it's a meeting point of Schwann and peripheral myelin and central myelin. So that is the place that is inside the canal, it arises from there. And it can be, sometimes it can be very small, and or it can be slightly big, or it can be still bigger, or it can be very big. And the present day, the prevalence of vestibular schwannoma is, you won't believe, prevalence is 1 in 500 persons. They have vestibular schwannoma. That is the present day statistics. And incidence, if you tell, long back when we all studied, it used to be 1 to 2 per 100,000 patient years. Now it is 5 for 100,000 patient years. So vestibular schwannoma, the pickup has come so much because people do left and right MRI scan for non-specific headache, for trauma like that. So people are finding out vestibular schwannoma in quite a number of people, especially in elderly over the age of 60 or 70 years. It is 20 per 100,000 patient years. So it is so much is there. The thing is, what is happening is, many of these patients, you know, during our era would have lived their life without ever having the tumor getting detected. Now these patients are getting, many people are getting detected to have small vestibular trauma, which opens a big Pandora box. What to be done, whether to be left alone or should we treat, change like that, which we'll address. This is the spectrum of cases. We see large tumors. This is the cases which I have seen in Chitra. It can come in different shapes, sizes, large tumors. So small vestibular schwannoma is a different disease altogether. Large tumors are another disease. It is a totally different disease. You cannot compare a small vestibular schwannoma with a large vestibular schwannoma. Like it can be polylobular. Say it can be bilateral, it can be extremely vascular, it can have pile breaching, it can have impaction into the bone, it can be cystic. So it can have so many problems coming to the ambient system, gross hydrocephalus, again bony invasion, bleed. So it is a different thing. No vestibular schwannoma is safe. If you get away with a large vestibular schwannoma, doesn't mean your next small vestibular schwannoma is going to be very easy. And I should tell, you know, in 2003, there was a meeting in Chandigarh. This was an NSI meeting. So I did 100 vestibular schwannoma cases and I didn't have a single mortality. So I presented there vestibular schwannoma surgery towards zero mortality. There was one person looking at me from above. That was God only. My next vestibular schwannoma patient died. So because I presented in that meeting vestibular schwannoma surgery towards zero mortality. Next vestibular schwannoma patient died. That is, after that I never talk of mortality in vestibular schwannoma. So this is the thing. Redo, patients get operated somewhere there, and then we have to admit there at Chitra. So it comes like in various shapes. And this patient came walking. You can see the brainstem sandwiched between two tumors, coming virtually intact with some hardness of hearing only. So let me go to the history of vestibular schwannoma. This is the first, the anatomist John Hunter described vestibular schwannoma in the 18th century, but there were no attempts to remove because, there were no antibiotics available. So people could not attempt this surgery. And the first reported case was by Balance. He operated a British surgeon in 1894. He enucleated the tumor with the finger. Surprisingly, patient lived for many, many more years. And also he was credited for anastomosis surgery. Going to the history, this is what he did, insinuated the cinder. Patient survived with facial palsy, but his eye had to be enucleated because of keratitis. Next came this man, is Feeder Cross. Feeder Cross was the father of German neurosurgery. So he started doing this through the lateral suboccipital approach. Those days, emphasis was on speed only. You should quickly remove it because of bleeding problem. And also CP angle earned the nickname of bloody angle. And then came this particular man, is the father of old, not modern neurosurgery, old neurosurgery, Harvey Cushing. He started doing in all positions, sitting position, dorsal position, semi-sitting position. You can see all the patients died. So it is by 1917, he had built up some 30 cases with very high mortality rate. Then came some, this is the era, some Charles Balance, he first successfully removed, which I told, Feeder Cross, Victor Horsley, Harvey Cushing, little improved with these people. Walter Dandy, Olive Krona from Sweden, and House Institute, presently called from California, started preserving the seventh nerve. So the thing is, until 1964, only suboccipital, you could see the whole posterior fossa bone they used to remove. It was not retrosigmoid, people used to call suboccipital approach. Later, in 1904, translabyrinthine approach came, but for the next 60 years, nobody ever bothered to use, until William House again started using labyrinthine approach. Same William House also did middle fossa approach. So we have, then we had an explosion in understanding the microsurgical anatomy, operative microscope, anesthesia. So there was an explosion in the understanding of vestibular schwannoma surgery. We know very well what is this angle bounded by all these fissures, flocculus. We know the big players there. This is the facial nerve and the vestibular nerve. You have the sixth nerve, you have the pre-olivary, you have the hypoglossal, post-olivary, lower, you have the vessels, hyca, everything we know the anatomy in detail. Because anatomy, we know very much about the pre and post meatal segments of hyca, which is a big player in CP angle surgery, and the perforators arising from there. We know the anatomy at the lateral end of the internal auditory canal very well. We know the position of seventh nerve in relation to the superior vestibular, position of cochlear in relation to the inferior vestibular. We know the anatomy very well. It's one of the easiest places, not easiest, better places to identify the nerve is the canal only. And this is how it looks. People call this cock and seven up and cock down. And this is again another picture of the lateral under the internal auditory canal. You can see the transverse crust there separating these nerves. And brainstem relations also we know very well now at the pondomedullary sulcus. And this is the seventh, eighth nerve here. So seventh nerve usually is anterior to the eighth nerve. But it could be anterior, inferior, superior, or wherever it is. And again, you should know that seventh nerve is always anterior and inferior to the eighth nerve. And like this, it can have varied position. Seventh nerve usually is in front, and it is inferior, superior, anterior. This, even with the best investigation also till now, people are, even with the best DTI even now, people are not very consistently telling the position of seventh nerve in presence of big tumor. And this is also, we know that ICA is a big player in vestibular schwannoma surgery. If you lose ICA proximally, proximal ICA you will lose, anterior inferior cerebellar artery, you can have a large infarct with significant deficits. And I will tell you how to avoid that. And distal ICA, even if you lose a distal ICA, it comes to the middle cerebellar peduncle area. Patient may come out with very subtle, even without any problem. So it is of paramount importance to preserve. This is ICA producing a large infarct. We know that. Now, what are the myths? What are the myths about vestibular schwannoma? First is the term, it used to be called acoustic neuroma. We know that these tumors, they are not arising from the acoustic nerve, they are arising from the vestibular nerve. Previously, people thought that larger vestibular schwannoma can't be removed completely. And these myths and all old time surgeons have solved this. And people told that facial nerve could not be preserved. It was a myth for me also, like what I told you. But great surgeons like William House, Majid Sami, they proved that every case they can preserve. And people even believed that hearing cannot be preserved. And the other myth, is this thing only. This is the myth which is still persisting, it is the main theme of my talk is this only. Whether CP angle is 1 CS of the cerebellopontine angle, is it 1 CS of compartment? So cistern, that cistern, CP angle cistern. Cisterns mean is dilated space. So is it just one CS of compartment, or it is multiple CS of compartment, CP angle? Whether vestibular schwannoma, whether it is a epiarachnoid, whether it arises epiarachnoid. These are all these are the myths, whether it is epiarachnoid tumor or not. Then whether the arachnoid, if it is epiarachnoid arising in the lateral end of the internal auditory canal, arachnoid cannot extend up to the far lateral end, whether it extends to the far end of the internal auditory canal. Then whether a layer of arachnoid separates the tumor from the 7th and 8th nerve. You take the tumor, if there is a layer of arachnoid, you can virtually protect the 7th, 8th nerve. Is there an arachnoid? These are the myths which are still going on. Many of these people have tried to solve these myths, and this is Dandy, Olive Krona, this is House, Yasser Gill, all these people, Majid Sameh, they have helped us in solving many of these myths. And first is CP angular single cisternal space. This saffron colored, this BJP colored thing people call a cerebellopontine angle, cistern. So is it a single cisternal space or multiple cisternal space? And this is the article written by the great giant Majid Sami, that this cistern encloses all the cranial nerves, 7th, 6th, everything. Is it true? Written by one of the biggest neurosurgeons. Let me come with just a video. Is it a single? This is not a case of vestibular schwannoma. This is, I am doing a surgery for microvascular decompression for trigeminal neuralgia. This is a 7th nerve. It is in acousticofacial cistern. There is one cistern here. So acousticofacial cistern carries the 7th, 8th nerve together. There is another cistern here. You can see the arachnoid here. It is in another cistern where the lower cranial nerves are going. You are not even seeing the 5th nerve. There is another cistern there where the 5th nerve goes. The point I am making is cerebellopontine angle has got multiple CS of spaces. The acousticofacial cistern, which is we are seeing now with this ICA and all, say that houses only 7th, 8th nerve. Understand? While you have a trigeminal cistern above, you can see the arachnoid covering another pouch. It is not in communication. It houses the 5th nerve. And lower cranial nerve, it is in another cistern there. What is important is, if there is any tumor arising from any of these nerves in this 7th nerve or 6th nerve, or 7th nerve or 8th nerve in this cistern, there is always a arachnoid which separates it from the 5th nerve. There is always a arachnoid which separates it from the lower cranial nerve. It's very clear. If there is a tumor arising inside the cistern, inside the subarachnoid space, like that a tumor arising from the lower cranial nerve, so there will always be a cistern which separates it from the seventh nerve. So thing is, if there is a tumor which is arising from the vestibular nerve, the point I am making, which I will show in multiple videos, there is no arachnoid which separates it from the facial nerve, because they are growing together. It is in one cisternal compartment. There is no arachnoid to separate the facial nerve from the tumor, which I will show. This is just another case I am just showing. When the sister, this is the 7th, 8th, this is the 5th, and here you can see the 6th nerve coming here. 6th nerve is coming. It is the vertebral artery. This is the ICA. 6th nerve rootless. This is opening all the cisterns after surgery. After I have removed, and you can see the lower cranial nerve, just to show that this is after surgery. This is ICA, lower cranial nerves there. This is the 6th nerve. So when you open everything, you can make it into a single compartment. Otherwise, it is not. This is the lower cranial. You can see spinal accessory, lower cranial nerves down. And most of my videos, this is 7th, 8th is in the middle. 6th is here. And even this is the 4th nerve here. So we can expose all the nerves. This is the 4th nerve. So all the nerves are in different cistern spaces. Next query is whether a CP angle arachnoid, does it extend to the far lateral end of the internal auditory meatus? So this is, you can see the present day high resolution MR. It shows the cistern going right up to the far lateral end of the meatus. And this is yet another beautiful picture. You can see the acousticofacial cistern with all the nerves inside right up to the fundus. You can see the 7th nerve going also. And this is a tourmaline blue staining of the arachnoid, which shows that the arachnoid is extending right up to the fundus of the internal auditory canal. And this is yet another picture showing the extension of arachnoid into the far lateral end. This to prove the point that there is no epiarachnoid space at the far lateral end of the canal. There is no space there because arachnoid is extending right flushed with the bone there. There is no epiarachnoid space. And what is the site of origin of vestibular schwannoma? So when I taught people, I always used to tell they arise epiarachnoid. Now I will tell you. So what is the exact site of origin? It usually arises in the Obersteiner Rittley zone, the transition zone, in and around that, which is inside the internal auditory canal. If it is inside the internal auditory canal, and if the arachnoid is extending up to the far lateral end, then it has to arise inside the canal in the subarachnoid space, which I will show in later video. This is a concept which I taught everybody. I think I taught even Ravi, and I think I was not senior enough to teach Krishna at that point of time. But then Kamala and all, I would have taught this only. This is the age-old concept. This tumor arises at the, this is a canal, internal auditory canal. This is a CP angle. This tumor arises at the far lateral end of the canal. And then as it grows towards the angle, as it grows medially from the canal, it takes it within this arachnoid which was inside the canal. And because it is supposed to arise epiarachnoid, so it takes the arachnoid along with that, and ultimately it juxtaposes to the parietal arachnoid of the CP angle, so that any surgeon who operates through a retrosigmoid or retrolabyrinthine route, they have to peel out this double layer of arachnoid to come to the tumor. This is what we all believe, which I taught many of my residents. So is it true? Because this is the picture I got from Professor Corno's article. I just explained that these tumors, this cistern extends to the lateral end of the canal. You can see the nerve here. Here you are seeing a vestibular schwannoma inside the canal. Had this tumor arising from the lateral end, there would not have been any CSF space lateral to the tumor. Here we are seeing a CSF space which proves that this tumor is arising from the subarachnoid space. These are two people who changed the concept about vestibular schwannoma surgery. One is Kenji Ohata, everybody knows, from Osaka, and Kono, whom I told you, from Tokyo University. So this is a landmark article which has come in Neurosurgery 11 years back. And this is Professor Kono from Osaka. So I will just tell you the cartoon. This is Professor Kono and myself in Los Angeles many years back. So this is a cartoon which shows the tumor arising epiarachnoid. It is arising epiarachnoid. This is another cartoon which shows the tumor arising subarachnoid. Understand, this is a epiarachnoid tumor. This is a cartoon which shows a subarachnoid origin. Now, what this surgeon did, he peeled out this double layer of arachnoid and then took a biopsy from the surface of the tumor. And then he found that all the patients have a arachnoid. After peeling off the double layer of arachnoid, he took a biopsy from the surface of the tumor and found that all the acoustic schwannomas have a arachnoid over the arachnoid, which he could prove with staining and all. There is still another layer of arachnoid. And that is how he proved first that this is not epiarachnoid, this is a subarachnoid tumor. And then I will tell, then you are seeing the formation of this double fold of arachnoid. This formation of double fold, people will think will not occur with a subarachnoid origin. But that also he gave explanation. So I have to come back to this slide again. So this is what he told. This cartoon is that it is arising in the subarachnoid space. Then the tumor gets adhered to the dura arachnoid or the petrous bone at the canal, and then that adhesion moves towards the CP angle area. So it begins subarachnoid, behaves epiarachnoid for some time to become subarachnoid again. So the point I am making is, if you have to open this, take out this tumor, say you open inside here, find out the nerve, then you peel this arachnoid. You peel this arachnoid, you cannot keep this double fold of arachnoid for long. At some point of time, you are entering into the subarachnoid space. So any acoustic neuronoma you see, large tumors you operate, you peel off this arachnoid, and after some time you are into the subarachnoid space, because you cannot maintain this arachnoid throughout the surface of the tumor. So that is a very important point, because many people, had it been like this, a epiarachnoid tumor, you take the tumor out from the canal, there should be a layer of arachnoid which should be covering 7th, 8th nerve. These tumors are supposed to arise the whole time epiarachnoid from the vestibular division. All the nerves are different. Suppose it is arising epiarachnoid, say there should be a layer of arachnoid covering the 7th, 8th nerve. If you pull out the tumor, if it is in the canal, but that hardly there is any arachnoid which covers the tumor, covers the 7th, 8th inside the canal. I will show with multiple videos. So this is the present day concept. This is the tumor and this is the tumor. The capsule of the tumor, which is this dark thing, it is actually the perineurium of the vestibular nerve. The perineurium of the vestibular nerve is the capsule of the tumor. And what is this yellow one? Yellow one is the facial nerve. So, and this is the arachnoid. So this is in the subarachnoid space. You can see the subarachnoid space. This is the tumor, and this is just stuck to the, this facial nerve is just stuck to the tumor. There is no arachnoid which separates the perineurium, which is the capsule of the vestibular schwannoma, from the 7th nerve. If you have understood this, you will save the 7th nerve. If you have not understood this, if you think that still arachnoid will come and help you, which will separate this tumor from the 7th nerve, it will never come. That is the most important message for a young neurosurgeon operating a large vestibular schwannoma. So you can see the tumor is in the subarachnoid space. This is again from Kono only. He has only taught me all this. This is another important concept. And this is one case which we operated in All India Institute at Bhopal. If you see carefully in this heavily T2 weighted image, you can see the subarachnoid space. Can you see, appreciate it here? T2 weighted, it is showing a CSF all around. Just to make the point, to prove that it is a subarachnoid origin tumor, which we operated at AIIMS Bhopal. A very good picture. That is why I took it. But does it always hold good? Is it always subarachnoid in origin in the canal? It can arise sometimes outside the canal. Sometimes it can arise from the cochlea. It can arise from modulus of the cochlea, otic. In these rare, very, very rare circumstances, these tumors arise epiarachnoid. Otherwise, our routine 98% of the cases, it is arising in the subarachnoid space. And this yesterday I showed this, always, in vestibular schwannoma, there is no arachnoid, which separates the tumor from the cranial nerve 7th, 8th, while always a petroclival meningioma. Always you have arachnoid to help you. So between the two, a same set, it is vestibular schwannoma, it is more difficult because there is nothing to help you. And this is a publication which we had from Chitrajanal Institute. This is a vestibular schwannoma. This is, you see this heavily weighted T2 weighted images which will show a microhemorrhages, which is a hallmark of vestibular schwannoma, which will not be seen for a meningioma because this is something. Even you can see a myoinositol peak for a vestibular schwannoma. Look at this tumor. This is a meningioma. It is also centered on the IAM, which mimics a vestibular schwannoma. This will look like a vestibular schwannoma because it is also extending into the canal. But there won't be any heavily T2 weighted image. There won't be any microhemorrhages. And it will show an alanine peak sometimes. So this is some differentiating other important things. If you see something in the canal, you should always look for a facial nerve. This is facial nerve schwannoma. So you can see enlargement of the facial canal, and it actually geniculate fossa gets enlarged. So these are some of the things which have come now for young neurosurgeons who are likely to operate on smaller tumors with the idea of preserving 8th nerve function. So this is something which has come. If there is increased signal intensity, usually you see in cochlear fluids, which if it is absent on T2 weighted image or a FLAIR image shows a hyperdensity, that shows that that patient, in spite of having hearing, very unlikely you can preserve hearing with surgery. And these are some of the things which neurosurgeons should definitely see for a high jugular bulb or pneumatization of the bone to decide your surgery. And now, what is the philosophy? Philosophy of vestibular schwannoma has changed tremendously. So when I was in Chitrajanal Institute, we used to see large tumors only, no small tumor. So our thing was to preserve a patient's life only. And after that, if we to try to take it out in toto, then comes 7th nerve, never ever 8th nerve. So it was like that only. Now it is only functional results are important. People are the mortality, their focus is no longer the surgery we are doing for reducing mortality. It is for functional preservation. So these small tumors, you have all these gadgets. Vestibular schwannomas, 50% of the vestibular schwannomas, they don't grow. That is why in 70 up, I told the incidence of vestibular schwannoma is 20 per 100,000 patient years. That means many of these oldies who are getting investigated for non-specific headache or some head injury or whatever it is, they will have a small tumor. Doesn't mean you have to chase, because 50% will not grow. They remain like that. So that is what you should be very judicious. Say if hearing dips or something happens, only then only you should open and suggest some gamma knife or something. Otherwise, you don't have to do anything. So the presently tolerance to cranial neuropathy is extremely low. Nobody wants a bad face. And we have to preserve all this if possible. So that is a cornerstone of treatment, even for larger. So no complications. That is what people want now. But how about large tumors, which is my talk? Say excisional cure used to be the goal. That is what we used to do. But now they want, they are not bothered about the excision. They want preservation of function. So we have other modes. So to preserve that, and these are some of the things which is difficult for a surgeon. If suppose somebody has a bull neck or a posteriorly placed, short neck people will have a posterior displaced sigmoid sinus. Very difficult to then do a retrosigmoid approach. Highly vascular tumor is always difficult. If it is polylobular, difficult. Pile breach I showed. Pile breach is a single thing on MR which shows that surgery is going to be difficult. And always cystic tumors, I will show some video. They are seemingly easy but extremely difficult tumors. So large vestibular schwannoma observation is never an option. It is decompressive surgery, decompressive surgery, decompressive surgery. Not excisional cure these days. So surgical concerns, I told you in Indian scenario, we have to save patient's life first. And after that, come to this function. So neurosurgeons must be very careful not to turn cure into something worse than the disease. I have had a patient, a young staff nurse with a large vestibular adenoma came to Chitra, around 30, 35. I said, "Boss, you are going to get a facial palsy, such a large tumor." That time I have seen preserving seventh nerve. Preserving seventh nerve doesn't guarantee function. So I told you are going to get, because they get referred, they said you go to him, he will preserve you. And then she said, I want discharge. I said, please go. Next day she got readmitted and got operated. But they want tumor to go out also. So most important thing in vestibular adenoma surgery is location of seventh nerve. It's very, very unpredictable. It can be anterior, superior, all anterior, just dead anterior, anterior, superior, anterior, inferior. Never ever posterior. And these days we have this DTI imaging which can predict the seventh nerve relation to tumor, even though they can predict, but there is no correlation till during intraoperative. People have found that they predict, but no intraoperative correlation. This is what present DTI. You can see the seventh nerve. This is a simple thing which you can do. This is a presentation publication from Korea. So this is the internal auditory canal. And this is the tumor in the CP angle. You draw a perpendicular this is a long axis, you draw a perpendicular through IAM. If this angle is acute, facial nerve is in front. If this angle is obtuse, facial nerve is down. So this is a small thing which has come from Korea, which is reasonably correct. And these things have helped us, this monitoring. I told just the previous talk that poor monitoring is worse than no monitoring. But this is a big guide to whether we are nearing the seventh nerve. And important thing is to preserve hearing. You should know whether the labyrinthine structures are inside this, fundus sinus line. If these labyrinthine structures are inside, it is very difficult to drill without losing vision. This also is a standard. We use this lacy as incision. I was teaching all the residents, they know. And key thing is this asterion. And this is a lacy as incision. And this is the thing you are seeing, the cerebellum, petrous face, sigmoid sinus, transverse sigmoid junction. So what we do is, this is the transverse sinus, this is a sigmoid sinus. If you can expose this transverse sigmoid junction, you can retract this dura more laterally. So you will get, this is how you should make a burr hole 1 to 1.5 centimeter lateral to the asterion, to come lateral to the transverse sigmoid junction, and then identify and then expose that area. So this is a sigmoid sinus, and if you retract like that, say retract the sigmoid sinus along, this is the view you get. So it will avoid much retraction, again a larger view. So why retrosigmoid approach? All the 835 cases I have operated with retrosigmoid because it can address all sizes, tumors, brainstem. You have control over vessels, everything. And magic mantra is there is only internal. First step is internal decompression. Second step, internal decompression. Third step, internal decompression. Everything is internal decompression. Once first you peel the double layer, then keep on decoring 360 degrees. Once the tumor capsule falls, you cut again, peel, decompress, and like that way. Otherwise, without decompressing, never wander outside. So this is, surgical steps. This is what I have to tell. This is acoustic which we are operated just to prove the point that these tumors are, there is no arachnoid between the tumor and, oh, what is happening? Correct time, it won't work. It is working. So here, what I have done is I have decompressed the tumor. CP angle part I have decompressed. I have kept bone wax over the cerebellar surface. This is in the event the drill slips, this wax will help. Sometimes it will slip also because it's useless, in institutes and all gone. Still we have to use that burr only. So when you use that, you have to keep these things will protect. So now I am taking the tumor from the canal. Now the nerves have started appearing. If it is a epiarachnoid tumor, you would have seen arachnoid over the 7th, 8th. It is not there. I am delivering the tumor inside the canal to the CP angle area. I will run it little fast so that now dissection starts at Now the main concern is to how to, now this is the CP angle part of the flattened seventh nerve. Here you see the internal auditory canal. You have to connect that slow, meticulous, sharp dissection. You can take this thing without, again, that. So this is a SS forceps. So this was our Professor Kano only asked me to buy this, and you can very sharp dissection. You can come into the dissection plate. It costs some $100–150. You go abroad, you should try to get from these forceps, SS forceps it is called. So you can remove the whole tumor. This is a flattened nerve. Ultimately, the whole tumor has come out. And let me tell you, this is this patient with 4 or 5 centimeter tumors. Every patient will have some degree of facial palsy. Even if you preserve, it is not that they tell grade 1, it will never occur. Everybody will have varying degrees of facial palsy after surgery, and they recover. They should, most of them will recover to some extent, not totally. Yet another large solid tumor, just to prove the point that these tumors are subarachnoid in origin. So this is, I have decompressed, and this is a flattened 7th, 8th nerve. All the tumors are right-sided tumors. So your 5th nerve will be to the right, lower cranial nerves to be to your right. 5th nerve is to your left. So here 5th nerve is inside this pit. So I know if I dissect slowly, these nerves will follow. So let me see. I will show you all the nerves. So here we can see the 6th nerve. You just saw the 6th nerve there. Lower cranial nerves are here. Here in this pit is the 5th nerve, separated by another 5th nerve is there. So it is separated, everything is separated by a cistern. It is not one cistern, and there is no arachnoid which is separating the 7th nerve from the tumor. If at all you see a membrane like that, it is the perineurium of the tumor, which mimics like a arachnoid. So let me come out. This is this patient again having subtle facial weakness. This is at another patient, just to show this was operated long back. This is operated in 2009. But still, another way, this is again sharp forceps. You have to dissect the arachnoid. Let me run it little faster. So this is drilling is going on. So you take out the tumor, and I'll run it little faster. Now you have started seeing the 5th nerve, 7th, 8th nerve, lower cranial nerves are down. Tumor is a right-sided tumor. You can see the petrosal vein. Petrosal vein is always in front of the 5th nerve. So 7th, 8th, lower cranial nerves down, other vessels. So if you do this meticulous dissection, you can get into this nerve. You can see the nerve very well. This is at another tumor. Let me see what is here. This is for, let me see. I just want to show you ICA inside the bone. Say ICA vessel can sometimes be inside the bone. Then you have to dissect it out. I don't think this is that one. Again, you can see the, this is the, I'm not very sure. This is a 6th nerve, 7th, 8th here, 5th nerve here. Lower cranial nerves are there. So you can see the vertebral artery or some artery there. So, so this is at another tumor. 7th nerve is pushed down here. That is why I wanted to show lower cranial nerves you are seeing here. I just want to show how to take out ICA. ICA from the no, this is again 7th, 8th, we are seeing 6th, we are seeing, I'll skip, this is not, this is the video. Here, this vessel can sometimes insinuate through the dura, into the canal. This is ICA, so you have to, first you have to drill that and take the ICA out from the bone. And then only you start here, I can see the premeatal, postmeatal loose with the tumor inside. I am taking that ICA out. And then proceeding with surgery. So it is mandatory. This is the ICA there, which has been reflected down. After that, you remove the tumor. So you can see all the vessels, nerves there. Let me show you 7th, 8th nerve where it is. most important point is there is no arachnoid which separates the tumor from the seventh nerve. That is most cystic acoustic totally different thing. Cystic acoustic, I was just telling the residents, they are present with short history. Normally acoustic neuronomas grow very slowly. It's around 2 millimeter a year. So that for some tumor to become 2-3 centimeters in size, it will take many years. But cystic schwannomas, they grow very fast. Hearing may not be the first manifestation. It will be loss of taste, dysgeusia or walking, disequilibrium. Hearing may not be the first manifestation, but it can come. They're seemingly easy, but it is very difficult tumor to remove. They come back, they recur. So they have atypical symptoms and they are usually large, they present with bleed, like what you see here. And this is, I think I have one video to show. I still have few minutes left because I think I am still on course only. Don't worry, I won't overshoot. So, because everybody must be waiting for. So same principle is same. You can see all vessels. You can see labyrinthine artery also here. So this we have started seeing the nerve here. Let me show you the labyrinthine vessels. I don't know. This is a chunk of tumor is left there. This is, you are seeing the fifth nerve inside. Fifth nerve is inside. Seventh, eighth is here. If some tumor is left in the meatus, now you can start seeing the seventh nerve, it will appear. That is the seventh nerve starting appearing. So fifth is up there. And this is, I don't know, a little confused. Maybe this is the seventh nerve. I am not very sure now. Okay. So now how about bilateral vestibular schwannomas? Bilateral vestibular schwannoma is totally different. So finding a bilateral vestibular schwannoma, it doesn't mean you should operate. It is, wait for things to evolve, how it evolves. Once the tumor starts becoming, because any hearing is a boom. Because, if you have somebody who is blind and somebody who is bilaterally deaf, the bilateral deaf person will commit suicide. Blind fellows, they still live. That is the thing. So deafness is a big disability. So if a bilateral acoustic fellow comes, if they have any hearing preserved, just observe, don't do, because whatever you do, you may not be able to save, the hearing will go. It is called procrastination. Just wait for something to evolve. How it evolves, if the patient tumor becomes big and start compressing the brainstem, then you have to open your eyes, even if hearing is preserved. Or if the hearing starts dipping, you can send for adjuvant treatment. So this is one of the things. This patient came to us long back, sizable tumor. You can see enough2. Other large tumor, we advise surgery. And we told that there is because here unfortunately the smaller size patient didn't have hearing. Larger size patient had hearing. So we were in a fix whether to go. Here this patient was deaf. And this is the thing. One was deaf, other is hearing was preserved. We suggested surgery, patient was not willing, kept on follow-up, started developing hydrocephalus. It close to became 4 centimeter. And then the other side also. This is the deaf here, and here also hearing started dipping. Then we convinced surgery, and this is, my only aim is to, in that patient was to preserve her facial function. And ultimately I could preserve her facial function, not only facial function, but also some hearing also was there. Not moving. Okay, just to show that I could preserve that 7. You can see trigeminal 7th, 8th. Trigeminal is inside in some pit inside. All are right-sided tumors, so there is no confusion. This is 5th nerve, 7th nerve, lower cranial nerves down. So there is no arachnoid. This is a post-op. This is the hearing still retained there. Patient has relatively good facial function. Some of these unfortunate tumors, bilateral is like that. They have spinal tumors. So here also, we keep on chasing. If they become symptomatic, big tumor removed from here, removed from the other side, then trigeminal schwannoma came, then shunting. And so then this is the patient, multiple surgery, very unfortunate patient, lucky patients. So you remove enough this large tumor, they have very subtle facial weakness. And this is a very unfortunate thing. This patient came with a small tumor, already had facial palsy. After surgery, other side also developed facial palsy. This is a very unfortunate thing. We send for all reanimation procedures. So the preserving seventh nerve doesn't mean that guarantee. Facial nerve function, we wait for 6 months or sometimes up to 1 year. And if it is not recovering, we send them for secondary treatment. And this is something which can offer facial hypoglossal anastomosis. And this is sometimes, as I was telling the residents at both the places, this is something, this is the only case in that 835 where the vertebral artery was cut. Vertebral artery was cut by, I should say it is my case, it's myself cutting only, but resident operated. He cut. This is so you should never become panic once you cut the vertebral artery. So this is already cut. I will show you that how the blood is coming. This anyway, by what had happened is I am not an anastomotic surgeon like Dwaraga. So what I did, this is how it started bleeding. We didn't get panic. There is a lesson by Duke Sampson. If something ruptures, like aneurysm ruptures, you should never get panic. You should just believe. First, you should pray to God, so nothing should happen. Second thing, what Duke Sampson has written, nothing has happened to the patient, don't worry. But your next wrong step will kill the patient. So you should keep calm. This is how it bleeds. Medical people who have not seen blood, this is how blood looks like in the field. So what I did, I called my anastomotic surgeon, our Girish Menon. No, so I said, Girish, can you just mobilize and see whether you can do anastomosis? He did. He did anastomosis, and this patient we discharged, called after 3 months, and then operated. Patient did well. But after that only I read that if vertebral artery is lost there, better to sacrifice, because sometimes your anastomosis all can give away. So that is also written. But this patient did very well. And operative mortality of this is Professor Same has written, should be below 1%. And touchwood, I had 1.07, because in Chitranal Institute we get large patient, at least 3-4 are not due to my surgical thing, they had various other problems. Biggest problem is patients developing vagal nerve weakness after surgery, large tumor. Upfront tracheostomy myself. I never used to keep them waiting, coughing next day. I know that I have not damaged a 10th nerve. Because I know if I give some rest like that, I do upfront tracheostomy. And then after that, when the function improves, after 1 week or 2 weeks, I close the tracheostomy. Principles are arachnoid peeling initially, and then intratumoral decompression. It should never coagulate over the tumor surface. Then you lose the plane, everything. And 360-degree decompression, circumferential dissection, intrameatal removal after that, and always meticulous hemostasis. The postoperative hematoma is not from arterial bleed most of the time. It is from venous bleed. Because, when you do proper surgery, you have closed, there's no problem, you close. But you don't give that Valsalva maneuver. Once you give Valsalva, sometimes some closed veins will open. Post-op, what they give, suction, everything, ICP, they can develop some hematoma. So you should do meticulous hemostasis, including anesthetist to do Valsalva maneuver. They should not give a big Valsalva, because otherwise cerebellum will come out. So ask them to give a small Valsalva and see. And this is one person, this is correctly what he has written. Say acoustic, you should never fear anything. First time you do, you will keep on doing. And you should believe you can do this surgery. It is a very tough surgery. And on a joking note, I will tell I always ask people, which is the difficult surgery? 4.5 centimeter acoustic or 4.5 centimeter petroclival meningioma, real petroclival. One I told you there is a arachnoid plane. Other I told you there is no arachnoid plane. That itself gives you some answer that vestibular adenoma could be difficult. It is both are difficult. The difficulty is, the thing is, if you are, how you can solve is, the thing is, morning you get up, you are better off, will tell. before you go to the hospital, you clean the place, take kids to school, bake breakfast like that, it will keep your mood off. So you should, so if you are better off, it could be either husband or wife. If you are a female surgeon, husband will tell, or vice versa. So you should get out of the house before your better off gets up. And go and do the surgery. And otherwise, whichever day your better off is asking you to clean the house before going to theater, that case is difficult. Both are difficult. Vestibular sarcoma is more difficult. I think I have to end now. So large and giant vestibular sarcoma message, no arachnoid, which separates the tumor from the facial nerve. That is a message which I want to give. And these are some of the publications which we had on vestibular sarcoma from Chitradenal Institute. And some have been accepted also. Very nice. You can read some of the present. And his cousin is meningioma in the angle. There also we have some publications. And this is something, we wrote something some time back, how we advanced in vestibular sarcoma. And this thing will come, this is written again by me, but Matthew Abraham is a single author, first author. So you read everything about the techniques you get. I think I thank you all for kind attention. And again, my sincere thanks to Timmappa, Komal, and all the team, Kiran, Shibu, and all of you for inviting me and allowing me to give this prestigious oration. Thank you all. I have still 2 minutes left. Okay. Sorry. 1:30. Okay, I'm sorry. It took so much time. Thank you.
Thank you, Professor
Thank
Suresh
you.
Nair.
I'll take it.
As usual, very lucid, honest learning which has been handed over to his students. I think the neurosurgeons of Bangalore had an occasion in the last 15 days, 2 giants in skull-based surgery of India, Professor M.K. Mishra and Professor Suresh Nair have come over here and delivered their experience. It's like Krupacharya and the Dronacharya of skull-based surgery. And I can vouch, as he said, I've seen his complete neurosurgeon. What I always call Professor Suresh Nair as a physician neurosurgeon, means he has understood what he is doing and he knows what he has to get out of it. And his experience has been the growth of microneurosurgery, especially in treating skull-based tumors of meningiomas and schwannoma. Sir, thank you very much. Once again, enthralling all this crowd and teaching. Most important, you are learning, you are transferring to us. Thank you very much, sir. Yeah.
Your meeting is coming. Yes, sir. It is the pretty blank.
I encourage everyone to now proceed for lunch.
Hello. Lecture I will call. This is all great. Definitely, it's a free learn. It's a free learn. That is why I love all these lectures. It takes so much pain for somebody to come and deliver a lecture and pass it. So even for people who live with suddenly,
Three months senior. I'm May born, you are 1 month.
Right, yeah.
Same.
Thank you so much.
We are contemplating.
Absolutely. So I just wanted to ask you, so, there is one journey of. Hi. Very nice.
So this is a good idea.
Yes. Hello, sir. My name is Sharad, sir. Hematology. When you said blood, I was very happy. Decompression. Get out of the house before the spouse wakes up.
If I take the art, it's called work. I don't know what work is.
Other thing is, if you have to do a major procedure, get out of the house before better off gets up. Because sometimes our mood will go. It applies to madam also. Suppose in the morning, madam, your husband tells you make this thing, they give me something, and you are busy, you are too busy. And suddenly some order will come. And then you cannot tell, no, I cannot do like that. That is why it is very good. So if you are, it is a difficult problem, don't get more problems before surgery. Okay. Puja. Take a picture. Take a picture.
Yeah, Mike.
I saw you taking They would have sent you a light there in Mumbai.
Hi, Sharat. Very sad.
So you came yesterday or today?
Yesterday to today. Past midnight, my flight came because it was late. I came from Kochi. I had a Indian Academy of Pediatric board meeting at Kochi.
From there you came.
I came. It was a 9:15 flight. It took off only at 10:30 or so.
So hectic there.
So now I.
You better go and crash out.
No, but
Go and
your
crash out.
lecture is here, no?
Ours is all myeloma, lymphoma, that kind of thing.
lymphoma. I will attend this too and
And
then
then
crash
you'll go
out.
to. You are here to remember.
I am staying, Baba. I can't travel every night. I'll be mad if I
You need
travel.
a break, total break you need. Oh, good.
Tomorrow I will.
Nice. I'll just load my presentation and come back.
Sure. This one.
The box is there. You want my card or something else? Just keep this. ಸರ್ಗೆ ಕೊರಿಯರ್ ಮಾಡಬೇಕು, ಕೊರಿಯರ್ ಮಾಡಬೇಕು, ನೀಟಾಗಿ ಪ್ಯಾಕ್ ಮಾಡಿ.
ಇದೆ ಅಡ್ರೆಸ್
ಫೋಟೋ
ಸಾಲೆಲ್ಲ ಸ್ವಲ್ಪ ಇದೊಂದು ಸ್ವಲ್ಪ ಡೌಟ್ ಆಗುತ್ತೆ.
ಸ್ವಲ್ಪ ಫೋನ್
ಹೋಮ್ ಮಾಡಿದ್ರೆ ಸ್ವಲ್ಪ ಇದರಲ್ಲಿ ಕೊರಿಯರ್ ಸ್ವಲ್ಪ
ನೋಡೋಣ, ಅದು ಸಪ್ರೇಟ್ ಬಾಕ್ಸ್ ಹಾಕಿ ಮಾಡೋಣ.
ಈ ತರ ಬಾಕ್ಸ್ ಮಾಡಿ ಫೋನ್
ಇನ್ನೊಂದು ದೊಡ್ಡ ಬಾಕ್ಸ್ ಹಾಕಿ ಒಂದು
ಎಲ್ಲ ಒಂದೇ ಬಾಕ್ಸ್
ಕಳ್ಸಿ. ಇಷ್ಟೇನ ಇರಪ್ಪ ಅಥವಾ ಬೇರೆ ಏನಾದ್ರು ತಗೊಂಡೋಗ್ತಾರಂತೆ? ಓಕೆ ಸರಿ. ಕಾರ್ಡ್ ಇದೆ. ನಾವೇ ಹೇಳ್ತೇನೆ, 3 ಜನ
ಏನು ಪ್ರಾಬ್ಲಮ್?
ನಾನು ಫೋಟೋನು ತೊಗೊಂಡಿದ್ದೀನಿ.
ಮನೆಯದು ಅಡ್ರೆಸ್
ನಾನು ಕೊಡ್ತೀನಿ. ಅಡ್ರೆಸ್ ನಾನು ಕೊಡ್ತೀನಿ.
ಫೋಟೋ ತಗೊಂಡು ಮೊಬೈಲ್ ನಂಬರ್
ಫೋಟೋ ತಗೊಂಡು ನಾನು ಅಪ್ಡೇಟ್ ಮಾಡ್ತೀನಿ ಒಂದು ಮಾಡ್ತೀವಿ ಡಾಕ್ಟರ್. ಒಂದು ಸೆಷನ್ ಸ್ಟಾರ್ಟ್ ಆಗಲಿ ಮಾಡ್ತೀವಿ. ಪ್ಲಾನ್ ಮಾಡೋಣ, ಏನೇನೋ ಕಳ್ಸಿ
ಬನ್ನಿ. ನಾವೇನು ಎಂತೆಂತ
ನೋಡೋಣ. ಇಲ್ಲ ಅದು
ಮೇಡಮ್
This I'll manage.
खोलो इसको पासवर्ड।
Welcome back. Welcome back everyone to our afternoon session. For this session, we have three chairpersons, Dr. Sharad Damodar, Senior Consultant and Head of Department of Hemat-Oncology and Transplant Services, NH, Dr. Arivagan, Professor of Neurosurgery, NIMHANS, Bangalore, and Dr. Shobha B, Senior Consultant Pediatric Hemat-Oncologist. I request you to please take your places on the stage.
Proceed better.
Good afternoon. After the lunch, we're going to have our first session by Dr. Sharad Damodar. The topic is neurological manifestations of myeloma, when to intervene.
Thank you, Dr. Shobha. And let me start off by thanking the organizing committee, Komal Prasad and his team for putting this wonderful meeting together and getting everything connected to neuro-onc discussed, I think, over the last day and a half up till now. Post-lunch sessions are difficult, but I'll do my best. I'll keep it short and sweet and just quickly run through the role of the neurosurgeon in the hematology patients. And there are two areas where they would actually come into play. One is in the myelomas and second is in the lymphomas, which is the second talk after this. So I will briefly just run through the interaction between hematology, hem-onc and the neurosurgeons. So myeloma is a disease which I think in today's world is pretty well known. It's been there since antiquity. From 1500 BC onwards, there's documented lytic lesion, which is the hallmark of any myeloma. Most of us in today's world would know somebody, friend, family member over a period of time afflicted with this disease. And it's a very slow growing disease most of the time. You have an aggressive myeloma called plasma cell leukemia, which is a rarer thing, but most of the time it's a slow growing thing. And earlier we never spoke about potential long-term cure rates or long-term control. That has changed. This is another picture to show you the effect of plasmacytomas, which is another unique thing related to this disease, where you have a lot of these lesions coming up, and sometimes in various parts of the body, they can produce neurological issues, and which is of relevance in today's talk. Now, where does the surgeon come in? So obviously upfront, even if I bring up a surgeon to any of our patients, it's a scary picture they have. They certainly don't want to go under the knife. Now, myeloma patients could also present onto the neuro or the neurosurgical side with some of these symptoms, typically back pain, bone pain, and then you pick up anemia, ESR. Elderly person has some lesion in the spine, there's a good chance you would make this diagnosis once you actually investigate it. So just to put things in perspective, I'll just run through a case which is from our own institute on how he actually presented first to the neurosurgery department. 52-year-old male evaluated for neck pain radiating to the left hand and shoulder, 3 months duration tingling numbness, some urine bladder symptoms, no other systemic symptoms, a lot of negative history there, which I won't really run through. And this is the image which was discovered when they imaged him under neurosurgery. Okay. Clearly there's a lesion there, which is producing compressive symptoms there. This is the cross-section view. And this was reported as a well-defined lytic lesion involving the C7 vertebra and producing collapse of the vertebral body. And there's retropulsion there and some amount of cord compression. And you can also note that there's another lesion also at T2. And in the T2, T3 region, telling you that there's something which is beyond just a localized event there. There's something going on, which is more than that. This is what the neurosurgeons did. I mean, to you all, I don't have to explain what this is. So that's a titanium plate put in there and they fixed it. So kind of immediate problem solved. Subsequently, further evaluation revealed that there's anemia. Like I told you, ESR is another hallmark in myeloma, which we chased. The protein was high, creat was normal. This was the M spike. This was the kappa lambda ratio, clearly showing you the excess of kappa. Bone marrow done, 35% plasma cells, and an additional PET done showing multiple lytic lesions. So straightforward diagnosis, but this patient presented first to neurosurgery and not to hemat. Now there are a lot of celebrities involved who are diagnosed with this disease and probably haven't had so much of complication, but for an individual family or friends, that particular patient is the celebrity they want to take care of and make sure that they do well. Now, just to quickly run through the basic teaching of myeloma, you've got plasma cells, lytic lesions, the M spike, which is all standard. Some of it can come up initially as a monoclonal gammopathy alone, which then progresses to myeloma, or it can just present straightforward as myeloma. There's something called smoldering myeloma, which is defined as a little low grade before you get a full-fledged disease. And thereby, you really don't treat, you just wait and watch in that particular setting. There is something called crab features. You could see that most of cancer is depicted as a crab, and this truly, you've got an acronym for that. Hypercalcemia, renal disease, anemia, and bone lesions. So these are the features which are defining events to treat from a systemic perspective, in addition to whatever localized problem you had. Diagnostic criteria for myeloma, there's a big list. I really won't go through this because this is standard things which are done. The newer definition of myeloma actually encases the additional definition of more than 60% plasma cells and the kappa lambda of more than 100, which was the case in this particular patient. So straight away defining myeloma, which requires treatment. There are stages which are described to basically prognosticate on how the outcome is. And these are survival curves. This is about 10 years back, these were the survival curves. But things have then changed from then to more recently, where newer drugs are available for the treatment. So the basic of treatment of myeloma is primarily chemotherapy. There is a little bit of radiotherapy and surgery involved, and because there is some component of surgery involved, we're discussing this today in the Neurosurgery Symposium. Lot of new drugs which have come up. A drug which was initially discarded due to problems during pregnancy called thalidomide has come back in a big way, and we've got derivatives of that. We've got a lot of the other drugs, including a monoclonal antibody. And in today's era, there's a lot of talk of immunotherapy. There's something called CAR T cell therapy, which has again come up in myeloma, which is almost now become a curative option. So the idea why I'm highlighting all this is it's gone away from a low-grade disease where you didn't get survival more than 3 to 5 years to chronic disease 10, 15 years and potentially talking about cure. And that's the reason why if there is something which requires surgical intervention, we want to do it because you may potentially be actually curing that patient. So we don't want to hold back. There are drugs which will help to reduce the incidence of bone lesions and bone destruction. You've got all the donates here, the bisphosphonates, and you also have denosumab, which is a monoclonal antibody, which is against the rank-1 ligand. And these are all drugs which are very useful to cut down the osteolytic activity. Now, treatment options, like I mentioned, things have progressed. If I just go through my own, medical cycle from my MBBS days, where we were only doing just a little bit of 3-year survival talks with very few drugs, then things got better when we started doing transplant. And now we've got a lot of new drugs and potentially talking about cure with the onset of things like CAR T cell therapy. So clearly the horizon has improved in the landscape of myeloma. So where do the other two options come in? One is radiation, the other is surgery. So clearly this is for localized disease when you've got a problem and you want to sort that out. And that's where one of these two modalities of treatment would come in. Radiation is more frequently used when you have a plasmacytoma which is sitting there producing pain or compression, and surgery when there is something like instability of the joint. So there are clear-cut guidelines and indications on the requirement of surgery. And clearly the top three is what I want to highlight here: spinal instability, a pathological fracture causing compression, progressive impairment of neurological function, straightforward indications for a surgical intervention. Rarely, sometimes it may be intractable pain, which even does not respond to radiation, where you might require a surgical intervention, a rare indication. These are softer indications which are more primarily to get a biopsy or tissue diagnosis. There are relative contraindications for surgery, some of which may be the debilitated state or comorbidities which the patient has. All this is generally controllable, including a coagulopathy, which can be handled in today's world, may not necessarily be a contraindication. Now I'll just move on to more into the neurosurgery angle from the hemat side. This is from our own publications in reviews in oncology, management of the cord compression myeloma. So the basic disease pathology here is increased osteoclastic activity and decreased osteoblastic activity because of the release of a lot of cytokines, both from the marrow stroma and from the myeloma plasma cells. This is what produces lesions either in the body of the spine, in the vertebral body, spine, or as a separate soft tissue plasmacytoma, causing encroachment on the cord and producing symptoms which require intervention. Again, some pictures of interventions which have been done, which is what was done in this particular patient. And as a result of this, we've got a clear-cut algorithm on what we do from a surgical perspective. When do they actually come in? If there's cord compression with neurological symptoms, yes. Initially, we would certainly give steroids. Then look at spinal instability. If it's stable, you look at radiation. If not, then retropulsion of bone fragments, yes or no, decompressive surgery or spine stabilization. So this is where we would bring in the neurosurgeons to take that call on what modality of surgery they would actually recommend. Otherwise, a lot of times we would just get away with just steroids and radiation. Now, clearly there is a spinal instability neoplastic score, which is well defined, called SINS. This has also been run through a lot of the residents and fellows in various institutes, and thereby authenticated. And this is routinely used in a lot of these scoring mechanisms, where they, based on the location of the lesion, presence of pain, bone lesions, radiographic features, and vertebral body collapse, you can score that individual patient based on the score defined between 1 to 6 is stable, or anything beyond that, potentially unstable or unstable, wherein the surgical intervention is kind of indicated. Now, I'll come to this last part where we're actually talking about data from the Neurosurgical Journal, where they looked at people presenting to the ER with a spine compressive lesion requiring emergency surgery. And this is from a database from the university in Miami in Florida, over a period of about 22 years, where 43 documented cases who underwent emergency spinal decompression. Okay, so this is interesting data, which they collated over a period of time and analyzed this. And to their surprise, they found that a big chunk on this, 50%, the lesions were primarily because of myeloma or plasmacytoma. So this is interesting data to see with somebody coming in cord compression, 50% of the time you're most likely to make a diagnosis of myeloma or plasmacytoma. And this was the subsequent breakdown demographic data there. And when they looked at the indications for the surgery, about neurosurgical deficit was the highest there in the neurological deficit in the myeloma subset. And again, spinal instability being a big chunk in the patients who had myeloma compared to some of the other metastatic lesions which also produce like this. So this is a good learning point for us that somebody coming in with a spine lesion requiring surgery, you certainly need to watch out and chase for a diagnosis of myeloma, because after that intervention, with whatever else we are able to do, we may be actually taking that patient for a long-term cure possibly in today's world, and thereby we don't want to hold back anything to compromise quality of life. So we want to do our best at that point in time so that he gets a reasonably good chance of reversal of that or prevention of further neurological deficit and go on to a normal quality of life subsequent, because there are treatments which can totally reverse this. So this should be my last slide. I will end here. This is the institute where we're practicing. I'm thankful that we've got a very good neurosurgical team who actually help out with a lot of our patients. And thanks to them, we've been able to salvage quite a few of our patients who've come in like this and who have gone on to actually take additional treatment and even proceed for an autologous stem cell transplant, which is the standard of care now. And then currently we have a potential that they may even reach CAR T cell therapy. So on this note, I'll end. Thank you. If there are any questions, I'd be happy to take them. Thank you.
Thank you, Dr. Damodar. Can you hear me? Yeah, thank you for the nice presentation, short and sweet, as you said. So from a neurosurgeon's perspective, I have a few questions. So we see these lesions, or we keep multiple myeloma as a differential. When we see a lesion in the spine, it may be either a primary bone lesion or a lesion involving bone with an extradural soft tissue mass. So my question to you is, should this lesion always show itself in the blood picture, or even if the blood is normal? I mean, my question is, if there is a lesion in the spine involving bone and soft tissue, and if you do all the blood workup, if the blood workup is normal, can we safely rule out myeloma or not?
Yeah.
When the lesions are multiple, life is simple.
Yeah,
Okay, multiple lesions, only
Indeed.
multiple myeloma or metastasis.
Correct.
If it's a single lesion,
you want to change that.
How common it is to have a myeloma with normal blood picture?
So there is this entity called a solitary plasmacytoma. So that's the situation where sometimes if it's very early localized, it will not have enough of paraprotein getting secreted to manifest in the blood test. So our logic is when we make a diagnosis of myeloma, the criteria which I put down like anemia and ESR and all of that is when the marrow is involved and there's a production problem and thereby you drop HP. But if there's a plasmacytoma just sitting in the spine, that is not compromising your normal blood function. So your blood count will all be normal. They will only manifest as pain. And sometimes if there is adequate secretion of the paraprotein, you will pick that up as an elevated protein and an elevated ESR, because that paraprotein contributes to the ESR going up. So this is a subtle thing to say that this is a plasmacytoma which is secreting. But sometimes if it's very early and not enough paraprotein has got secreted from there and it's a single lesion, then without a biopsy, there is no other option than to prove that. So we would at least recommend doing a tissue biopsy for a single lesion. If there is a decent tumor burden there, we will pick it up on the blood test, at least as a paraprotein. There's another smaller entity which is less than 10% called a non-secretory myeloma, where you may not get the kappa laminar light chain. So I would still say yes to your question there. That is why we push for that biopsy.
Yeah. Since it's a learning session, I want to narrate a patient which we had treated about 3 months ago. Similar picture. Elderly lady, multiple lesions in the bone. One of the vertebrae have collapsed. Our diagnosis was metastasis. Got full workup for metastasis. Nothing turned out. So, like I said, my differential were either metastasis or multiple myeloma. She underwent surgery, decompression of the lesion, and fusion. And biopsy report was only bone. We did not find any neoplasm. So then we asked an endocrinologist. That patient had very high calcium levels. And then she said, this is hyper. In fact, the first doubt came from a radiologist. A radiologist said, we have to look for hyperparathyroidism.
Yeah.
Calcium levels are high and there's a lesion. Till we got a negative biopsy report, we did not think of anything other than malignancy. Even with our pathologist review, our Dr. Vani said, there is no tumor in this. It's only a bone. Then she turned out to be a small adenoma causing hyperparathyroid secretion. And she underwent surgery for that, and now she's better. So this is something which we learned after so many years. These are rare, but these are something which we should remember for lifetime. All tumors, all lesions in bone need not be metastasis. Sometimes they need not be tumors itself.
Right,
And
right,
increased
absolutely.
calcium is not only due to myeloma.
Myeloma,
There's
right.
another disease you should remember. Hyperparathyroidism, a small hyperparathyroid adenoma can present with a similar picture.
Absolutely.
Please correct me if I'm
absolutely.
wrong.
Yeah, no, absolutely. And we've also seen this very rare. You know, when you start chasing the hypercalcemia, the first thing obviously all of us do is chase myeloma. And then when your entire workup, including your PET, everything comes back negative.
This
that's
lady
when-
underwent everything, including PET MR, M-band, everything in
Possible in
fact,
the
referred
workup.
as myeloma.
Right.
We got this, sent the patient back to Kidwai. They did workup, they gave a single line, this is not myeloma, you treat further.
Right,
So we had to
right.
do biopsy, and
And
biopsy
then
turned
to-
out to be normal bone, I mean non-neoplastic. We were literally at the end of the tunnel. Then
Parathyroid
multiple
normal.
discussions, and it turned out to be a small PTH adenoma.
Absolutely. Fully agree with that.
Thank you, Dr. Damodar.
Right.
So we'll call Dr. Pragya Koka. Oh, please. Before that, we'll felicit it. Yeah, next we invite Dr. Pragya to talk on update in management of primary CNS lymphoma. Dr. Pragya is a consultant medical oncologist from Narayana Health, Bangalore. Please.
Good afternoon, everybody. So I've been given 20 minutes to talk about a very exhaustive topic. It's primary CNS lymphoma. So just to give you a brief context, and I'll keep this quite limited. So we all know primary CNS lymphoma is an extranodal non-Hodgkin's lymphoma that is basically confined to the brain, the leptomeninges, the eyes, or the spinal cord. So it's quite rare. It's just about 2% of primary neoplasms in the brain, and the primary age of diagnosis is usually 65 years. Survival outcome is actually inferior compared to other lymphomas. When we see lymphomas outside the body, we are actually telling patients that no worries, you're actually going to do quite well. But the survival of CNS lymphomas is not so good. It accounts for only 4 to 6% of all lymphomas combined. So paradoxically, it has actually got quite a high chemosensitivity. It's actually radiosensitive, but yet it has a high rate of local relapse. So let's see what advances are being done for this. So just for the sake of the postgraduates over here, what are the common clinical signs and symptoms at present? So it's varied, of course, and there are focal neurological deficits in about 70% of patients. About 43% of patients have got behavioral and neuropsychiatric changes. So these can be non-specific, and sometimes the diagnosis can be missed. The signs of elevated intracranial pressure, such as headache, nausea, vomiting, they're also quite common. They're seen in about a third of the patients. Because cortex is relatively spared in primary CNS lymphomas, only about 14% really present with seizures. Patients with ocular involvement usually complain of blurred vision, decreased acuity, floaters, visual symptoms, but actual symptoms are quite rare. It's only 4% of patients who come with ocular symptoms, although ocular involvement is seen in about 20 to 25%. That means majority of patients with ocular involvement are actually asymptomatic. The classical B symptoms that we see with non-Hodgkin's lymphomas, like what we call as fever, loss of weight, loss of appetite, they're actually quite rare. So coming to the diagnosis, so diagnosis is mainly two things, radiology and pathology. So to basically assess the extent of disease, what we do is an MRI of the brain, the spine, an ophthalmic examination, and CSF. So the MRI, of course, is a modality of choice, and you have to have a contrast-enhanced MRI. It cannot be a solitary lesion, it can be a multifocal lesion. It's generally periventricular. It involves deep white matter, basal ganglia, and corpus callosum. and the lesion appears iso-intense or hyperintense on a T2 MRI, and they're usually homogeneously enhancing, mild amount of edema, and they're often associated with diffusion-weighted restriction. So this is how you would see a typical primary non-CNS lymphoma. So what you're seeing in the first slide, that is A, you're seeing an axial image of a left parietal lesion. You can see that the diffusion is basically restricted and the ADC is also low. So this is a typical image of a primary CNS lymphoma. Of course, not every lymphoma presents the same way, and there are many variations of this. The second part of the diagnosis is, of course, pathological, and you always need a needle biopsy. So tissue is the issue, like all our oncologists say. So unless we have a biopsy-proven diagnosis, we don't usually start treatment. The procedure of choice to establish the diagnosis is a stereotactic biopsy. And if there is ocular or CSF involvement, we would generally go for a vitrectomy or a CSF cytology. So sometimes in HIV positive patients, the EBV DNA can be used as a surrogate marker that it is a primary CNS lymphoma. So ideally, in an ideal scenario, corticosteroids should be deferred till the tissue is obtained. So unless, of course, there is some life-threatening mass effect like edema, and corticosteroids can obscure the pathology. So very recently, we had a patient who came in a very bad situation. So the decision of whether to start steroid, yes, no, was going on, but we started because the patient's condition was deteriorating. And once you have detected the diagnosis as lymphoma, you should do a full body PET CT scan and a bone marrow biopsy to complete the staging evaluation. So this is again a typical pathology slide of primary non-CNS lymphoma. So what you're seeing is basically lots of mononuclear cells, which large nuclei, scant cytoplasm, and there's a very classical sign called as perivascular cuffing that you see in these people. So survival, initially in the 1970s, when we actually started getting data out, the survival was just about 12 months. So from there, we have moved to maybe 26 months on an average. What is disheartening is the fact that majority of people get back their disease even after treatment. So the median time to relapse is usually about 10 to 18 months, and most relapses occur within 2 years of diagnosis. So some patients even relapse much later, but majority of patients relapse within the first 2 years. So there is a prognostic score. So IELSG stands for International Extranodal Lymphoma Study Group. So they have made a score where they take these 5 factors, that is age more than 60 years, ECOG more than 1, and elevated LDH, elevated CSF protein, and involvement of deeper regions of the brain. So patients with more number of these factors are going to do poorly. Patients with less number of these factors are going to do better. Okay. So pathology, so most of the cases, in fact, 90% of primary CNS lymphomas will be a diffuse large B-cell lymphoma, especially of the activated B-cell type, what we call as ABC subtype. So going deeper into the pathobiology, you see that there is something called as a B-cell receptor pathway, which we call the BCR signaling pathway. And this is found to be mutated. Many of the downstream signals are found to be mutated in this particular disease. And there is, so the basis theory of how this disease comes about is possibly because of a chronic activated BCR signaling. So coming to the treatment, so that was that diagnosis, and coming to the treatment. So I'm starting from 1990s, just to give you an outline of how things have changed. So when we first started treating primary CNS lymphomas, the only modality was radiation. So historically, we used to give whole brain radiation to everybody, and it used to be in doses ranging from 36 to 45 gray. So there was one study by the RTOG group, which was 8315, and that was a phase 2 trial. They put 41 patients under study. They gave them whole brain RT 40 gray plus a 20 gray tumor burst, and what they achieved was a survival of 12 months. So not much, but still significant steps compared to the previous generations. So what was found is there was no durable response, and there was a high risk of neurotoxicity. So we needed something better than radiation here. So next came the wonder drug, which is basically high-dose methotrexate. So the effective regimen for primary CNS lymphoma involves an intravenous high-dose methotrexate. Now, high-dose methotrexate can be defined with variable doses, 1 to 8 grams. This is typically used not alone, but in combination with other chemotherapeutic agents, plus minus radiation. So there are various schedules, a lot of discussion. There is a wonderful woman called Lisa DeAngelis, whose name has been associated with the DeAngelis regimen. And when we first started in the early 2000s, DeAngelis regimen with high-dose methotrexate was possibly the most common thing that was being given. So what we normally give is high-dose methotrexate in a dose equal to about 3 grams per meter square. It is delivered as an initial bolus over 30 minutes, and there's an infusion over 3 hours. And these cycles are repeated every 3 weeks, that is 10 to 21 days. And the safety, efficacy, everything has been well established. And the longer durations you give, the better response you get. So then after just high-dose methotrexate came other chemotherapeutic drugs, and one Swiss trial, which came in the late 2000s, they got about high-dose methotrexate plus Arasi. Arasi is basically cytarabine. So cytarabine was given on the day 2 and day 3, and they gave it BD, so twice, 4 doses totally. And again, cycles repeated every 21 days. And then after that, patients went on to consolidative radiation. And what they found was that they got a much, much better radiological response and a superior 3-year. So small steps going towards better and better response. So then came the concept of combining chemotherapy and whole brain radiation. So now what is the problem with whole brain radiation is the fact that there is a high incidence of neurotoxicity. So combined, especially in the elderly patients. And what happened is later studies came about which said that why not we reduce the dose of radiation. So there was one study where you used a chemotherapy regime, which was RMVP. And after this, they gave a reduced dose radiation, which was 23. Previously, they used to give 40 grays, and now they came down to 20 grays. And then they followed it up with cytarabine administration, and they found that actually you get much better responses. And also the incidence of neurotoxicity was better. So this became a standard for a long time: induction chemotherapy, whole brain radiation at reduced doses, and followed up by cytarabine as consolidation. And the irradiated volume should include the whole brain. It should include the posterior 2/3 of the orbit and the first 2 spinal segments as well. And the reduced dose didn't affect survival, so that was good. So then came what is the risk of neurotoxicity, whether we should eliminate RT altogether from the treatment. Okay. So then there was one study which was called the GPS, Primary CNS Lymphoma Study Group 1, which came about where they took patients, they randomized them to chemotherapy, and then they made RT optional, yes or no. And then what they found is that, even after removing radiation, the outcomes were pretty similar. So there's a lot of talk around this time, which was basically early to 2010, where maybe the role of radiation can be entirely eliminated. So the early regimens, when we used to give De Angelis, there was even a role for something called as intrathecal therapy. So we used to give intrathecal methotrexate. The first generation chemotherapies used to give intrathecal methotrexate, but nowadays people have shown that even by eliminating this step, the outcomes are the same. So we don't use intrathecal injections anymore. So next came rituximab. So rituximab is used across the board over a number of indications. It's an anti-CD20 monoclonal antibody. So this was being incorporated into NHL regimen. So then they said, why not let's try it in primary CNS lymphoma. So they started giving it intravenously. The dose in normal NHL is what we give as 375 milligram per meter square, but they started giving higher doses to see whether the CNS penetration was better. And what they found is even despite the limited CNS penetration, there were radiographic responses even in patients who had just monotherapy. But there was this one trial, which was the WHO-1 trial, which actually said that there was no difference whether you gave rituximab or not. So that put rituximab onto a controversial platform. So then came the role of stem cell transplantation. So we have come to combined, we have started with radiation, we eliminated that, we gave high-dose methotrexate, then we added some combination chemotherapy, then we added rituximab, and now we are trying to remove radiation out totally and try to compensate it with some other kind of consolidation. So then came the role of stem cell transplantation. So because there were limited durability of response, many patients within 2 years, they used to get back their disease. So there was increasing interest in whether high-dose chemotherapy followed by autologous stem cell transplant is a better option. So the conditioning regimens, which include thiotepa and carmustine, they are the ones which demonstrated some encouraging results. So one landmark trial and what is currently the standard of care is this trial, which I will be talking about, the IEL SG32 trial, which demonstrated that both radiation and high-dose therapy with autologous stem cell transplant, both are safe and effective as consolidative treatment. And 4 courses of matrix followed by autologous stem cell transplant, which should probably be the current standard of care. So this is the trial. So this IELSG stands for International Extranodal Lymphoma Study Group, the trial number 32. So the question they addressed is, number 1, what is the best treatment we should give these patients? And should we give them RT or should we do a stem cell transplant? So they took about 227 HIV negative patients who are newly diagnosed primary CNS lymphoma. And the first part of the question, they divided them into 3 groups, group A, B, and C. So group A basically received methotrexate and cytarabine, which we already knew was established by the time. Group B received methotrexate, cytarabine, and rituximab. So that was the third, group B. And then the third one received methotrexate, cytarabine, rituximab plus thiotepa. So that was group C, and that is what we call as a matrix regimen. These cycles were repeated every 3 weeks for 4 times, and first MRI was done after 2 cycles. If the response was good, 2 more cycles were given, and then after that a repeat MRI was done. Between the second and the third cycles, the stem cell transplantation, the stem cell collection was done, and if there was adequate stem cell collection, the patients would move on to consolidated treatment either with radiation or with stem cell transplant. So the transplant conditioning regime they used was a mixture of carmustine with thiotepa. So this is what they found. So which was the best induction regimen? Group C, the group C basically being the matrix regimen, which was more active. It gave 49% responses. Overall response was 87%. In fact, the long-term 2-year progression-free survival was very high at 61%, and 2-year overall survival was 69%. So overall, the conclusively established that matrix is possibly the best regimen we have right now for induction treatment. So the other question, what is the best consolidative regimen? So here the results are basically mixed. So both radiation and autologous stem cell transplant gave more or less the same results. So there was an equal amount of complete remissions, equal amount of long-term responses. There was no significant differences between the progression-free survival between the 2 groups. So then what happened? So then what happened is the survival difference between the 2 groups was the same, but hematological toxicity very expectedly was more in the patients who went for a stem cell transplant. But most importantly, the deciding factor to make a decision which one to give was the neuropsychiatric testing. So they did a pre-treatment and a post-treatment neuropsychiatric testing for patients who received radiation and for patients who received autologous stem cell transplant. And what they found was the mean score was basically lower in patients who received radiation and compared to the ones who received stem cell transplant. So the current recommendation is 4 courses of matrix followed by autologous stem cell transplant. So that is the current standard of care, but there are some newer drugs that are coming up in the horizon. So this is, like I said before, the entire, the pathology behind primary CNS lymphoma seems to be this BCR pathway, BCR standing for B cell receptor pathway. So these are a number of downstream molecules that can be targeted, and most commonly we have started targeting Bruton kinase inhibitors. We're using ibrutinib, we are using lenalidomide. Potentially there is a role for even PIK3 inhibitors, a lot of things. So one of the drugs that is in trials right now is BTK inhibitors or Bruton tyrosine kinase inhibitors. So the drug ibrutinib has been tried in 2 doses, 560 and 840, and both the doses are found to be quite good. And in fact, most of the upcoming trials in primary CNS lymphoma incorporate some dose of ibrutinib into their regimens. So another drugs that are coming up are lenalidomide and pomalidomide. So these are immune modulatory drugs. So these also affect the B cell receptor pathway. So there is one regimen that we are using, which is called the R2 regimen. So R2 is basically stands for rituximab along with lenalidomide. So it's given as 28-day cycles. We give an induction. If there's a response, you go on to maintenance lenalidomide. And these patients are doing quite well, especially in a refractory setting. And the median survival in these patients is almost reaching up to 2 years. So there are some newer interests with immune checkpoint inhibitors. Immune checkpoint inhibitors or immunotherapy is coming up in a big way across oncology. So there is possibly a role even for primary CNS lymphomas. So there is a particular locus which is called as a chromosome 9p24. And once if that is amplified or the copy number is more, usually a PD1 ligand is more, PDL1 is basically increased. So there is a potential for these patients to respond to a immune checkpoint inhibitors like nivolumab or pembrolizumab. So that is it. So I kept it brief, noting that it's only 20 minutes for the talk. So any questions? Yeah.
Thank you, Pragya.
Yeah.
There's a nice little overview on that. A little difficult topic to address in 15, 20 minutes. Questions, anybody? So Pragya, sometimes we land up with the situation where, deep-seated lesion in the brain, difficult to access,
Yes.
suggestive lymphoma, CSF negative, whatever.
Yes, sir. So we've had that very recently, many times. So we try for CSF EBV DNA, and if that is not suggestive, and if the symptoms, and if you have treated them for other possibilities and it's not responding, I would just treat it empirically with a high-dose methotrexate and steroids. Would you have any other suggestions, sir?
Controversial, simple question and a controversial answer. do you treat lymphoma with methotrexate without a histological confirmation?
So ideally, no. I would love to have a histological. All oncologists want
Not
tissue.
to. It is
Yes, sir. Across the board, no.
It can. It can. I mean, I'm not sure, but if we refer a patient either to Kidwai, the patient within 1 day will bounce back. Without histology, they will not.
So the universal rule is tissue. We need a
Tissue
a
or
pathology.
like same question I asked them.
Yeah.
Tissue or any other mode of diagnosis. In fact, I was trying to ask because I had reviewed a paper some time back where someone has written that they treated lymphoma based on I'm not able to remember the molecule in blood or CSF interferon levels or IF6 level or something will be very high. So based on that they treated, I wasn't fully convinced. Paper might get published soon, but I think in our mind, what I think we have been told over years that lymphoma, the oncologists will treat with methotrexate only if there is a histological confirmation.
Yes.
Steroids can be given because steroids are given for multiple conditions. But
Yes.
To start De Angelis therapy or previous blood chalk or whatever, I think without histology, treatment is going to be really, I mean,
Very
shaky
much
is
so.
what I think.
So we are dependent on the biopsy, but if there is a situation where biopsy is not possible, which has happened multiple number of times recently, we try
Biopsy is not
CSF.
possible is- I don't know. I mean,
Poor
biopsy is
performance
always possible.
status.
It depends on what is the risk involved.
Yeah.
Most of the times, like you showed, these lesions are usually very ventricular. So they are difficult to do open surgery, but they are
Yes.
meant for stereotactic biopsy. So we always do a stereotactic biopsy. Since that point came and there was a discussion on steroids, you noted that you avoid steroids
Yes.
for lymphoma patients, but many times these patients would have been started on steroids by a primary physician will come. So if the patient already comes with steroids, what do you do? We have a paper we published 7 years ago. If the patient is on a steroid therapy for more than 7 days, then the chance of getting a negative biopsy by stereotaxy, it's about 40%. But there are times when we had done open surgery for lymphoma because the lesion was so large and causing mass effect. Patient can present to you in altered sensorium.
Yes.
Most often supratentorial, sometimes even infratentorial cerebellar lesions, wherein a surgeon will do open surgery. If you do open surgery, whether patient was on steroids or not on steroids, biopsy will always be confirmatory. The problem comes when you take 2 millimeter biopsy in stereotaxy. If the patient has received steroids for more than a week, then the incidence of negative biopsy is very high, around 40%. And we have had patients where we have given date for biopsy, patient on steroids. You fix the frame and do the scans, the lesion would have disappeared. I'm sure many of us have seen, Dr. Shivu will remember many patients where we have fixed the frame with him, and when you do MRI or CT, the lesion will not be there. Then what we do is we remove the frame, stop steroids, call the patient after 3-4 weeks, let the lesion reappear, confirm the biopsy,
Yes.
then only the oncologist will start radiotherapy. I mean, sorry, not radiotherapy, the chemotherapy. Even actually the steroid response to the lesion is considered to be pathognomonic for lymphoma. Even that is not sufficient to start chemotherapy, is what we have learned from oncologists.
Yes, sir.
The closest differential diagnosis is glioblastoma in elderly people. And that is why those necrotic lesions and
no,
all.
madam, actually usually these are periventricular lesions. They
Uh-huh,
are usually
no.
small. We do not consider.
No, but you said deep-seated lesions.
yes.
Deep-seated lesion, the closest would be like in elderly people, glioblastoma.
Metastasis. The lymphoma, when we look at the scan, we'll be able to find most of the cases. The closest differential sometimes can be in middle age is demyelination, where you can have multiple small and glioblastomas are usually the cortical or subcortical. They present more to the surface. The deep lesions are thalamic lesions. These are usually near caudate, periventricular. You will have multiple lesions. So many times we'll be able to pick up lymphoma. The differential will be demyelination or sometimes infections or toxoplasma and tuberculoma. So whenever we have in our institute, the protocol is whenever we have a patient with lesion, we do HIV and all those things to test. Not that the patients with lymphoma will be HIV positive. If you read only the Western literature, most of them are seropositive patients with lymphoma. In our literature, our own institute data we published, in India, most of them are seronegative patients. They are elderly. The incidence of HIV positive lymphoma in India is very, very less. It's about 5 to 8%.
And what is What
And the
is the
differentials
CNS
will be
lymph?
toxoplasma and tuberculoma. These are the three differentials I keep when we see lesions.
CMV and encephalitis, toxoplasma.
Yeah,
and-
these are
yeah.
the three differentials you should keep in a lesion which appears to be lymphoma and MRI. Glioblastoma will be very low in the list.
And how about patient on continuous immunosuppressive therapy for renal, for any transplant related immunosuppression,
We don't
organ
see them in our
transplant?
practice.
Do you get them CNS lymphoma also, or you don't have?
So it is rare, ma'am, as standard PTLD coming up as a primary CNS lesion is less frequent. But again, I think like what was discussed, we wouldn't touch, chemotherapy without a biopsy tissue diagnosis. We've been pushed for steroids, rarely rituximab when you have a broad differential, still not able to get material. Even after the stereotactic, like we said, sometimes comes back negative. Up to that is still acceptable, but generally methotrexate we would. Yeah.
Dr. Pagni, this is about your last slide.
Yes, sir.
So this chromosome 19p24 aberration which you mentioned,
Yeah.
is this specific and relationship of that to PDL1? Is this specific to CNS lymphoma or you see that in
No,
other
it's across
carcinomas?
NHLs. It is across tumors. It is not specific to
Even for
CNS.
lung you see that, is it?
I didn't hear you say.
Lung carcinoma? Lung?
I'm not sure about
Okay.
lung, but across other NHLs, the chromosome
All right.
9p42 amplification or copy number alterations
Okay.
is associated with increased level of PDL1.
Okay.
So that is
And-
something
and
that
the
is
JAK2
established in
also.
NHLs, yes. Hmm?
Okay.
Hmm.
Okay. Thanks.
Thank you, Pragya.
Yeah.
We'll go on to the next speaker. I'd like to request Dr. Gopal Das, Senior Consultant Neurologist at Mazumdar and Narayana Health City. His topic is perioperative use of anti-seizure medication. Oh, before I do that.
So 13.
Good afternoon, everyone. My sincere thanks to the neurosurgery team for giving me this opportunity to deliver this talk. I'll be discussing about the perioperative use of prophylactic anti-seizure medications in patients with brain tumor. My objective of this talk is to address only one important question that in common clinical practice, before neurosurgery, we tend to advise prophylactic anti-seizure medication even if the patient does not have seizure and if the MRI scan or CT scan shows an epileptogenic lesion. Let's review this important area. Seizures are the common clinical manifestation in patients with primary or metastatic brain tumors, traumatic brain injury, stroke, and intracranial infections. Either these patients present with seizure as the first clinical manifestation or during the course of their illness, these patients develop seizures. Neurosurgical procedures theoretically, at least transiently, may increase the risk of seizures in patients without history of seizures in which patients, those who have epileptogenic lesions in the MRI scan. Now, there is a significant controversy surrounds the use of prophylactic anti-seizure medication, especially in patients, those who do not have history of seizures. Things become quite easy if a patient presents with seizure and if the MRI scan shows an epileptogenic lesion or EEG shows epileptiform discharges. Now, I'm talking about the clinical scenario where we tend to prescribe anticonvulsant to these patients where MRI scan shows a lesion and the patient has not developed seizure yet. Anti-seizure medication prophylaxis without prior history of seizures may be prescribed in the following clinical scenario. Number one, in the perioperative period before or during the brain surgery. In patients, those who are being managed conservatively, but they have an epileptogenic lesion in the MRI scan. Or even in critical care situations, they have got a potential metabolic abnormalities which can provoke the seizures. So these are the common clinical scenarios where clinicians tend to prescribe prophylactic anticonvulsants even if the patient does not have seizures. Now, what is the objective of prescribing a prophylactic anti-seizure medication to these patients? Well, the objective could be to decrease the incidence of early onset seizures
and minimize the risk of late onset seizures with minimal or acceptable adverse effects. Now, the decision to provide seizure prophylaxis requires a careful analysis of the risk and benefit, because sometimes if the patient has not had a seizure and we prescribe phenytoin, there is a small but not zero risk of having even a Stevens-Johnson syndrome. So this kind of risk and benefit analysis must be done, and at least this should be informed to the patient that there is a small risk of serious adverse effect. Anti-seizure medication prophylaxis is justified if the benefit of preventing the occurrence of seizure exceeds the risk of adverse effect of the anti-epileptic therapy. Now, what happens is that post-operative seizures, most of the time, it happens within the first 1 week, and 2/3 of the seizure happens within the first 72 hours. And the risk of acute post-operative seizure or acute symptomatic seizure gradually decreases over a period of time. It is about 10% by 6 months. In a study, supratentorial craniotomy, the first post-op seizure occurred at a mean of 2.3 days and 42 months for untreated and treated patient respectively. So in this particular retrospective study, what they found that when they give prophylactic anticonvulsant to these patients, they could prevent the onset of early onset post-operative seizures. Now, this is the various risk. The risk of having a post-operative seizures depends upon the etiology. It depends upon the epileptogenic lesion. For example, it is highest in patients with tumors between 37 to 87%. In traumatic brain injury, the incidence varies between 3 to 20%. In patients with abscess, they are highly epileptogenic. The incidence varies between 20 to 90%. In brain tumor, particularly, that is a subject of interest today, the epilepsy accompanies, especially in the primary brain tumor, it varies between 25 to 30%. And in patients with metastatic brain lesion, the incidence varies between 25 to 40%. Epileptogenesis in this group of patients depends upon the histology, the location of the lesion, the grade of the lesion, as well as the individual's genetic susceptibility to develop seizures. Now, as all of you may be knowing, the less aggressive tumors, particularly the DNAT and ganglioglioma, they more commonly present with seizures as their first clinical manifestation. In one study, Pace et al. Found that 83% of patients with low-grade astrocytoma, they had more seizures as compared to high-grade tumors, like 46% in anaplastic astrocytoma and 36% in glioblastoma. DNAT and ganglioglioma, this represent the most common epileptogenic brain tumors with seizure incidence of nearly about 100% in this group of patients. Epilepsy is less frequent in meningiomas as compared to DNAT and ganglioglioma. Cortical tumors are more epileptogenic, and posterior foci and skull-based lesions, they generally do not cause seizures. Now, what is the rationale for anti-seizure medication prophylaxis before the patient who develops the seizure? There are theoretical advantages like immediate and early post-operative seizures can be prevented by prescribing a prophylactic anticonvulsant to these patients. The early post-operative seizures, especially the person has got an epileptogenic lesion and he has undergone a neurosurgical procedure. If there is an acute post-operative seizure, then it can mask the post-operative evaluation of the patient's mental status. It can lead to aspiration, hypoxia, edema, intracranial hypertension, or superadded neurological deficit due to the seizure. Further, it can lead to the functional and psychosocial morbidity of the patients. So there is a theoretical benefit of prophylactic anti-seizure medication because it may reduce the ill effects of the short-term seizures and reduce the risk of long-term epilepsy rates by inhibiting kindling. Now, based on this discussion, let us see what the literature says, whether we have a definite evidence to prescribe these prophylactic anti-seizure medications or not. In 2000, American Academy of Neurology Practice Parameter Guideline states the following two important points in relation to prescribing prophylactic anticonvulsants to patients, those who have got newly diagnosed brain tumors. Number one, in patients with newly diagnosed brain tumors, anticonvulsant medications are not effective in preventing first seizures. Because of their lack of efficacy and their potential side effects, prophylactic anticonvulsants should not be used routinely in patients with newly diagnosed brain tumor. The point number two, in patients with brain tumors who have not had a seizure, tapering and discontinuing anticonvulsant after the first postoperative week is appropriate, particularly in those patients who are medically stable and who are experiencing anticonvulsant related side effects. This guideline was published in 2000. Let us see the next literature. This table represents randomized controlled trials, meta-analysis, and reviews on the role of anti-epileptic prophylaxis in patients with brain tumors. These patients have not yet developed seizures, but they have potentially epileptogenic lesions in their MRI scan, and they have undergone neurosurgical procedure, either biopsy for diagnosis or neurosurgical intervention as a part of the treatment. Glange et al., they have 1,000 patients. This is a meta-analysis of 4 randomized clinical trials and 8 cohort studies. So in this nearly 1,000 patients, they have used phenytoin, valproate, and phenobarbital. The conclusion is that prophylactic administration of anti-epileptic drugs is not indicated. Anti-epileptic drugs associated side effects are especially common and occasionally can be life-threatening. Sirven et al., in a meta-analysis of 5 prospective randomized controlled trials, 403 patients were analyzed. Phenytoin, valproate, and phenobarbital were used in these patients. They did not find any evidence for AED prophylaxis in patients with brain tumors and no history of seizures. Rosati et al., they had 64 patients. They have used phenytoin and levetiracetam. They found prophylactic anticonvulsant treatment is not justified. In the next study, the Francetti et al., in 129 patients, phenytoin and phenobarbital were used. They found a benefit of short-term preventive treatment with AED after surgery. That means in this analysis, they found that prescribing an anticonvulsant prophylactically reduces the risk of early postoperative seizure, not the late postoperative seizures. In another study, Massio et al., that's a retrospective analysis where they have used levetiracetam, oxcarbazepine, and topiramate. They found significantly reduced seizure frequency, and there are few side effects because in this study they have used newer anticonvulsant, that is levetiracetam and oxcarbazepine and topiramate. These are non-enzyme inducing anticonvulsant. Tremont-Lucas et al. In 2008, they have analyzed 5 randomized controlled trials, and they conclude that there is no difference in overall seizure risk, significantly higher rate of adverse events. So what we understood in this particular slide is that a majority of the study have not found any significant benefit in preventing early postoperative seizures. There is one study which found that there could be a chance that prescribing a prophylactic anticonvulsant may reduce the early onset seizures. This is another summary of randomized controlled trials and meta-analysis. In these studies, group of studies, they have used phenytoin, phenobarbital, gabapentin, and majority of the study concludes that there is no statistically significant difference in preventing early or late postoperative seizures in this group of patients. Those who have received prophylactic anticonvulsant, that means these people have still not developed seizures. This is another paper which was published in Journal of Neurological Sciences in 2019. 4 randomized controlled trials with 352 patients met the selection criteria. The results demonstrated that perioperative anti-seizure medicine prophylaxis for patients undergoing brain tumor surgery provides a statistically significant reduction in the risk of early postoperative seizure compared with controls. Anti-seizure medication prophylaxis had no statistically significant effect on the total incidence of seizure. That means it could not prevent late onset seizures, or the long-term epileptogenesis was not prevented by prescribing prophylactic anticonvulsant. So the authors conclude that this meta-analysis demonstrates for the first time that perioperative AED prophylaxis for brain tumor surgery provides a statistically significant reduction in early postoperative seizure risk, but not the overall incidence of seizures. So the guidelines lack clarity. There are some studies which have shown that it can prevent an early onset seizures, but majority of the study have clearly demonstrated that it won't prevent the subsequent late onset epileptogenesis. By prescribing an anticonvulsant prophylactically, we are not preventing any late onset epileptogenesis to these patients. So guidelines lack clarity. And still, as you know, the prophylactic anticonvulsants are very common in neuroscience or neurosurgical practice. In a survey in 2015 by Diwan et al., observed that more than 63% of the neurosurgeons administer seizure prophylaxis after tumor resection in patients without a history of seizure for a period of which varies between 1 to 6 weeks period of time. And currently, levetiracetam is the most common drug which is being prescribed. In United Kingdom, however, the data is a little different. The survey reveals that 59% and 79% of the surgeons responded that they never prescribe prophylactic anticonvulsants to glioma and meningioma resections, respectively. What is the choice of anti-seizure medicine prophylaxis if you prescribe a medicine? Historically, neurosurgeons and neurologists, they're very comfortable in prescribing phenytoin because it does not impair the level of consciousness, and we know that it has gotten well-established therapeutic serum concentration which can be monitored very easily. However, it has problems or side effects like unpredictable non-linear pharmacokinetics. That means the margin in which the phenytoin produces side effects like gait ataxia or toxicity like myoclonus, and the dose which produces seizure freedom actually is very, very minimal. The risk of adverse effects, for example, in patients with the brain tumor, the possibility is that they may be receiving chemotherapeutic agents. So enzyme-inducing drugs, especially phenytoin, it will interact with the chemotherapeutic agents, and it may result in the failure of the chemotherapeutic agent because it will result in enzyme induction. These side effects are, of course, less common in patients those who are receiving oxcarbazepine or levetiracetam because these are non-enzyme-inducing anti-epileptic medications. So valproate and levetiracetam, generally they have good tolerance, they have less drug-to-drug interaction. They also, when it comes to efficacy, their efficacy is equivalent to phenytoin, and valproic acid and levetiracetam they also have anti-tumor action. Valproic acid, a promising therapeutic agent in glioma patient. Valproic acid have other mechanism of action, thereby it can exert some anti-tumor action. Valproic acid, theoretically, it has been shown in various in vitro and vivo studies that it acts at the level of cellular proliferation, migration, invasion, and various levels of cell cycles, including apoptosis, because the valproic acid is one of the most common histone deacetylase inhibitor and has been detected to directly or synergistically exert inhibitory effect on glioma in vitro and in vivo. So this is one of the most important aspects about valproic acid. This medication can increase the sensitivity of the glioma cells to chemotherapeutic agents. So valproic acid has been shown in literatures that it increases the sensitivity of the glioma cells to the co-prescribed medications like chemotherapeutic drugs or radiotherapy or even immunotherapy. So therefore, valproic acid is one of the potential agent which could change our practice in due course of time. The ideal duration of prophylaxis, it's still not clear because there are no standard recommendations of prescribing. Many times the commonly prescribed doses it varies between 1 week to about 6 weeks, but it all depends upon the subsequent clinical progression of the patient. So now at this point of time, I will review the latest guideline about this particular aspect of the clinical question which we are discussing today. Is there a definite evidence to prescribe anti-seizure medication to a patient who has a brain tumor and who has not developed seizure yet? So the question number 1, in patients with newly diagnosed primary or metastatic brain tumor who have not already experienced a seizure, does anticonvulsant prophylaxis compared to no anticonvulsant prophylaxis increases the seizure-free survival? And number 2, reduce the frequency of first seizure at 6 months from diagnosis. And the conclusion is that in patients with newly diagnosed brain tumor who have not had a seizure, clinicians should not prescribe anti-seizure medication to reduce the risk of seizures. This guideline was published by the Society of Neuro-Oncology and European Association of Neuro-Oncology. This is level A evidence. Now question number 2, in patients with newly diagnosed primary or metastatic brain tumors who have not already experienced a seizure and who undergo a neurosurgical procedure like craniotomy or biopsy for initial treatment or diagnosis of the tumor, does perioperative anticonvulsant prophylaxis compared to no prophylaxis prolong time to seizure occurrence? In patients with brain tumor who have not had a seizure and are undergoing surgery, there is insufficient evidence currently to recommend prescribing anti-epileptic drugs to reduce the risk of seizure in perioperative or even post-operative period. And the level of evidence is C. In patients with newly diagnosed primary or metastatic brain tumors who have not experienced a seizure and who undergo a neurosurgical procedure for initial treatment or diagnosis of the tumor, does perioperative anticonvulsant prophylaxis compared to no treatment reduce the frequency of first seizure at 2 weeks following surgery? So the answer is no. In patients with brain tumors who have never had a seizure and are undergoing surgery, there is insufficient evidence today to recommend prescribing anti-epileptic drugs to reduce the risk of seizure in perioperative or post-operative period. The next question, in patient with newly diagnosed primary or metastatic brain tumor, does treatment with valproic acid or other anticonvulsant compared to treatment with any other anticonvulsant medication increases progression-free or overall survival? Again, the answer is, in the patient, those who are newly diagnosed primary or metastatic brain tumor, there is insufficient evidence to support prescribing valproic acid or levetiracetam with intent to prolong the seizure-free or survival rate in this group of patients. So that particular decision we have to take based on our clinical judgment in that given particular patient. Now, one positive response in this particular study is that in patient with a newly diagnosed primary or metastatic brain tumor, does treatment with a non-enzyme inducing anti-epileptic drug or more modern anti-epileptic drug prophylactically or following a seizure compared to treatment with enzyme inducing drug have a more favorable side effect profile? Yes. So therefore, if you prescribe an enzyme inducing medication, particularly phenytoin or carbamazepine to this patient, they are likely to experience more side effects. They are likely to have problems with drug-drug interaction to chemotherapeutic agent. So the society recommends that in patients with newly diagnosed primary or metastatic brain tumor, physicians may choose to prescribe levetiracetam rather than older anticonvulsant to reduce the side effect. There is no efficacy difference in terms of phenytoin or levetiracetam in this group of patients, but the chances of side effect with newer anticonvulsants are less, number one. Number two, the newer anticonvulsants, those who are not enzyme inducing, they will have less interaction with the chemotherapeutic group of drugs. In terms of the histology and the location of the lesion, also currently the response is negative. So we may not be able to select anticonvulsant based on the histology if the patient has not developed any kind of seizure. So this is the final recommendation by the Society of Neuro-Oncology and European Association of Neurology. In patients with newly diagnosed brain tumors who have not had a seizure, clinicians should not prescribe anti-epileptic drug to reduce the risk of seizure, level A evidence. In brain tumor patients undergoing surgery, there is insufficient evidence to recommend prescribing anti-epileptic drugs to reduce the risk of seizures in peri or post-operative period, level C. There is insufficient evidence to support prescribing valproic acid or levetiracetam with an intent to prolong progression-free or overall survival. Physicians may consider use of levetiracetam as compared to older drugs to reduce the chance of side effects. There is insufficient evidence to support using tumor location, histology, grade, molecular or imaging features when deciding whether or not to prescribe prophylactic anticonvulsants. This is just a brief one table to understand the anti-seizure medication prophylaxis in other clinical conditions, though the primary focus today was neuro-oncology. In traumatic brain injury, American Academy of Neurology guidelines suggest that you may prescribe, if the patient has not seizure, then you may prescribe the anticonvulsant for just about a week. In ischemic stroke, no recommendation. In intracerebral hemorrhage, there are no recommendation. In brain tumor, there are no recommendation. In patient with subarachnoid hemorrhage, you may prescribe the medicine for about 3 to 7 days if the patient has not had a seizure. So thank you so much.
Thank you, Dr. Das, for that exhaustive data on the utility or the lack of utility in using the anti-seizure medication. Questions, please? Yeah.
In fact, I just repeated. So a lot of patients on Levipril, the problem is mood changes, and everybody, the caregivers especially complain. What is the next best drug other than Levipril?
One of the common drug, if the question here which I address right now is number one, patient has not developed seizure, and sometimes we prescribe them with the theoretical worry that the patient may develop an early post-operative seizure. The guideline says that if the patient has no seizure, all the randomized control trials and meta-analysis, they suggest that there is no much benefit. Now, if the patient has developed a seizure, then you have to select the drug.
Yeah.
Now, while selecting the drug, especially in a patient with brain tumor, those who are likely to receive chemotherapeutic drug, the options are number one, oxcarbazepine is one good drug, which is very effective in focal epilepsy, and it is not an enzyme-inducing drug. Number two, another sodium channel blocker is lacosamide. Lacosamide can be given parenterally, and it has also less drug-drug interaction and less chances of psychiatric side effects. Levetiracetam is a good drug, because it will also have less drug-drug interaction, and it does not cause much problem in terms of the renal dysfunctions or liver dysfunction. However, we need to modify the doses of levetiracetam in those group of patients. However, if your patient with levetiracetam develops a mood side effect, you have two options. One, you can reduce the dose. Second, you may select oxcarbazepine or valproate. Oxcarbazepine and valproate, they are mood stabilizer. So you may select these two group of drugs in those patients. Sir, brivaracetam, currently there is no evidence that we start with brivaracetam to these patients. If a patient with levetiracetam develops some mood side effect, you may switch, but we have better options than brivaracetam. So currently there is no evidence that a patient with brain tumor to start with brivaracetam.
Okay. The other scenario what we get is patients on this antiepileptics operated elsewhere or in our own place, but for many years ago, so for some reason, but there's no history of seizure. They will be religiously taking, like children would have started and now they would have become adults. So now those cases.
That's a real, very practical and difficult clinical question. At the moment you stop, they might develop even a seizure.
Yes, yeah.
There you have to take a clinical decision. Suppose, for example, if the patient is seizure-free for 3 years and his last stage is not showing any abnormality, and if the patient is having a side effects related to the medication, we will discuss with him about the AED withdrawal with him. Especially this question which you are asking, it is more in terms of the benign tumor. Like this patient, suppose you have removed the ganglioblastoma and the patient never, suppose we have removed it based on our oncologic potential and the patient never had a seizure, but he's still taking, suppose, phenytoin. Then after around, say about 2 years of seizure freedom, we will discuss about the AED withdrawal, because we need to give the option of AED withdrawal to the patient after 2 years of seizure freedom, as because he is taking it prophylactically.
That time, do you think EEG is
a terminal EEG will be helpful to the patient if there are no antiepileptic. Another practical problem that I see is that patients, those who develop focal unaware seizure or complex partial seizure, patient will come alone and he will inform you that he never had a seizure, but the patient may be having seizure. So therefore, a thorough detailed clinical history is very, very important. Recently, I saw a patient, he told that he had 2 episodes of generalized seizure and he had a meningioma. Then he told that he never had a complex partial seizure. But subsequently, when he was accompanied by his family member, his brother told that he is recurrently having memory problem. That means those brief memory problem are complex partial seizures of the patient when they took a detailed history. So number one, we have to find out whether the patient is having complex partial seizures or not carefully. And if the patient has no complex partial seizure and no generalized convulsive seizure and terminal EEG is normal, then we have to give the option of AED withdrawal. And there we have to inform the patient that after I reduce the medication, the chance of having relapse of seizure is 10%, then chance of having not seizure is 90%. So the patient will participate in the decision making.
Thank you.
2 questions.
I'll just one. Yeah. Some of the patients may develop some changes either because of radiation or as a delayed effect of surgery. Whether these can lead to seizures, and what is the international literature or your experience in this?
Yes, sir.
Because they may not have immediate seizure. Most of the surgical things also immediately they may not have, but later on, maybe 6 months, 1 year, 2 years, MRI and other things we see it.
So that part I address in the initial part. People, those who believe that an anti-seizure medication prophylaxis is required, they strongly believe that the initial post-operative changes or even radiation-induced thing, they believe that a prophylactic medication should be instituted to this patient with a theoretical worry that most of these seizures, generally it happens within the first 1 or 2 months. Subsequently, acute post-operative or symptomatic seizure, the chance is gradually going to be reduced. It is around only 10% at the end of 1 year. However, if there is delayed epileptogenesis and the patient develops fulfilled criteria for epilepsy, then we have to initiate the medication. But whatever literature I reviewed in the last 2 weeks, there is no role of giving prophylactic anticonvulsant to these patients at all. The randomized, the meta-analysis which was published in Journal of Clinical Neurosciences, which I showed in 2019, the authors, they conclude that if you prescribe anticonvulsant, it is just going to reduce the risk of having early postoperative seizure. Late postoperative seizures cannot be prevented by prescribing a medication. That is the latest data.
Okay. Thank you, Dr. Gopal Das. We are running out of time. So we would like to move to the next topic. Before that, we'll finish.
Thank you.
So we have the next topic, management of recurrent gliomas. Dr. Hiba Altaf will be presenting. Thank you.
Hello, everyone. I'm Dr. Hiba, and I'll be talking about management of recurrent gliomas. Yesterday, we have discussed in great detail about the new WHO classification and its impact on the treatment of newly diagnosed gliomas. At present, the grade 3, grade 4, and GBM are treated by STOPS protocol, where the patient undergoes surgery with maximum safe resection, followed by radiation with concurrent temozolomide, followed by 6 cycles of temozolomide. And in case of grade 2, patient undergoes usually surgery, followed by either immediate or delayed radiation with PCV or temozolomide. And with this, we have a survival of 14 to 18 months in case of glioblastoma and 3 to 5 years in grade 3 astrocytomas. And we have better median survival in grade 2 tumors, especially oligodendroglioma, where the median survival is from 10 to 15 years. However, regardless of what treatment patient has received, virtually all gliomas eventually do progress over time, and the time frame may be as long as 10 years or more even after diagnosis. Now, recurrence in low-grade glioma can happen in 2 ways. Either the tumor may progress without transformation, there will be increase in tumor size, or they may progress and transform into higher grades. It has been seen almost 50% patients of low-grade gliomas may eventually progress to a higher grade. The first question that we ask in recurrent gliomas is that, is it a true progression? So the diagnosis of a recurrent gliomas is usually based on the clinical status, MRI findings based on RANO criteria, and the clinical state and the clinical medical history of the patient. It's very important to distinguish these tumors from the tumor-related, treatment-related complications like pseudoprogression and radionecrosis. Pseudoprogression is mostly seen in patients who have undergone radiation and usually in the time period of 3 to 6 months post-RT. And they are usually seen in patients who are either asymptomatic or they have very less symptoms compared to true progression. This is also seen in patients who have received immunotherapy and the tumors which are who have methylated MGMT status. Specialized imaging like MR resonance spectroscopy, tumor perfusion, and PET scans can help us differentiate these tumors from the true progression. These patients should be usually followed by close clinical radiological follow-up, and it is very important to avoid premature discontinuation of potentially efficient treatment like bevacizumab or temozolomide in these patients. Almost 50% patients who develop progression immediately after RT have been found out to be pseudo-progression. Another entity that we need to differentiate from recurrent gliomas is radiation necrosis. It also occurs in patients who have received radiation, usually 6 to 12 months after RT. Multimodality imaging again can help us in these cases, that is spectroscopy as well as MR perfusion and nuclear imaging. These patients, however, sometimes may require a biopsy to differentiate from recurrent gliomas. However, in most patients, patient may not be fit for to undergo the procedure, or may be too frail, or may not give the consent to undergo the procedure. Now, as far as the treatment modalities for recurrent gliomas, at present, we don't have any standard of care for recurrent gliomas. This is because of lack of large randomized controlled trials. Whatever data we have is mostly based on retrospective, prospective studies and small randomized controlled trials. Now, these trials have evaluated salvage surgery, that is resurgery, re-radiation, chemotherapy, targeted therapy, and other new modalities. Now, most of these treatment modalities have shown only a modest survival benefit so far. But one thing that is clear from these studies is that selected candidates may benefit most from these treatments. Now, first is the surgery. Surgery is necessarily the most common treatment modality that is available for patients of recurrent glioma, especially the patients who undergo, recurrent low-grade gliomas. But less than 50% of patients with recurrent GBM are the candidates for a second surgery. We have studies which have shown that second surgery is beneficial in selected patients, while there are other studies which may have demonstrated limited impact. The goal of surgery in recurrent gliomas can be either cytoreduction with maximal safe resection, which has obviously shown better outcomes, or it may be just biopsy to confirm the diagnosis or differentiate from radionecrosis, or in some cases just to get the more tissue material for molecular markers for future treatment decisions. The true value of reoperation versus systemic therapy, their effects, the patient quality of life and added increase in survival, however, is not clear due to lack of randomized controlled trials. This was a meta-analysis which in 2018, which showed, which was done with 8 studies, and it showed a significant survival advantage of surgery. The recent studies had shown more benefit than the older studies, but there was a selection bias in the cohort that was taken for the analysis in this review. Now, the median survival for recurrent GBM with surgery has been found to be 8 to 12 months, and for recurrent grade 3 astrocytomas is between 12 to 18 months. Carmazine monomer wafers may prolong the survival, and also new intraoperative tools like 5-aminolevulinic fluorescence, intraoperative neurophysiological monitoring, and intraoperative imaging, which may help to increase the rate of gross total resection and eventually may lead to a better outcome. There has been a lot of prognostic scores that have been developed to select the patient group which may benefit more from these surgeries. And these prognostic indicators may be most important prognostic indicators are good performance status, progression-free interval wherever it is longer, young patients where maximal safe resection is possible, tumor in a non-eloquent area, non-ependymal involvement, and small tumor volume. Now, role of radiotherapy. Now, if the patient was not previously radiated, for example, in a patient of grade 2 glioma who post-operatively was kept on observation and eventually recurred, these patients should receive radiation either post-operatively undergoing a resurgery, or if the patient is not fit for surgery or tumor is not resectable, they should receive definite radiation to full dose. However, the role of re-irradiation in recurrent glioma is less well defined. Again, there is lack of prospective RCT in this regard. The main issue with re-irradiation is the tolerance of the healthy brain tissue that has been previously irradiated to a very high dose of radiation. But with recent technology like SRS, hyperfractionated SRT, and fractionated stereotactic radiation, this concern has been reduced to some extent. Now, SRS stereotactic radiosurgery, we give focused high-dose radiation in a single fraction to the tumor. Most of the tumors are very small in size, like 2 to 3 centimeters, and the doses that have been tried in various studies is in the range of 15 to 24 gray, and we have reported overall survivals of 5.3 to 13.5 months. In some studies, however, the radiation necrosis has been as high as 24%. Most of these radiation necrosis was seen related to increased tumor volume, and the studies where the cumulative EQD2 was kept less than 95 to 100 gray, the radiation necrosis incidence was much less. The second is hyperfractionated stereotactic radiation, where we give high dose radiation in 3 to 5 multiple fractions, in some cases maybe up to 15 fractions. The doses that have been used is 25 to 35 gray, and the median survival we have found in this group is 7.3 to 12.0 months, with radiation necrosis less than 10%. This may be suitable for patients where the tumor is slightly big for the SRS. Next is fractionated stereotactic radiation. In this, we are giving the radiation with the conventional fractionation of 2 gray per fraction, and patient receives a dose between 36 to 40 gray. We have seen a median survival of 8 to 11 months with radiation necrosis of 0.8 to 6.8%. Now, this may be a good option for patients where the tumor may be very close to OARs, and we are concerned that these OARs may receive a very high dose with SRS or a hyperfractionated SRT. Brachytherapy in the early 2000s was also explored in recurrent gliomas. In GBM, in one study, after resection, there were placement of iodine 125 seeds, and they showed a median survival of 13 months in anaplastic with 12.2 months in GBM. There was another brachytherapy related study which used glycoside post resection, where they used inflatable catheter which was placed in the resection cavity and which was later expanded with liquid iodine 125. It showed a median survival of 9.1 months in KPS greater than 70. However, the brachytherapy is associated with very high dose of very high rates of radiation necrosis, up to 40%. And with the advent of more focused radiation like SRT and SRS, the focus on brachytherapy in recurrent GBMs and gliomas has reduced. Now, proton therapy is the new thing, and it has been tried in recurrent glioblastoma. Protons have an additional benefit to photons is that there is no exit dose. So, in case of re-radiation, we can actually reduce the radiation dose to OARs and the rest of the brain. And so far, we have found whatever data we have is mostly retrospective and prospective series, and they have shown that proton beam is well tolerated and offers similar efficacy rates as photon re-radiation. We have also tried re-radiations with systemic therapy like bevacizumab and temozolomide, and in an ongoing randomized trial of our TOG, where radiation, hypofractionated radiation is given with or without bevacizumab, and it has showed improved progression-free survival, but not the overall survival. Re-radiation has also been tried after resurgery in patients of recurrent gliomas. It has so far shown decent median survival of 12 to 13 months. And in some cases, they have also found the indicators at KPS, MGMT methylation, and time interval between the first and the second RT. But in some cases, the radiation necrosis rate has been as high as 64%. So it is very important to identify these patients carefully to see the meaningful benefit of improvement in overall survival versus negative effect of treatment-related toxicity on the quality of life. There is a prospective trial going on which is asserting early adjuvant re-RT after reoperation in recurrent GBM. There are a lot of prognostic scores for re-radiation, and the main indicators are histology, age, interval between first and second radiation, reoperation, KPS, PTV, that is the tumor volume, and MGMT methylation. So, re-radiation can be an option in selected group of patients, and we can offer it to the patients we have smaller recurrences, good KPS, located in a favorable location, ability to spare or minimize the dose to OARs, long interval between the previous RT and now, which should be more than 6 months. And we should consider SRS or hypofractionated cases if it meets the size and location criteria, while in others where OAR toxicity may be a concern, fractionated stereotactic radiation can be an option. Now, chemotherapy or targeted therapy. Most commonly used systemic agents in recurrent gliomas are bevacizumab, nitrosoureas, and temozolomide. However, no single agent has shown to be clearly superior to another. In a largest randomized study where it was evaluated whether a single agent was better, combination was better than single agent, the addition of bevacizumab to lomustine improved progression-free survival, but not the overall survival. The median survival for recurrent GBM on chemotherapy is 8 to 9 months. So nitrosoureas, which include lomustine, carmustine, can be either given as a single agent or in combination as PCV. It has a response rate of 9 to 14%, and it has also been compared with temozolomide and in a phase 3 trial, which has not shown any statistical difference in PFS or overall survival. Since most of the patients who are recurrent gliomas, they may have received temozolomide as a part of their initial treatment, but temozolomide re-challenge can be an option, and it is the best candidates for those are patients who have relapsed some months after completing the adjuvant temozolomide and tumors who have methylated MGMT promoter. Also, this is the study where it was shown that the MGMT promoter methylation was a strong marker for the benefit of dose intensified temozolomide re-challenge. Now, bevacizumab, which is a monoclonal antibody that binds to VEGF factor, it shows a response rates of 30 to 40%. And it has also been tried as a single as well as combination with irinotecan and lomustine. The main benefit of bevacizumab in recurrent gliomas is that it has an important steroid sparing effect in many patients that can positively impact the quality of life. However, in larger studies, it has not demonstrated to improve overall survival in patients or in newly diagnosed or recurrent glioblastoma. This was a study where bevacizumab was alone was compared with combination with irinotecan. It showed improvement in progression-free survival, but not overall survival. But the steroid doses over a period of time were reduced. Another study where lomustine and bevacizumab was compared to lomustine, it showed increased progression-free survival, but not the overall survival. Now, since our traditional treatment modalities have not able to increase the median survival in recurrent gliomas beyond a certain extent, other treatment modalities are coming, and the more important is the tumor treatment fields. In this, electrodes are placed on patient's scalp, and an electric field is applied to affect the cell division by affecting the spindle cell formation during mitosis in the cancer cells. Now, one of the studies that was a phase 3 trial in recurrent gliomas showed that, however, there was no improvement in overall survival, but it showed the efficacy and activity, which was similar to chemotherapy, and the toxicity and quality of life was clearly favoring it. It is also being evaluated in newly diagnosed glioblastoma with temozolomide, and the interim analysis of this study is showing there is a significantly prolonged progression-free and overall survival, but that is in newly diagnosed glioblastoma. Now, there are other treatment modalities which are under evaluation. The one is immunotherapy, mostly nivolumab, which has in Checkmate 143. Nivolumab in combination with ipilimumab has been evaluated in recurrent gliomas, but it has not so far shown any encouraging results. Similarly, there is another molecule, which is Depatux-M, which was an antibody conjugate, which is targeting activated EGFR. This molecule, again, initially did not show any efficacy results, but the later survival reports that are coming that are showing significant difference between the groups. Other molecules that are vaccines, either peptidic or dendritic cell vaccines, are being evaluated. Analytic viral therapies, which utilize either polio or retroviruses, have been also evaluated and are under evaluation for recurrent gliomas. TKIs and PARP inhibitors are other molecules which are being evaluated in recurrent gliomas. Now, this is the chart that we usually follow for these patients. The first is the performance status. If the patient has poor performance status, which may be mostly because of peritumoral edema or steroid toxicity, they can be given a trial of bevacizumab. However, in most poor prognostic patients, best supportive care may be a better option. And in patients who have a good performance status and patient has a local pattern of recurrence, if it is completely or near completely resectable, they should undergo surgery followed by systemic therapy with or without radiation. And if they are not resectable or they are at a non-eloquent area, these can undergo either irradiation or systemic therapy or alternating electric fields. In conclusion, the treatment decision must be individualized, taking into account patient's preference, prior therapies, functional status, and quality of life, and overall goals of care. Repeat surgery and re-irradiation may be beneficial in selected group of patients. And for most patients who are selected for systemic therapy, options should be the single agent or combination bevacizumab, lomustine, and temozolomide. And participation in a clinical trial should be encouraged. And before I finish, I want to discuss one case. This was a 27-year-old male which presented in 2015 as anaplastic oligodendroglioma grade 3. They underwent left frontocraniotomy and decompression, received it post RT with temozolomide, followed by 6 cycles of TMZ. After 5 years, patient developed recurrent seizures, and MRI showed a recurrence near the surgical cavity. He underwent re-exploration of the left frontal craniotomy and excision of left superior frontal gyrus. Histopathology showed glioblastoma, grade 4, P53 positive, Atrix negative, and IDH mutant, according to the new classification, which would mean astrocytoma grade 4. And he underwent re-radiation with concurrent temozolomide, followed by monthly temozolomide. And as for April 2020, patient is alive with a stable disease over the periodic MRIs. Thank you.
Thank you, Hiba, for a nice and comprehensive covering of a very difficult topic. I think we don't see many of it, especially coming from, radiation oncologists about this topic. Usually it will operate and give other treatment like that. Floor is open for any questions. Yeah.
No, so TTF is not available. I think not in India, maybe in US and some of the European understudy. I think the Swedish study, they are doing a study about it, but I don't think it is available in India.
Is it the cost or like because it's
license? They have not got the license.
No, FDA approved, I think.
Yes, it is FDA. It is FDA approved, but not
the delay.
Some of the companies are trying to get it here. One is the licensing is not yet done, and the cost will be prohibitive when it gets. But nevertheless, a small group of people may be able to afford it. But I think the administrative licensing is not
probably. It's just a matter of time. Probably.
Yeah.
So we'll go to the. Thank you.
Okay. Thank you,
Dr. Hiba. We'll go to the next talk. Yeah. Before that, keep forgetting. Please. Next, we invite Dr. Sri Harsha Krishna to give the talk on role of perfusion imaging in pre and post-operative imaging of gliomas.
Yeah. Is there a mouse? Okay. Good afternoon. Thank you for having me over here, and I thank the organizers for this opportunity to present this topic. Of course, perfusion imaging has been around for more than a good part of 20 years plus in radiology, and even then the use of this modality is a little limited because of the technical issues with the modality. The main issue, of course, is a knowledge base and the availability of the injectors which we use for giving a bolus of the contrast. And that's the reason that many centers which are not doing high volume oncology work are not using this modality, which is a very, very useful adjunct to conventional imaging, especially in oncology, along with the MR spectroscopy and other imaging sequences that we routinely use. Now, coming to MR perfusion, there are many techniques of doing MR perfusion studies. The most commonly used and easy to use one is DSC, which is Dynamic Susceptibility Contrast MR perfusion study. The other two techniques that are less used in oncology are T1 contrast enhanced perfusion MRI, and the other is arterial spin labeling, which is a newer, maybe about a decade-old technique which has come into use now. Each of it has its own advantages and disadvantages. I'm not going to do an extensive review of those because that's beyond the scope of this presentation. I'm just going to summarize the main salient features of each technique. Coming to T1 contrast enhanced MR perfusion technique, what we actually do is inject a bolus of gadolinium contrast just like any other study and trace the contrast passage to the tissues using dynamic multiple repeated acquisitions of T1 weighted images over a period of several minutes to see how the contrast passes through the vasculature and the interstitium. This technique has a longer acquisition time, at least bare minimum 5 minutes. Some acquisitions go all the way up to 10 minutes long. And because of the long acquisition time and also the difficulties in some of the technical challenges in post-processing this technique, it is less commonly used. However, it has advantages. It does have a lesser susceptibility artifacts, which is around the skull base or wherever there is blood degradation products
we have less difficulty in reading the perfusion studies when DSC, which is the dynamic susceptibility contrast technique, does not help in those areas because of the blooming from the skull base or from the blood degradation products. ASL perfusion is a non-contrast technique. Here, the inherent flowing blood in the arteries are labeled for by using particular techniques of MR acquisition, where the blood is labeled in the carotid artery before it enters the skull, and then that is used as a tracer for the analysis. And there is no exogenous contrast, so that's a great advantage. The acquisition time is in between 3 to 4 minutes, which is reasonable. If you go by dynamic susceptibility contrast, it's about 1 to 2 minutes, whereas for dynamic contrast analysis study, it's about 5 to 10 minutes, which I came to earlier. So this is right in between the two, but there are issues with it. We get cerebral blood flow quantification, but we don't get any other parameters which we need to use for oncology studies. This is a most commonly used technique which we routinely use in our hospital, which is dynamic susceptibility contrast. Basic physical principle is that gadolinium is a paramagnetic substance. It causes decrease in the signal intensity when you use a susceptibility weighted sequence. It is just like SWI or GRE sequence, where we see the blooming of the blood degradation products or see the hypointense signal in the calcium. So similar to that, multiple acquisitions of susceptibility weighted sequences following a rapid injection of gadolinium contrast is what we term as DSC imaging. Here, the first pass bolus is the most critical. The passage of contrast through the arteries, the veins, capillaries and veins is traced using multiple acquisitions, and that gives you a particular curve which I'm going to show you. And based on that curve, we can arrive at multiple parameters, including cerebral blood flow, cerebral blood volume, time to peak, mean transit time, perfusion indices. So many permeability indices are so many things that you can derive from the single acquisition in a reasonable, very short acquisition. The only problem in this is that whenever you come across areas where there is blood degradation products, it creates a difficult situation. So immediate post-surgically, when you are doing DSC perfusion imaging, you're going to have a little bit of trouble in the around your surgical cavity, and that makes a little limits your evaluation to some extent. So this is what happens when you inject contrast and acquire a susceptibility weighted images in sequential images over a period of about 60 seconds to 90 seconds. Okay, so the contrast initially passes through the aorta and then comes to the intracranial circulation. So as it arrives in the intracranial arteries, the signal in the voxel within the artery and then subsequently in the veins drops because of the susceptibility effects by the paramagnetic substance. This is traced over a period of time. From that, using mathematical principles, we decide the various parameters. The most critical component in this is the initial drop, which is the first pass of the contrast. Then subsequent, the contrast undergoes recirculation and gets distributed into the interstitium and then washes out. So that can also be traced subsequently, and each of these has a significance in the analysis. So when you do it for a tumor, because of the increased number of blood vessels in a glioma or any other brain tumor, there is going to be a more substantial drop in the signal in the tumor versus the normal white matter. So that is a principle that we use for interpreting tumor versus normal white matter in the brain. Various applications, pre-operative and post-operative, you can group it into two. Pre-operatively, first and most important thing is to differentiate tumors from mimics. This is very, very vital, because many times we go by purely by the imaging that we assume that it's a tumor, go in and end up with something that's not a tumor. You're going to be very remorseful of that. And of course, you want to try to differentiate the different types of tumors, glioma versus lymphoma versus metastasis. And then you can try to grade the tumor before your surgery and also plan your biopsy according to the area which has the highest perfusion, which is going to yield the highest grade of the lesion. Then you can also study the peritumoral zone. This is a misnomer. Peritumoral zone, what we mean is the non-enhancing components of the lesion, which are hyperintense on T2-weighted and FLAIR images, and the areas which are beyond those areas of T2-weighted and FLAIR signal, which are also containing tumor tissue, which is a very, very particular feature that we see in infiltrative gliomas, that the non-enhancing components of the lesion are also tumor. The FLAIR hyperintense areas are also tumor. The areas beyond the FLAIR hyperintensity can also be tumor, because the lesion tends to infiltrate. So studying that area is also one of the uses of perfusion imaging. Post-operatively, you need to do radiation therapy planning. Suppose you have a residual lesion, you want to see where the residue, which has the highest perfusion parameters, which area has to be boosted with radiation, and which area has a maximum tumor burden. Then we need to do response assessment before we, conclude our treatment. We need to see whether the patient is responding to treatment or if there's been any adverse effects like radiation necrosis or pseudoprogression. These are some example cases. I'm just going to show you here. This is a very classic case of what we call a tumefactor demyelination, which is a very, very good mimic of glioblastoma or any other brain tumor. But the very easy way of differentiating this, one is of course what we call the open ring enhancement, which is there in this case. At the same time, the T2, the diffusion weighted images are showing only peripheral diffusion restriction, and the clincher of course comes in the perfusion imaging. This is a DSC perfusion imaging. The right bottom corner image on the right side is a CBV map of the perfusion study obtained from DSC data. And you can see that there is no increase. Actually, in fact, there's a decrease in the CBV values at the periphery where the enhancing components are. So that is very unusual for a tumor. It doesn't happen in most tumors because there will be neovascularization and increase in CBV in most tumors. So that's a very useful. One more thing that you can do is differentiate tumors from mimics like toxoplasmosis, tuberculosis, or other granulomatous or non-tumoral conditions. This is a case of a patient who had presented with altered sensorium, and you have a lesion in the left thalamus. It is showing green enhancement. There is significant edema around it. Some mass effect is also seen. And we have a DSC perfusion data set. There is absolutely no increase in the CBV values. In fact, on the curve analysis, you can see that the later part of the curve beyond the first bolus is actually the signal is going above the baseline. So that signal above the baseline indicates leakage of the contrast from the vessels. It's an indicator of the permeability of the lesion. That is a classic feature with low CBV and high permeability of a granulomatous lesion or an infectious condition. So this is what turned out to be a toxoplasmosis. Okay, so similarly, even in tuberculosis, of course, there is one small problem here in tuberculosis. Many of the giant tuberculomas can have a little bit of increased CBV in the periphery, similar to tumor, but they will show increased leakage of contrast, which does not occur in gliomas. Okay, this is what we alluded to earlier, radiation necrosis. Post-treatment, it can occur up to 3 years. Post-radiation therapy. This is a case of an oral cancer patient who has radiation for a stage 4 disease involving the infratemporal fossa. And he came with for a follow-up imaging, had some seizures, and of course, you see a very heterogeneous enhancing in the left temporal lobe, which is not something that you expect in an oral cancer which has been resected. You usually don't get this unless it's a gross intracranial disease. So a perfusion imaging, of course, here clearly the CBV is very, very low, and that's classic of radiation necrosis. One more condition which we encounter is CNS lymphoma, which has been discussed in the previous talks. Again, in lymphoma, the permeability of the tissue is very high, but the CBV values will not be as high as in glioma. Now, the difference between CNS lymphoma and glioma comes in the extent of drop in the signal, that is the extent of CBV, the ratios, and in the permeability, which is the signal in the voxels you're tracking goes above the baseline. This is a feature which is seen in granulomas and in CNS lymphomas, so but not usually seen in gliomas unless it's been radiation therapy. So when you have this kind of curves, where you have a slight elevation of CBV values and a high permeability, you are very confident on calling this lymphoma. Of course, the morphology also is favoring lymphoma in this case, but some cases you will have difficulty between glioma and lymphoma in certain cases. In such cases, it can definitely help you differentiate between the two. Metastasis versus tuberculoma. This is a case, small ring enhancing lesion in the right temporal lobe in a male who came with seizures. Now you can see on the T2 weighted images, it's got low signal intensity. It's got a little bit of blooming at the periphery on SWI. rim enhancement is seen and there is some diffusion restriction, then you are really confused whether this is a tuberculoma or it's a metastasis or any other primary neoplasm. So in such cases, when you do perfusion imaging, it gives more information. Now people go ahead and do spectroscopy and try to differentiate. Spectroscopy has its own limitations. Now, for example, in this case, there was a big lipid lactate peak, which is a classic finding in tuberculoma. Now, lipid lactate peak is just a reflector of necrosis in the lesion. It's not a direct evidence of being a tuberculoma. So when you do a perfusion imaging here, you can see there's a drastic increase in the CBV values at the periphery of the lesion. Now you can see the curves, the blue curve on the bottom here is where the lesion is. The other is normal white matter. The curve has, it's come down all the way down and the signal never comes even close to the baseline. It never recovers to the baseline. So what we call a percentage signal recovery is very, very low. So when I have a low percentage signal recovery, it is unusual for a tuberculoma. So this was thought of as a neoplasm and a biopsy was done, it turned out to be metastasis. Okay. So spectroscopy may be confusing, but perfusion tends to give a better evidence in cases where you have difficulties in differentiating tuberculoma versus metastasis versus glioma versus lymphoma. Okay. Now, this is from the literature. I didn't have a good similar analog case. The first case, of course, all three cases are ring-enhancing lesions. Okay, and we have perfusion analysis done for all three. The curves are shown because the curves are very, very important, not just the CBV values. In the first two cases, the A and B are of the same case, image A and B top left two images. You can see that the signal recovers above the baseline. That itself tells you that it's either a lymphoma or it is a granulomatous lesion. But you also see that there's a substantial high level CBV. Now CBV is extremely high, but the lesion signal goes above the baseline. That is not usual for a glioma. So those that lesion typically, is not going to be glioma, but you can probably think of a lymphoma in this case. So that was biopsy shown to be a lymphoma in this case, in the first one. The second one on the top right corner is a color map, and the image on the bottom left, this is this second case, where you can see that there's a significant drop in the signal on the first pass, but the signal never recovers and the CBV is elevated, significantly elevated. That's a glioma. Okay, so the curve never recovers to baseline, whereas in lymphoma, the curve can go above the baseline. And then, of course, one with a low CBV, okay, and some recovery of signal to the baseline, that's going to be a metastasis, a significant, elevated CBV with low recovery to baseline, that can be a metastatic lesion. So those are the way how you differentiate lymphoma versus glioma versus metastasis. You can get to some level of accuracy there, but not entirely 100% accurate, but definitely you can plan, like, suppose you have a patient who has not had a PET CT and you have only an MRI. At least you have an idea that, okay, this may not be a glioma and you need to do a PET CT before you do a brain biopsy so that you can at least pick up a primary in such case. Okay, so that's the way for pre-operative planning, it helps in this imaging helps. This is a case for pre-operative planning also we can use. You can see that there's a lot of hyperintensity on T288 and flare images in this lesion. And there is some areas of blooming, very minimal contrast enhancement. Now, glioblastomas, initially people used to think that the enhancing component is the most important component. It's not true. The area that is maximum important in a glioma is where the CBV is the maximum. That's where the highest grade of tumor is going to be, not the area where there's enhancement. Enhancement is due to blood-brain barrier dysfunction, whereas CBV elevation is due to neovascularization. So it's far more important to see where the high areas, where the high CBV values are. So that's why perfusion map, you can see that the highest perfusion is the green areas, which is close to the ventricular margin, and that's not the area where the enhancement is. So that's where you need to actually get your tissue from for getting the correct stage grading. Similar case, a younger patient who had a cystic lesion, solid cystic lesion in the left frontal lobe, some areas of hemorrhage in the lesion. This child was actually a post-treatment case of non-Hodgkin lymphoma who came with seizures. Now we are confused whether this patient has a lymphoma recurrence in the brain or a glioma. On a morphologic imaging, this looks more like a glioma, because usually you don't see hemorrhage, you don't see cystic changes in lymphoma. So then you need additional information, you do a perfusion analysis, and lo and behold, the curve does not go above the baseline. When the curve does not go above the baseline, as in both the voxels that are placed here, again, that is in favor of a GBM. So this was subsequently operated and subsequently it was proved to be glioblastoma, a second malignancy in a patient who was treated for lymphoma. Post-operatively, you can use perfusion for looking at where the residue is. This is a case of a young male who had a surgery for a oligodendroglioma, and post-operative an MRI was done, and you can see on the contrast enhanced imaging there is no enhancement. So people are going to be very happy. Oh, there is no enhancing tissue left. There is no tumor, so we can radiate, without any real hassle. But the issue is most oligodendrogliomas don't enhance at all in the first place. But on perfusion, we can see that there is significant increase in the perfusion indices in the periphery of the surgical cavity, especially in the left temporal lobe. So that definitely is residual tumor, and you need to target that area with your radiation therapy. Tumor progression, of course, it looks far more aggressive on the morphologic imaging. There may be enhancement, there may be edema, there may be mass effect, but you want to confirm it, rule out pseudoprogression, rule out radiation necrosis, and your CBV maps is one that really goes in favor of this. It gives a very high perfusion CBV values with the curves not going above the baseline, very comforting to tell that this is tumor progression and not radiation-induced changes. Another case, similar, this is several years after radiation therapy. This is 3 years post-radiation. She came back with a, for follow-up imaging, you have heterogeneously enhancing lesion, you have worried it is tumor. You do a perfusion imaging, absolutely no CBV elevation, actually decreased in CBV, dead tissue. So that you're very comfortable calling this radiation necrosis and comforting the patient, putting her on treatment for radiation necrosis rather than going in for a rebiopsy. Pseudoprogression, of course, we see this in patients who are in 3 to 6 months within radiation therapy, significant edema, mass effect, midline shift, lot of increase in the lesion size compared to pre-operative radiation therapy. But you can see that there is absolutely no increase in the CBV values. There is no area which is showing increased CBV or any evidence to say that there is increased perfusion in the periphery of the surgical cavity. And this is classic pseudoprogression. This patient was treated accordingly and did pretty well. We have the follow-up imaging of this patient. This is the pseudoprogression, the initial pseudoprogression where there's increase in mass effect and there's enhancing lesion there. There is no perfusion, increase in perfusion. And so subsequently treated accordingly, you see that this all starts resolving on its own. Patient does very well and actually is still alive after this treatment. This is pseudo response. I didn't have a case in my study here because we have not been using anti-hygienic medications here in our institute too frequently. So I didn't have a case of it. So I had to borrow it from literature, and the contrast enhancement disappears after anti-hygienic medications, bevacizumab. It disappears and gives you a false sense of comfort that your treatment has worked, but it hasn't worked. What unveils the truth is a CBV map. It shows increased blood values, CBV relative cerebral blood values around the cavity, which is where the enhancement was previously, and that actually tells you the truth that this is not actually a patient who has responded to a therapy. It's pseudo response. Coming to summary, it's a very indispensable tool. Any person, any institute that does a good volume of neuro-oncology definitely should be doing perfusion for all cases, pre-operative, post-operative, follow-up, all cases to get it. Irrespective of the indication, we always do it because that information cannot be derived from any other MRI tool. And we don't have any additional cost of doing it except having the power injector. The contrast bolus is the same that we use for the post-contrast T1 imaging. The only problem is you need a power injector, and if somebody can come up with a solution to avoid the expense of a power injector, that would be a really nice way of boosting the usage of perfusion imaging in routine practice. I would say upwards of 90% of MRI machines don't have a power injector with them in India. That's a very sad situation. Okay, and of course there needs to be some awareness. You need to train people to use perfusion imaging, interpretive perfusion imaging. That's of course the radiologist's job. If we can get this popularized and more utilized, it will be really good. Any questions?
Thank you. Thank you, Dr. Harsha. Any questions? Any question from the audience? I want to ask one question. Does this perfusion imaging help in grading the tumor?
Yes. Yeah, elaborate tumors will not have CBV elevation. Grade 1 and grade 2 gliomas will usually not have elevated CBV values. So that helps, if you see, especially in suspected oligodendroglioma or astrocytoma, if you're seeing areas which are showing high CBV, that correlates with the grading. It's probably going to be grade 3 or grade 4. We can't differentiate grade 3 from grade 4, but we can definitely try and tell you that this is now grade 2, most of the cases, okay? So there is a good amount of sensitivity and specificity in that, you can tell with the perfusion imaging.
And response to treatment, will it be used lymphoma?
Yeah, so when you get radiation therapy, definitely the CBV values fall. So if you have seeing a patient do well, then CBV values sequentially from the preoperative postoperative. If you have preoperative and postoperative comparison, it's really, you have a longitudinal data set, then definitely you can say that the CBV was elevated in this area, it's come down now, that's a good sign. Along with that, definitely there will be residual decrease in the edema and mass effect, right? So adjunctively, you can always help in prognosticating, seeing where the patient is going.
Thank you so much. Yeah. Any questions?
Yeah. I don't know if that's the right thing to ask, but how does this compare for tumor response or to differentiate between pseudoprogression and radionecrosis with PET MRs and PET methionine PETs, which are being done by other institutes? We don't have the facility, but
I think both are valuable. Definitely, I don't have a specific comparison side by side. I don't have the data with me right now to tell you which one is better and which is not. Definitely, DOPA, if its availability is very limited. How many institutes in India will be able to do it? But perfusion can be implemented in any MRI machine which is 1.5 Tesla upwards, provided you have an injector. So the availability, definitely wise, perfusion imaging is far widely available. Side to side comparison, I am not aware about which one is better, but maybe FDG will do a slightly better, DOPA PET will do a slightly better job at PET with MR may do a slightly better job. I am not aware about the literature on that. I'll have to review that.
Okay, so I'll answer the question. So there are a lot of papers which have analyzed, especially the main problem in clinical setup is when we see a patient who's come after surgery, radiotherapy taken, glioma, when there's a lesion. At a cross-sectional level, you need to decide whether this is recurrence or radiation necrosis. That is a day-to-day problem for us. And if you look at the literature, there are many papers which have talked about sensitivity and specificity of individual techniques. You can divide them, the modalities into three. One is morphology, that is MRI and contrast MRI. Second is imaging, advanced imaging like perfusion imaging, spectroscopy and diffusion. And third is metabolic imaging, whether PET or SPECT. In PET, you have multiple different traces, whether you will use FDG PET or you will use the methionine PET, various techniques. So all of them will hover around 60 to 75%. But there are papers which have compared combined use of these technologies. Let's say spectroscopy with perfusion with PET. So there are papers which show that the use of combined technologies will give you a higher sensitivity and specificity compared to a single modality. And if in the combination, actually, I think ASL perfusion with contrast enhancement spectroscopy with one of the PET techniques will give you the highest sensitivity and specificity. They do not reach 100%. The rates I don't remember offhand, but they will reach around 80 to 85% sensitivity in diagnosing. We don't call them as radiation necrosis now anymore. It's called as treatment effect, because like they talked about in both the lectures, you can either have a pseudo response or you can have a pseudo progression. Both put together is now called as treatment effect. This can be either due to radiation or chemotherapy or even due to immunotherapy. All of these therapies can result in varied imaging features of the lesion, whether they are recurrence or the treatment effect is confusing. There are papers, I don't remember, the values are somewhere around 80 to 85%. And combined use of these technologies are more beneficial and more accurate than a single technology.
But side-by-side comparison of the two, I don't think, is there any literature? I don't know how that.
I don't remember offhand, but there are a lot of papers I can share. We have written a chapter also regarding that. Even there's a paper from India group, I think from SGPG Lucknow, where they've analyzed using multiple modalities, the same patient, and looking at the sensitive specificity. And comparing one versus other is also there.
Okay.
A PET versus perfusion, like that, there papers, lot of papers are there.
All right.
Any other questions? There are no other questions. I think we are concluding this session, and we have the next case discussion. Dr. Harsha, please.
Thank you to all the speakers and the chairpersons. For the next session, we have a panel discussion on stereotactic radiosurgery and advanced radiotherapy techniques. For that, I call Dr. Shivu Pillai, Dr. Saurabh Kumar, Dr. Hiba Altaf, and Dr. Nishant Sadashiv to come to the stage, please.
One will always be here. So good afternoon. I guess fatigue is setting in. Everybody is looking weary, but let's get through the next session. Basically, last lecture introduced stereotactic procedures and specifically radiosurgery initially. So he used a frame-based system to sort of create a three-dimensional map of the brain and then used that to focus electrons onto the tumor or for functional radiosurgery. So basic principle of the thing was that you have multiple beams coming in from multiple directions all around the head, and they all meet up at the point where you want to target the therapy. So because there are multiple beams from all directions, the rest of the brain gets very little of the toxicity, and the main effect is on the lesion that you're trying to generate. So ultimately, the idea of whatever stereotactic radiosurgery planning is to minimize the side effects. Depending on the pathology, the kind of side effects you can develop varies. So the important structures will vary depending on where exactly you're targeting it. For example, in a vestibular schwannoma, it may be the 8th nerve or 7th nerve or the brainstem. If it is in the sella suprasellar region, it might be the optic chiasm. So depending on which region it is, you might have to adjust your dosing such that the normal structures get the minimum. So we'll discuss about that as we discuss the cases. And it can be used for multiple lesions. Most often, most of us use it for benign pathologies in India. So it could be things like schwannomas, meningiomas, or others like AVMs. Glomus is a good indication. Abroad, in fact, the commonest indicator is metastasis. Here in India, it hasn't picked up as much, but it has potential and there's significant effect as we'll discuss. So let's move on to the cases. This first case is a 14-year-old child who came here with reduced hearing in the right ear for 6 months with occasional tinnitus. And other than that, there was no other significant problem. Child was perfectly normal, and this was the pathology. So diagnosis was that of a glomus. So now the options, Nishant, what would you think are the potential ways to treat this pathology?
Because the lesion is measuring less than 10 cc, the first option should be to consider radiosurgery. So we have to, because
why do you think radiosurgery is preferable to surgery at in this situation?
Yeah, so there are multiple publications as well as experience which tells that surgical morbidity is very high. Especially with glomus tumors, most of the lower cranial nerves are entangled within the lesion. And according to literature, the lower cranial nerve morbidity is approximately 40 to 80%. So, but the same amount of morbidity is not there in radiosurgery. In fact, even surgical mortality is up to 4% in cases of glomus tumor. So the first option should be radiosurgery in such cases. If the lesion is ideal for radiosurgery because it is less than 3 centimeters and the volume is less than 10 cc, even if the lesion is higher, we can consider fractionated radiosurgery. There are publications which tell that previous embolization followed by surgery reduces morbidity, but still the level of morbidity is higher compared to radiosurgery.
Yeah, so that's what we did. And we planned for radiosurgery, and this is the treatment planning for this child. Post MRS, there's been a definite response. The hearing didn't really worsen. And so this has been the general treatment for glomus now. Almost, there are hardly any situations where we may consider surgery. Even in patients who come with lower cranial nerve involvement, hoarseness, difficulty swallowing, those things we have found that once you give the radiosurgery, all those symptoms actually improve. So definitely, I think compared to surgery, SRS is definitely the first thing, especially within the range of size that is amenable for SRS. We recently had a patient with glomus where the extension of the glomus was quite low into the neck. So although we considered SRS, we couldn't really target the lower end of the lesion. So then subsequently, I think we decided that we should opt for surgical excision of the lower part of it so that we reduce the size of it because the lower part was accessible. And probably that wouldn't have much morbidity, and then do SRS for the rest of the upper part of the lesion. So for the next case, so this is one of the
One point I
papers
want to
about
make
this.
is like for
Pardon?
glomus, because it's a benign tumor, we can even consider fractionated when the tumor volume is quite large. You can consider fractionated stereotactic therapy, frameless ones, where we can give radiation 25/5 or 30/5 is also an option where the control rates are pretty good.
Yeah.
In LINAC-based therapies, posterior fossa and lower located tumors, it's a problem actually. Close to brainstem, and even the lower the lesion, the accuracy of delivery is also a bit questioned.
Yeah.
So
I think,
that's when
our experience with neck and that you
that's
can
when
share.
the modern gamma knife treatment comes in. So the modern icon based treatments can reach, like we have treated tumors which have reached almost up to C3, C4 level.
Okay.
If there is an intact or the lesion is attached to the skull base where the chances of movements are less. So definitely gamma knife radiosurgery should have been considered.
But what about neck movement? Doesn't that change? Like for
Because-
example, the position of the neck during the initial imaging versus later doesn't really matter.
No, like actually speaking, when we fix the head, usually it remains the same, especially because the tumor is fixed to the skull base. Usually it doesn't move. So that's what is understood, and that's what is matters.
So the dilemma what we used to face is because we have for SRS, we have a frame-based system. And the imaging, the planning is done on a CT, and this is done. So there is a neck movement, and then the carotid artery also moves. So there you won't get the matching. But with the frameless basis, wherever we are doing a frameless with a mask, if you are able to do it, there the reproducibility is maintained. So if you're doing a fractionated one, we won't have that. Or if we are even doing a frameless stereotactic radiotherapy on LINAC, it is definitely possible to reproduce the same.
What about between the two, which if for a same size lesion, would you prefer fractionated versus single dose?
For a large tumor, I would consider fractionated because cervically you can spare a lot of other structures.
No, for a limited size within, say, like this.
No, I'll go for single dose.
And for frameless, we usually give 1 or 2 mm margin, which we don't give in one with frame. So that gives us a little bit of a leverage that if the patient is still moving. So, and that will be better in the fractionated, not in SRS. In SRS, we usually will not give any other margin, but in fractionated and frameless, we can give a 1 or 2 mm margin. So that gives us a.
Next, Saurabh, you can take. Go ahead.
My only query in this patient is a 14-year-old child. So I'll be very hesitant to make a glomus diagnosis in this child with only an MRI. Even the data you showed, no, it's usually glomus is late young age and middle age patients.
Yeah.
The diagnosis of a glomus jugular in a 14-year-old child is very, very rare, and that's something. I mean, at least a DSA or something showing vascular lesion as opposed to a bony lesion, because radiosurgery may work in all. The dose differs between the lesions.
Right.
So very young child, we have to be.
The next case is a 66-year-old male, a known case of cirrhosis with decompensated liver disease. He underwent live donor liver transplant at our institute in June 2019. So explant liver showed a grade 1/2 hepatocellular carcinoma, PT2N0M0. Though that lesion was not picked pre-op and even any imaging, the very small lesion. So it was kind of a complete treatment for the patient and no adjuvant treatment was offered. On PET CT in Jan 2022, the transplant liver in the hepatic region with no abnormal mass lesion, FDG with no abnormal FDG uptake, no significant FDG avid periportal or portocaval lymph nodes. There was a hypermetabolic lytic lesion in the T10 vertebral body with soft tissue component of concern of distant metastasis. Thoracic MRI spine was done on 11/1/22. It showed a mild expansile lesion in the left half of the T10 vertebral body with adjacent marrow edema and pre- and paravertebral soft tissue thickening consistent of metastasis. So this is the imaging, the MRI imaging as well as the PET and CT. So what other investigation would you request? Dr. Hiba, what?
We will definitely ask for one is the PET scan to see the extent of the disease, and second we will ask for a local MRI to see whether there is any involvement of marrow in these patients.
Any other test? Do you think there is a need for biopsy because the surgery was done in 2019 and now previous PET scans didn't have anything, but right now on MRI and imaging you can see there is a lesion there.
Usually if a recurrence occurs after a significant period of time, we should ask for a repeat biopsy, but it may not be an option in all patients. But yes, if it is surgically feasible, we should get a biopsy to confirm the diagnosis.
Okay. So patient's AFP was elevated, it was more than 1000. In hepatocellular carcinomas, in a patient who's already had and whose AFP had come to normal, now the AFP is risen again. So still do you want to go ahead with the biopsy or do you want to go ahead with the treatment based?
For AFP based, like in hepatocellular carcinoma, if AFP is raised and we have a lesion on liver, that may be enough for the diagnosis initially. Here also we can take a call if the patient already has a high AFP, we can go ahead without biopsy. So
for this patient, we did a biopsy and it confirmed the diagnosis. So from the neurosurgery side, would you want to do anything, Dr. Shibu?
I think
is there a need for spinal stabilization or anything like that in this patient?
It doesn't look like there's any spinal cord compression and the bone itself seems reasonably okay. So I think we can go ahead with direct.
So this is the SIMS stability scoring for the spinal, whether there is a need for any spinal stability fixation. So this score will come to around 5, which is like a stable spinal disease, and hence the patient was taken up for a radical. So he's a oligometastatic hepatocellular carcinoma, solitary lesion, and spinal metastasis is one of the most common sites of metastasis other than brain metastasis. And there is, based on the location, we will be considering different forms of stereotactic therapy. So we have planned for stereotactic radiotherapy, 30 gray in 4 fraction. This is delivered from in Jan 2022.
and a PET scan and an MRI was repeated on follow-up after 3 months, and there was a complete metabolic response, as well as on MRI, there was no progression. The lytic lesion seems to have stabilized, and the soft tissue also had responded. So the second case is an 82-year-old female from Raichur, a known case of RCC clear cell type, post-radical nephrectomy in August 2011. Patient has been on close follow-up since 2012. CCT in 2015 showed multiple nodules in both the lungs. Patient was started on systemic therapy, a monoclonal, some immunomodulatory drug called pazopanib. In June 2016, CCT showed partial response. In October 2016, there was no evidence of any local recurrence, mild increase in the size and number of non-hypermetabolic lung nodules. In 2018 MRI, there was a well-defined enhancing extra-axial signal intensity intradiploic lesion in the parieto-occipital region showing diffusion restriction with central necrosis, likely represents a metastatic lesion. And also there was another lesion on PET scan, a lesion in the clavicle, osteolytic lesion in the clavicle. FNAC of the lesion from the clavicle came as clear cell carcinoma. So any further investigation would be required from your side? What scans would be, what is the imaging modality of choice here?
Clear cell carcinomas of renal, they have actually very good survival, and these patients actually do very well on systemic therapy. So whenever they present with any metastasis in brain, we have to make sure to check the extracranial, what is the extent of the disease. So these patients, again, since biopsy has been already done, PET can be done to see the extent of the disease extracranially. And if patient has only 2 of these lesions, we can offer them highly focused radiation instead of a palliative, that is a whole brain radiation. So those patients will actually do much better with stereotactic or radiotherapy or radiosurgery, depending upon the size.
So this is the lesion in the brain. Sir, do you consider, would you consider surgery for this patient in any way? Like,
I don't think there's any advantage in surgically removing it. For one, it'll be stuck to the sinus region, and it's not like you're going to completely excise it. And so a direct adjuvant therapy is probably good enough once we have a diagnosis.
So any of the solitary lesions, what would be your criteria to offer surgery over stereotactic radiosurgery in the current?
Surgery would be if the mass is so large that it's creating mass effect and the risk of herniation. So those kind of situations, you would need to operate for the mass effect it's causing. Other than that, I think for a lesion which is most likely to be a metastasis, I think directly some form of radiation therapy would be the first thing. And both in this situation as well as multiple brain mets, we could consider stereotactic radiosurgery.
And post-surgery, do you consider stereotactic radiotherapy to the post-op volume, or what is the current?
Sorry,
post-surgery, complete resection, would you consider adjunct again stereotactic therapy?
Yeah, so there are different things which people have tried. Either you operate, take it out, and then give whole brain radiation. So that's typically what's being done.
Yeah.
So whether we should, once you excise it, I don't know what is the role of giving radiosurgery, because essentially you've taken out the lesion completely. So then I don't think there's any role for radiosurgery. Either you just wait or you give whole brain. What do you think, Nisha?
Approximately what is the size of the lesion?
This lesion? This. No, I'm not asking for this lesion. This, I think, obviously here surgery might.
Generally for
brain metastasis.
Generally, brain mets, if it is a solitary lesion which is large, causing mass, we should consider surgery as first option. But if there is no mass effect, or localized lesion, or even multiple lesion without causing mass effect, I think the first option in this era should be radiosurgery. But in this particular case, there are umpteen number of evidence telling that post-operative bed radiosurgery can also be considered, provided that the risk for the patient to develop multiple metastasis in the future is there. In this patient, I think if the patient has the volume of this lesion is more than 3 to 4 centimeter, and if I think that surgically I can totally remove it, because it is not inside the brain, and the skull, if I can take out with a margin, I think I would give another thought about surgery, and I would consider surgery as well.
Hiba, what is your
It's
take?
an RTOG study basically, which has compared surgery followed by SRS with whole brain. Yes, with whole brain, they had decreased recurrences in rest of the brain, but their cognitive improvement that got affected. So now they are suggesting that surgery followed by stereotactic radiation may actually improve the progression-free survival. Yes, there will be still a risk of developing metastasis in the rest of the brain, but it will be still better than surgery alone. And surgery in a single, especially solitary metastasis, may actually give us overall survival benefit in certain set of patients.
So this is a very interesting meta-analysis of patients with brain metastasis only who have got surgical resection versus stereotactic radiotherapy. So basically here there is a subset of patients who have got whole brain radiation who have got surgery versus the ones who have gone for whole brain or this one. So wherever they have done surgery, even with whole brain radiation, there has been some kind of local recurrence. The forest plot is more in favor of whenever you see for 1 year survival or this one, 2 year survival, there is a poor prognosis in patients who have undergone surgery without any adjuvant therapy to back it up, like SRS or whole brain. Even if you do some form of radiation, the 1 year and 2 year survival has increased by a significant proportion. So there is also, like we were discussing, I think there was a point made that in the West, there is more and more.
The only thing is, should you, like, once you've taken out the lesion, why don't we just wait for the next lesion to appear and then give SRS for that instead of giving it to the bed? Is there an advantage in that?
So that is what. No, I think we are still in that dilemma, but that is what this.
Why don't you just wait for the next lesion to appear again?
So that's what was checked in that study, that patients who had surgery with SRS, because versus whole brain, it makes sense that whole brain will take care of rest. There is a benefit, but why SRS? They found that with compared to surgery, there was some benefit in progression-free survival in those patients, those who have received. So yes, once the patient develops another metastasis, patient will be again amenable to most likely SRS only for that lesion.
Another important issue is most of these metastases have surrounding micrometastasis. So we will not be removing that. And if you see operated case of metastasis, the recurrence usually happens in and around the operative cavity.
Around the bed.
Always there will be some recurrence. Even other metastases occur. Usually subsequently, if you follow up long enough, there will be recurrence of the lesion in and around the operative cavity. That means to tell that there was a micrometastasis which we were not detected. So it has all the benefit of giving radiosurgery to the cavity.
To the cavity post-op, I think we have to give. From this study also, whenever they have found a local recurrence, again, they have given SRS or whole brain. But the final outcome, they're seeing that ones who have got immediate local therapy have fared better over the ones who have got some local therapy at a later point. So the other question is single fraction SRS versus fractionated stereotactic therapy. The advantage, I think there's always going to be a debate versus fractionated versus single fraction.
So we feel that fractionated sometimes the normal tissue tolerance and the OIR doses can be reduced significantly, especially in large volume tumors. So this is a study where they have compared fractionated SRT versus SRS in metastasis. And so whenever you talk about local control, they found that in comparison with SRS in metastatic setting, fractionated fared better over single fraction radiotherapy. The reason being probably for a large size tumor, the dose starts reducing by the RTOG 9005 study.
So it is very much true in cases where the lesion is bigger. If you see literature, the initial studies were 2 centimeters. For example, if 2 centimeters was the cutoff where they studied that fractionated was better.
I think this is a study where they have taken 4 centimeters.
4 centimeters, yeah. So there is difference in different studies where they considered whether it is what is big. So if you consider radiosurgery in the present era, where the lesion more than 3 centimeters, even people who give radiosurgery, they would consider fractionated radiosurgery. So the proportion of patients who get complications like radiation necrosis dramatically increases over 10 cc. So some people tell that it is 8 cc, some 10 cc, 12 cc, but higher the volume, we have to understand that radiation necrosis and complications can be higher. The occurrence of radiation necrosis as such is not a major complications in treating. For example, it can be managed. Okay, so we have to consider that as well. Just because there is a chance of radiation necrosis, that doesn't mean that you should not choose that modality. There are higher chances of radiation necrosis if it is 8 cc, but still, if there is radiation necrosis, we can manage it by anti-edema and other stuff. So we should not shy away from single fraction radiotherapy just because we are more concerned about radiation necrosis. But it is true that if, for example, if there are 2 or 3 lesions and one is 3 cc, another is 3 cc, it is better to go for hypofractionated than single fraction.
So Nishan, just coming to the same question, how many lesions and what would be the spacing? Suppose it is scattered throughout the brain, what would be the number of lesions, or what is your cutoff to consider for fractionated versus or any form of stereotaxy in a brain metastasis patient?
I think we should refer to Dr. Yamada from Japan. He's, I think, the pioneer of treating patients with multiple metastasis. Initially, before his research came, I think 4 was the cutoff. So subsequently, we have moved away from the number of lesions to total volume of lesions. So higher the volume of the metastasis in the brain, more chances of complications. So we should not go away from stereotactic radiosurgery just because there are 10 metastases or 15 metastases. For example, if there are tiny metastases throughout the brain, still radiosurgery should be the first option. And if the total calculated volume of the brain metastasis is more than 12 cc to 14 cc, then the proportion of patients who get complications from that is reasonably high. So, but by any way, higher number of metastasis doesn't mean that giving radiosurgery is equal to radiotherapy or whole brain radiotherapy. It is not equal to that. So the number of lesions doesn't matter. Right now, throughout the world, people give until 15, 20, 25 metastasis. If it is small, they give. But if some of the lesions are more than 2 centimeters, they go for fractionated treatment for only the bigger tumor.
But do you have any point to make? Like,
and the issue is with the size also, that the dose is less. That if you have a tumor size of less than 2, you can go for 24 grain single fraction. And as it increases to 2 to 3, you go to 18, and 3 to 4, you go to 15 grain. So that may also affect. So it's better to go, the larger the lesion, it is better to go for fractionated. And yes, officially and guideline wise, they usually recommend 4 or maybe 5 metastatic sites. You can go ahead, but it, I think, depends again on the size of the tumor, and it may also should be kept in consideration the biology of the tumor that the patient has. The patients with good biology, even if you have small many tumors, it's better to go for SRS than for the whole brain in those patients if they have a better outcome.
One thing I want to add is the indication for whole brain radiotherapy in a case of brain metastasis right now is dwindling, and it should be kept for a patient where you cannot keep giving radiosurgery. For example, a patient who has 5 metastases now, you give radiosurgery, and the patient gets another metastasis after 2 months. You can give radiosurgery for further metastasis. Whole brain radiotherapy should be considered only in completely disseminated tumors, or if you think there is patient is not able to tolerate, or patient is not able to come back again and again for radiosurgery. So as of now, whole brain radiotherapy is not the procedure of choice for brain metastasis as such.
So this patient, I'll come back to that point. So this patient, and we have done basic planning, 3D CRT based stereotactic fractionated radiotherapy, 35 gray in 5 fractions. This was done in 2019. Patient is on regular follow-up with us on systemic therapy, and there is no new lesions, and the lung metastases are stable, and patient is on pazopanib systemic therapy. So in oncology, the dictum is tumor biology is king, case selection is the queen, surgery, RT, chemo are prince and princesses. Prince and princesses may have occasional victory, but the king and queen rule. So anytime we have a brain metastasis, I call my medical oncologist and ask them, what is the prognosis? If they feel there is a targeted agent, if it is a good biology disease, you can do with anything. You can try and we can even observe some of the brain metastasis. Recently, we had a brain metastasis, 3 brain metastasis patient who was put in ceritinib systemic therapy, and we didn't treat the patient. So this is a new concept where you don't give radiation also, we just observe the patient also. But if it is a bad biology patient, these 3 metastases turned out to be 15 when Sri Harsha did imaging at 3 months. So I think at the key thing will be what is the molecular, the evolving molecular biology of the tumor is what will tell us where we are standing. And I don't agree with the thing that whole brain radiation is gone for the era, because stereotactic radiosurgery, the cost is also a factor, and repeatedly it is not feasible for financially or to this one to consider SRS on a regular basis.
I agree. And if you see recent publications, most people, especially from the Japan and the US, they are specifically like, you cannot do a study just telling that it's a brain metastasis right now.
Yeah.
So if all things are like, for example, prognosis of renal cell carcinoma, prognostic score for brain metastasis is different from a score for an adenocarcinoma colon. So, so like they have scoring system for all cancers with brain metastasis. So for example, your recursion partition analysis, all these scores, whatever scores are there, in spite of all those scores in the present era, I think you have to see what is a primary, what is a treatment given, especially if you are giving immune therapy. So that dictates the treatment and prognosis more than anything else right now.
Yeah, so that's what. So basically, we have to titrate whether we consider SRS or this one should also depend on the tumor biology. Unless there is going to be a good prognosis or this one, there is no point in doing a very fractionated, aggressive
and
treatment.
I think ultimately we have to give the patient the options available.
Yeah.
And they may have to decide based on their circumstances.
And their
things.
circumstances.
Yeah. So I think we'll move on to Nishant's case. Any comments from the audience while Nishant sets up his computer? Go ahead.
one of the points in favor of radiating the tumor bed was that there is a high incidence of micrometastasis.
Yeah.
At the time of diagnosis of any intracranial metastasis, it has been shown that many of them have undiagnosed micrometastasis at other parts of the brain. So isn't that one of the reasons that people used to say that whole brain radiotherapy is something which should be done?
Yeah, that's the basis for giving that, but what, go ahead.
So that micrometastasis, once it become macrometastasis, we can treat that. So there is no need to treat the micrometastasis with whole brain radiation, and that radiation you are giving includes normal brain also. So it need not be treated like that. It's been proved by multiple randomized control trials that people are moving away from whole brain radiation.
And there is one more point with whole brain radiation, that once the patients who undergo whole brain radiation, they have developed neurocognitive decline over some time. And they have observed that patients who receive SRS, although they are at high risk of developing recurrence, but you can delay that neurocognitive decline in patients and give them a better progression-free survival just with SRS or surgery followed by SRS. So we are just trying to delay the occurrence. Either it is give whole brain and patient will have a neurocognitive decline, or just wait, and once the patient develops a single, one more metastasis, then treat them again.
So I'll start my case presentation. This is a middle-aged female patient who presented to us with history of tinnitus, and patient underwent imaging as well as audiological evaluation. So the MRI showed left side cerebellopontine angle tumor going into the internal auditory meatus, which was around 1 centimeter in size. And when audiology was done, it showed that patient has just about serviceable hearing. Patient has serviceable hearing, but patient has a left CP angle tumor, which is probably a vestibular schwannoma. What all a surgeon would think before he treats, and what would be the ideal management strategy? I would open the discussion.
So this person has hearing which is sort of serviceable, but obviously it has been deteriorating over time. It's quite small. So surgery, I don't think open surgery is not an option. I think not worth taking the risk. You're likely to end up worsening the hearing at this point. So now what remains is observation versus stereotactic radiosurgery. Between the two, I think at this point, if you give SRS, you're more likely to have a slightly better preservation of hearing compared to observation at this point in time. So probably that's what would be the best option. So that's what other things in this patient, when you give the dose prescription, you should make sure that you don't end up causing some facial nerve problems. So that is, although nowadays with the kind of prescriptions that are advised, chances of facial nerve problems are very low, but we have to make sure that doesn't happen. So cochlea and facial nerve are very important in the dosing.
So the point to stress about here is, like earlier we used to tell that a patient who has a good hearing and serviceable hearing, we didn't consider SRS at all. So we used to think that radiation can cause damage to hearing. So that's not the case now. We know that from longitudinal studies, it has been proved that over time, hearing loss happens in even intrameatal and small vestibular schwannomas. And at 10 years, 33% of the patient only have hearing at baseline, will remain with hearing if we don't treat at all. Compared to that, if you give radiosurgery, at 2 years, 5 years, and 10 years, there is far more proportion of patients remain with intact hearing than compared to observation. So observation of a patient who has a small vestibular schwannoma with intact hearing, radiosurgery would be a better option. Like this, how we would treat is like this similar patient. This is not the same patient.
What about tinnitus? How severe is it, and what will be the option if whether it is surgery versus SRS?
even tinnitus, it has been proved. I will show some of the publications that radiosurgery, tinnitus also, even disabling tinnitus comes down with radiosurgery. With surgery, for example, a patient has intact hearing, and if we can do a surgery and preserve hearing, which happens in around 50 to 60% of cases. So, for example, 100 patients, if we operate like this, we can preserve hearing only in 50 to 60% of the cases after surgery. So, obviously, radiosurgery has far more preservation of hearing than surgery. But the literature tells that if we operate and preserve hearing, the long-term hearing of that patient remains stable. For example, after surgery, patient's hearing is totally fine. After 10 years, hearing will be good still. But compared with radiosurgery, after 10 years, only 64% patients can remain with hearing. That is one favor, which favors surgery. But the surgery for such cases, preserving hearing, has, like, with the best of the hands, it is 60%, which is not always replicable.
And probably you have to take the level of hearing now is probably not one which may be preserved even after surgery.
Yeah.
If it was even better hearing, then maybe you could still consider that.
Yeah, even the preoperative hearing, for example, this patient already has close to serviceable 50, it is close to 50. If this is the case, even radiosurgery, observation, surgery, all have equally bad prognosis. The worst is with surgery. If the patient is already having hearing loss, if we do surgery, we are more in favor of patient losing hearing than preserving hearing. So in this case, the ideal choice would be radiosurgery. So this is a patient who I saw recently, so we have not treated this patient yet. But a similar patient who we have treated here with gamma knife radiosurgery, we have treated with 12 gray at 50% isodose line. We can see the peripheral rings here, like which is the yellow line is 12 gray line, and following that is 8 gray, I think 5 gray, and the 2 gray line. The peripheral line is 2 gray line. Around 2 to 3 mm of the brain stem receives 2 grays. That means the dose follow-up is very steep. So we are effectively not damaging the patient. So what about patients with intracanalicular tumors with only mild reduction of, I don't have the exact values of SRT, but this patient came to us in 2015, and there was a very mild reduction in hearing. So what would be the ideal choice for such patients?
Probably at this point, I would still wait and watch for some more time. See how the hearing progresses. Watch with serial audiometries. If it is showing steady and quite rapid progression, then maybe go for SRS. If it remains stable for a long time, then just give it some time. Maybe that will be a better option.
This is middle age, around 35 to 40. So that's what most people would have thought, and we also thought the same at that point of time.
My one option would be to consider SRS. Why wait?
Yeah, so there are at that point of time, in 2015, the evidence for both were not robust enough for us to take any decision.
So at least with the LINAC-based systems, from what we have seen, there is significant chance of hearing dropping. With gamma knife, probably I don't know now what are the current data, but our experience has been that hearing is going to steadily keep dropping. So at a faster rate probably than the natural history. So do you want to give it at a later date than this early stage is what I would debate about. You can of course give the patient the option, tell him that do you want tumor control with some little chance of possibility of hearing loss. But maybe that is something he may opt rather than, that fear of something sitting there untreated.
I'll answer that.
We can discuss all that here.
I'll answer that. So this is data for patients who we are not able to decide whether to wait and watch or to give proactive gamma knife. So if we consider hearing, at 5 years, wait and watch, patients, only 14% of patients had persistent hearing. This is a longitudinal prospective clinical data, quite a big one, like around 150 patients. And the proactive gamma knife, 60% of patients had intact hearing at the end of 5 years. That means to tell that hearing loss happens, but we can delay the hearing loss over time by giving gamma knife. So that means that the proportion of patients who are having intact hearing are higher in patients where we are giving gamma knife in patients who have intact hearing. So it's the same, like there are multiple studies supporting that. So this is what we did for this patient. In 2015 and 2016 and 2018, there was a progression of tumor. And if you can see, there is a significant dip in hearing status. This we had to go ahead and give radiosurgery. I don't have the follow-up images, but patient had progressive deterioration, but still the amount of deterioration which happens after radiosurgery is better compared to wait and watch strategy, which is supported by this paper, which tells that annually there is decrease in hearing whether you give treatment or don't give treatment. But the annual decrease in hearing is about 5 decibel per year if you wait and watch. But it is 3 to 3.7 decibel per year if you give radiosurgery. That means to tell that if you give radiosurgery, we can delay the amount of hearing loss occurs per year. So we can add, so it is well-known fact that from longitudinal prospective studies, especially from Denmark, who used to preserve patients, who used not to operate or give gamma knife for patients for a long term. We have enough data which to tell that patients who have intracanalicular as well as small vestibular schwannomas, over time they lose hearing. That loss is decreased or delayed by giving radiosurgery. Of course, like the tumor control rate, which is around 95% in such cases, which is far more superior to what we can offer with wait and watch strategy.
The only contradiction to that or answer to that is that there is a lot of individual variation in tumors among patients. So there is always still a role to see how this patient does, at least say 6 months, 1 year, you could still say that you will know what this patient is behaving like. Of course, you risk that suddenly it's going to all get worse, which can happen. Suddenly from good hearing
I have
to...
the answer in the next slide.
Yeah. Go ahead.
So, for example, if a patient, like sir told that, why don't we wait and then give? Some patients might deteriorate, some patients might not deteriorate. So what about patients who waited and then got radiosurgery? So there is another paper which tells that patients who got early treatment less than 2 years by the time they detected the tumor, and more than 2 years after they were detected the tumor. So at 4 years follow-up, 51% of patients who got treatment with radiosurgery before had intact hearing, and 29% only had intact hearing after if they got delayed treatment. That means to tell that even if intact hearing, there is a harm in waiting. Means like patient's deterioration over time might be more if we go through wait and watch strategy than give gamma knife radiosurgery.
What about if this is a NF2 patient? How would your approach change, or would it be the same?
So the guidelines tells that if patient has an intact hearing, stable, not increasing, with normal hearing, we have to wait and watch. For neurofibromatosis patients, NF2 patients only. But they also tell that there is a CNS guidelines which has come out, which tells that patient has tinnitus and patients have progressive hearing loss. Still, radiosurgery would be a better choice in smaller tumors. It's a mix-up. Like, for example, if a bigger tumor, there is a bigger tumor, like around 3 centimeter tumor with intact hearing. But still, that's a gray area where we cannot tell what would be the best option, because obviously those patients will lose hearing over time. NF2 patients ought to lose hear over time. But whether radiation gives advantage over it, there are no robust studies. but most of the real world radiosurgery practice, they give radiosurgery for patients who have progressive decline in hearing as well. If it is a only hearing ear and the other ear has already lost hearing, so we would wait because there is no evidence, but still there is a chance that we can accentuate the hearing loss by giving radiosurgery because NF2 patients are known to have malignant potential and other things.
What is the cochlear dose you want to achieve always?
We practice a maximum dose of less than 4 gray. So whatever literature tells is a mean dose of less than 4 gray is what is recommended. So in the present machine, what we have, we can put the maximum dose and then we can do inverse planning. So in that, we put maximum dose as 4 gray and try to achieve treatment like that.
When it is intracanalular,
Even with intracanalular, we are able to treat cases with less than 4 gray to cochlea.
So what will be the dose in the intracanalular portion when you are doing 4 gray?
So one more thing is like we don't try to reduce the coverage just because the 4 gray line is going to the cochlea. There are two studies, like if you know, there are one study which tells 4 gray as the cutoff and another study tells that 5.4 gray is the cutoff. So some people tell that if 4 gray is not there, we can keep 5.4 gray. But we have been very strict in managing such patients. If there is a hearing, serviceable hearing, we try not to cross 4 gray at all. And if the patient has intact hearing, some point of under coverage, we try to accept it. Only the intracanalular part, on the cap one.
We'll move on to
yeah. So this is from our center, patients with the intact hearing, age, the pre-surgical hearing, as well as mean cochlear dose, whether it is 4 gray or not, that dictates whether patients will have intact hearing over a long time. So these are small and let's come to a small and medium-sized vestibular schwannoma. So what would be the choice of treatment for such patient?
So here with some amount of brainstem compression, sort of medium kind of tumor, I think surgery would be also an option. What is the size? Looks like about 2.5, something like that.
2.5.
Yeah. So both SRS and especially if hearing is still intact, SRS would be the thing which you would go more towards, at least in my hands, because I don't think I would be able to preserve the hearing. So then the other thing is how much of the mass effect doesn't look like there's anything significant, right?
Patient doesn't have gait abnormality.
Yeah, so there's, so then you have to leave it to the patient. These are the two choices. One is you'll be able to take out most of the tumor, maybe even completely. Hearing is going to go. And then other option is SRS with its possibility that you may be able to preserve hearing for a little longer. So those two options you have to give the patient and then let them decide. I think it's a fair bet between both.
So we treated this patient with gamma knife radiosurgery. Over 3 years' time, we can see that there is progressive decrease in size. The mass effect on the brainstem has come down and the lesion has shrunken and only the intracanalular part is remaining. We tend to follow up this patient for a long time, and regrowth of such patients are rare but still reported. So we need to tell the patient, explain the patient that they have to come at least 2 to 3 years, every 2 to 3 years. So what is the evidence? Like for medium-sized vestibular schwannomas, if we are considering hearing as a treatment option, 14% we can preserve with microsurgery and up to 72% with radiosurgery. So especially in such cases, a surgeon who has 100% facial nerve preservation rate can only compare it with radiosurgery, because with radiosurgery, I have hardly seen any patient who has developed facial nerve weakness after radiosurgery, because it never happens unless there is a bleed or there is a major catastrophic event, which is very rare. So comparing facial nerve dysfunction, I think radiosurgery is clear a winner. So what about slightly bigger tumors? This is slightly around 2.5 centimeter. The same, this 2012 and the latest is 2022, 10 years over time. the lesion has remained stable and the mass effect on the brainstem has come down. So we have come to conclusion that with normal hearing, it is better to give radiosurgery. With serviceable hearing, to preserve hearing, radiosurgery. With non-serviceable hearing, better to do radiosurgery for the sake of facial nerve weakness. And what about grade 4, Coos grade 4 tumors? This is a Coos grade 4 tumor where there is significant mass effect, quite large tumor. Any surgeon would tell that this patient requires radiosurgery. Like, would you have thought any otherwise? Sir,
I mean, this generally I would operate. Yeah.
So what we did was
unlikely that we would have ever considered the option, because at least from what we have seen, we end up having higher doses on the brainstem side. So typically such a large thing, especially which is burrowing into the brainstem, we generally tend to avoid giving it unless there are serious risks involved in surgery. So first option for us would be definitely surgery.
So what described is the brainstem dose, the max brainstem dose should not be more than 12 gray. Just because we are giving 12 gray for the tumor at 50% isodose line, the 12 gray volume to the brainstem will be 0 in gamma knife radiosurgery. So it is reasonable to give 12 gray if there is mild brainstem compression. So we treated this patient with radiosurgery, and over 78 months, we can see that there is gradual decline in the size of the tumor. Brainstem compression has come down, but we have to be cautious. Even in such patients, when slightly bigger tumors, there is a chance of regrowth. So there are multiple studies who have shown that hearing loss as well as tumor control rates are around 92 to 95% over long term, even in Coos grade 4 tumors. There are multi-institutional studies. Even in our studies, we did a study which showed that if a patient has gait abnormality, and if the patient has a combination of gait abnormality with cranial nerve abnormality, it is better that we operate that patient. So how to choose a patient who has a reasonably large vestibular schwannoma with mass effect on the brainstem for radiosurgeries? If we know that giving radiosurgery will have a transient edematous response at around 6 months, which happens in almost all patients who receive radiosurgery. We should consider that in mind when we give radiosurgery, so that around 6 months later, patient should not develop new symptoms because of the edema. So that means that if patient already has gait abnormality, already has 7th nerve involvement, that means he is a very bad candidate for radiosurgery. Because some patients we see that there is a lot of cysternal space, loose space, old age. Radiosurgery would be a better choice if patient is asymptomatic. But a patient who has a tight posterior fossa and cysternal space are not seen, brainstem mass effect is there, especially if there is edema in the brainstem, patient is a very bad candidate of radiosurgery. We should not consider radiosurgery in that patient.
Such large volume tumors, what is the data on fractionated stereotactic radiotherapy?
Yeah, so it is
fractionated. Even there are some studies which say that marginally the hearing preservation is even better than a single fraction.
So there are studies which have seen fractionated radiotherapy as well as fractionated radiosurgery. So there are studies for small as well as slightly bigger tumors. If you see the overall control rates, it is almost similar. Fractionated radio, even considering fractionated radiotherapy. But hearing preservation, brainstem mass effect and side effects are slightly more in fractionated radiotherapy compared to radiosurgery.
Recently, we had one slightly larger vestibular schwannoma. Patient developed trigeminal neuralgia after about 4 or 5 months after the
Absolutely,
treatment.
it's very common. Yeah. Large tumors close to the trigeminal nerve, after radiation, they can develop trigeminal neuralgia. Usually, we have never operated because patient had trigeminal neuralgia, but usually they get controlled with a transient a few months maybe. I can tell at least 4 to 5 months they will need medical management of trigeminal neuralgia. After which that trigeminal neuralgia is mainly because of compression rather than radiation side effect. What I can tell, because there will be radiation necrosis inside the tumor, and that mass effect can cause trigeminal neuralgia rather than direct radiation effect to trigeminal nerve.
Unfortunately, this chap is allergic to carbamazepine. So
Then
he's having a tough
surgery
time.
would be, yeah. So
How much time do we have? We are 1 hour late, no? Okay, another 10 minutes.
10 minutes.
Okay.
I'll show a few cases. These are the failures which we had for after vestibular schwannoma radiosurgery. Over this patient is followed up till 7 years. This patient initially operated radiosurgery for the residue, then cystic change for which surgery was done. So as such, patients' failure of the tumor is not a reason. Many times, a cystic change in the peritumoral tissue can be a reason for resurgery. And unfortunately, this patient had intratumoral hemorrhage after radiosurgery, for which we had to go in and operate. This happened around 1 week to 10 days after radiosurgery, which is a catastrophic event, and we had to operate for this patient.
Any history of malignant transformation? Any?
So there are total 13 cases of malignant transformation reported. 13 cases of malignant transformation of a vestibular schwannoma. That doesn't mean that like they became malignant peripheral nerve sheath tumor.
Okay.
So they were operated, and the histopathology showed some malignant change. That doesn't mean that it became totally malignant, but those have not recurred over a long time. So histopathology showed malignant change, and they failed, for which surgery was done. There are 13 cases reported so far, like out of several thousands of cases done. So this is one example over 5 years. This is over 48 months. There is progressive decrease in size, decrease in mass effect of brainstem. These are several examples of how response to radio surgery happens. So in the present era, I think this would be the most common case where radiosurgery will be given. Huge tumor where I operated with preservation of facial nerve. A sleeve of tumor will be left around facial nerve. So this will be the ideal patient where in the present era we give radiosurgery. We would prescribe around 12 gray for this tumor, and long-term results of control with radiosurgery is as good as the primary treatment. This is another patient where we operated and there is intracranial color residue. These patients have not undergone radiosurgery yet because this is seen recently. So what about meningiomas? Like meningiomas, most meningiomas are considered for radiosurgery if they are difficult to access and we are not able to remove it, and in areas where we have left the tumor because close to critical structures. I think the panelists would agree that all these tumors, like they would have considered radiosurgery as a choice. So considering data for patients who have small asymptomatic tumors, proactive gamma knife has been shown in a few of the studies to be indicative, but there was a lot of backlash until recently. There is a multi-centric prospective randomized control trial which proved that radiosurgery is a good option rather than watchful waiting for control of growth. So even with microsurgery, over time, even after doing microsurgery, there will be a recurrence chance, but that is not a case if you give gamma knife radiosurgery for a small tumor instead of surgery. Like gamma knife has a better long-time outcome, but better outcome than surgery. So these are typical examples, and I would go to the next session. So in NIMHANS, we have operated, we have given gamma knife around 423 cases, out of which it is very important to notice here that 86 plus 96% of the cases had good outcome. That means the tumor remained the same size in 86% of the cases, and only 10% of the cases there is reduction of size. Compared to what I showed in vestibular schwannomas, tumors don't decrease in size in meningiomas. they remain the same. So for example, if we see a tumor like this, we should not opt for radiosurgery. We should do surgery first because there is a mass effect on the brainstem. And we know that there is a chance of increase or stable disease. But like vestibular schwannomas, these tumors don't decrease in size. These are the examples of stable disease over time. This is the lesion which actually decreased in size because patient was considered for radiosurgery because patient had cardiac morbidity. One thing we should be aware of is in parasagittal locations as well as in skull base, there is a high chance of radiation necrosis as well as peritumoral edema in patients with radiosurgery. In this case, we could manage this patient with only anti-edema measures.
One place where I'm very cautious about is when the parasagittal meningioma is on the motor cortex.
Yes.
They tend to have a lot of seizures, even some weakness develops. Even if they already have some weakness, it tends to worsen. So a bit of a stormy course for even up to 2 or 3 years sometimes. Then slowly things get better. But for the initial period, you have to warn them that things might get quite difficult.
So parasagittal meningiomas are known to have bad radiation necrosis, edema. One of the patients which we had treated had, even after surgery, like we had to remove the tumor because of radiation necrosis, but still patient did not do well. So whatever I showed initially that better to conservative management, better to give radiosurgery, it should be thought once more before considering radiosurgery for a parasagittal meningioma, just because they have high chances of radiation necrosis. But we never had any patient where we needed further than steroids. So this is a case where there was a gamma knife failure where there is an increase in tumor which we had to operate. So coming to cavernous sinus hemangioma, like this is a patient who is around a 60-year-old, came with third nerve palsy, which was around since 25 days. And patient was very unhappy because of her closed eyes and double vision, for which she came to us with this left side cavernous hemangioma. What would the panelist think of for this case?
This situation definitely direct SRS, no doubt about it. Because, I mean, there's nothing gained by operating. So just go ahead with SRS to control the lesion. Yeah. And for all you know, you might benefit from it.
So surgery in cavernous sinus hemangiomas are thought as like a pinnacle of neurosurgeons' surgical skills. Sometimes because it bleeds excessively, a lot of nerves, complicated anatomy, and a lot of surgeons take a lot of pride in operating cavernous sinus hemangiomas. But if in the recent past, the scenario has entirely changed. For example, this is a small cavernous sinus hemangioma, you would agree, but even for larger cavernous sinus hemangiomas, in the present era, the response would be like this. So this is a patient at 1 year, the cavernous sinus hemangioma has totally disappeared. And patient had complete improvement in her ptosis as well as diplopia. So this is a normal, routine and very predictable course of a patient who undergoes gamma knife radiosurgery for cavernous sinus hemangioma. And you can see with the volumetric response, this patient had compression of optic nerve as well as, like most neurosurgeons would think that compression of optic nerve is an indication for surgery. But in this case, if you can see the yellow line, it is slightly below the optic nerve. So we have covered suboptimally. That means like 1 to 2 mm of tumors we have left without radiation. Means it's not like without radiation. 12 grays of radiation is given, but the yellow line is 8 gray. Sorry, the green line is 8 gray. 8 gray is a tolerable dose for optic chiasm. So we have kept below 8 gray. So this patient did fantastically, totally improved, like all cranial neuropathy has improved. So this would be that, this is at 6 months. So we can imagine over time, it reduces over time. So I can show multiple examples where the lesions have totally disappeared over time. Lesions which are reasonable size, bigger size, even smaller size, they have a fantastic response with radiosurgery. And this is an era where like all of neurosurgeons should be aware that it's a very good treatment modality. And I have operated cavernous sinus, 2 or 3, like huge ones earlier. It's a very messy procedure, lot of bleeding. We don't know where the nerves are. And most often patients would develop more deficits after surgery than before surgery.
I think glomus and hemangiomas, I think we should directly consider SRS as the first choice.
Definitely, sir.
Okay, I think, thanks Nishant.
Yes, sir.
I think we had a good discussion. Any questions, any comments from the audience? Yeah, Komal.
Yes, sir.
So very interesting and very slides are really amazing that what you have the cases what you have shown. Like, is there like we have like asked to choose between surgery or radiation? Like, is there a third option? Like, do we even consider? Anyway, they have to come back for scan. Like, will we give that option of come back after 3 months? We'll see. For example, a asymptomatic 2.5 centimeter schwannoma.
Vestibular schwannoma.
Vestibular schwannoma, like the one which you showed, the small and medium sized ones. Patient hearing is okay and no deficits incidentally detected. Like, is it the choice only between surgery and SRS, or do we have a third choice of we'll wait and watch?
I think I showed 2 cases where wait and watch strategy was considered earlier, but if you wait and watch, the hearing loss happens more rapidly.
In all of them, like
in majority of them, like that's what I showed. In 60% compared to 15%, like hearing preservation with radiosurgery is 60%. If you wait and watch, the preservation of hearing at 5 years is 15% in that particular study. But even in meta-analysis, it has been shown that the progression of hearing loss over time is worse if you wait and watch compared to radiosurgery. So it's obviously like while giving radiosurgery, we have to make sure that cochlea receives less than 4 gray and preserve all this. Then only we can preserve hearing. Earlier, there was an era where they give 14 gray, 15 gray for radiosurgery in vestibular schwannoma. They had a lot of edema, a lot of complications. Hearing loss was very less, very more, too much. So once there are several studies which showed that 12 gray is an optimum dose where the benefit is fine, but there are no complications at all. From that era, when around 2003 or 2004, after that, the complications rates are so less and hearing preservation is so high that we have moved away from wait and watch as well as surgery, and we preferred
directly attributable to improvement in safety measures.
Yeah.
Technically.
Okay, I think we'll close that. Thank you.
Thank you very much.
Now I'd like to invite the chairpersons for the last session. Dr. Narayana, Senior Consultant Neurosurgeon in NH. Dr. Madhukar Nayak, Professor and Head of Department Neurosurgery, Father Medical College. Dr. Satvik Shetty, Senior Consultant Neurosurgery, Manipal Hospital, Bangalore.
So we have come to the last session of this 2-day extensive Neuro-Oncology Symposium. So we as a clinician see patients and some minor symptoms like headache turning on to be a tumor, symptoms like and sudden appearance of neurological deficits. All this, when a patient comes to know that he is having a brain tumor, so that radically changes his approach to daily life. So how that is being dealt, and post surgery, how patient has to undergo rehabilitation, all this we have in this session. So I now call upon Dr. Srikanth Venkatakrishnan to talk to us about post-operative rehabilitation after surgery for glioma, the challenges and opportunities.
First of all, I'd like to thank you very much for giving me this opportunity to present some of our experiences. It's really rare to have rehabilitation in these forums. And I guess while we're nearing the end of this conference and all the patients need to be discharged, the rehabilitation team input needs to be taken, and I'm here to give that. I won't be very specific in terms of the interventions that need to be done, but I'll give you an overview of what the process of rehabilitation in neuro-oncology is going to be like. So when it comes to the background, we have a large burden of care due to increased survivorship. So I'll be talking a little bit about that. What is the literature evidence favoring rehabilitation in neuro-oncology care? What exactly do we look to do? What are the aspects of prognostication we consider in our planning? How we assess our patients to go ahead with the plan? What are the goals and what are the process of goal setting that we make? How we implement our team in the multidisciplinary team setting? And the transition towards palliation from rehabilitation is an important aspect that I'd like to touch upon. Additionally, I'd like to talk a little bit about new advances such as hyperbaric oxygen and a few experiences that we have treated some of our patients. So in this era of better treatments, there is an increased survival rate in brain spinal tumors. And we see that survivors are left with complex residual impairments. And the integration of neurorehabilitation to standard rehabilitation measures is a challenge. Parallelly, we need to develop effective rehabilitation solutions for non-oncological conditions. Here we have a tool to transition our patients from acute care and hasten the process of recovery so that there is not an increased burden on the hospital to maintain the patient flow. But what we have seen in the last few decades is that there is a lack of clarity on the intensity, settings, and type of rehabilitation that can be offered. But that is slowly changing. And when it comes to gliomas, we consider the aspects of whether they are low or high grade based on which gives inputs on how we plan for their care. When we consider aspects of radiotherapy to prevent recurrence, we have to deal with residual fibrosis and the deficits that they place, and also aspects of chemotherapy-related encephalopathy, steroid myopathy, and the other acute medical issues place greater burdens on an already complex situation. What we find in the last 2 decades, at least from 2010 onwards, is that there is positive effect of rehabilitation on patient outcomes. So much so that there are structured rehabilitation settings only for neuro-oncology which have been developed in the United States, UK, and Israel. And even high-grade glioma survivors, 2 years from the diagnosis, can benefit from rehabilitation. What we have found is that a gain of 10 points on film correlates with longer survival, and poorer functional outcomes are associated with mortality. What recent studies indicate that gains from inpatient rehabilitation can be similar to even non-oncological conditions such as stroke and traumatic brain injury. And a recent meta-analysis from 2011 suggested that there is positive evidence for non-malignant tumors through prospective case series and cohort studies. But the challenge of doing RCTs in this setting means that there is a lack of clarity for malignant conditions. So what are we seeking to do with rehabilitation? We know that motor dysfunction places great burdens on the patient's mobility, restricts their activities of daily living, and places them at risk for complications of immobility, falls, and venous thromboembolism, which causes the associated pain, anxiety, and psychological issues with loss of functional independence and a reduced quality of life. So rehabilitation targets not only the causes of motor dysfunction, but also its effects on physical function, well-being, and the quality of life. In this graph, we see that a sentinel event has caused a drastic drop in function, which can be partially ameliorated with rehabilitation over time. So what are the aspects of prognostication that we consider here? Always the grading, prognosis, and the extent of impairments are used to work our rehabilitation plans. And when it comes to oncology, the trajectories in life can be complex. Now with increased survivorship, there is more of a waxing, waning, and gradually declining course which we need to consider for rehabilitation. That is not the case for non-oncological conditions where lifespans can be
greater. So based on the anticipated survivorship, we set our goals in terms of short-term, long-term plans, and also reorient our care based on changes in the patient status. So what we see that from 1969, the Dietz classification talks about treatments in terms of being preventive, restorative, supportive, and palliative. And rehabilitation spans the scope of all these treatments and gradually transitions into palliative care. So when we look at assessment of our deficits, we need to consider the spectrum of the disease and disability burden as per the International Classification of Function model, where we take a note on the impairments and the extent of the activity limitation caused due to them, the restriction in participation caused due to these impairments, environmental and personal factors which will play a role on the disease presentation. And we have to screen competently and sensitively aspects of motor dysfunction, whether they are pyramidal or extrapyramidal, sensory problems, screen for visual, cognitive and perceptual issues, organic behavioral issues, and look at musculoskeletal impairments that may be in terms of wasting, deconditioning, contractures, which affect ultimate mobility and function. When it comes to the pathobiology and localization, the tumor size, location, post-surgical changes, post-radiotherapy changes, and their ultimate location plays a role in the presentation of the condition. And the functional ability needs to be quantified in terms of the Barthel index, FIM, the functional independence measure, and the Karnofsky performance scale, which help us in planning and assessing where the patient is going in the rehabilitation plan. And this helps us to make the discharge plans and plan the setting of care. We could also use functional scales such as the Western Aphasia Battery, the SARA, and the Berg balance test to assess balance in ataxia, but generally we use more gross functional scales for our assessments. We also need to do a proper assessment of the psychosocial and socioeconomic burdens in terms of their access to wheelchair, the home environment, accessibility, access to rehabilitation services, and social support. When it comes to setting of goals, we plan our goals in terms of short-term and long-term settings. And the settings of care is decided based on the functional ability of the patients, the capacity to withstand therapy for at least 3 hours, sit supported for at least 1 hour, the relative medical stability, and the performance in rehab measured in terms of functional scales decides whether the patient can be discharged or needs to continue with inpatient care. Examples of short-term goals can be the ability to perform better on bed mobility, transfers, sitting balance, functional mobility, and somebody with hemiplegia, we can achieve functional mobility with assistive devices and orthotics, and someone with paraplegia may require prolonged weight training for a period of 3 to 6 weeks to achieve ambulation with KFOs and a walker. If this is not feasible, we have to reorient and plan for wheelchair independence and gradually train the patient to be ADL independent. All this while, we need to take a note on prevention of complications in terms of wound management, prevention of acute infections, and the prevention of thromboembolic complications. When it comes to long-term goals, we would look at the ability to perform self-care and ADLs independently, the ability to perform instrumental or extended ADLs, and if the prognosis is good, focus even on vocational and community integration. Suppose somebody's survival is more is less, our goal reorients to palliation, and we look at self-care, transfers, wheelchair independence, and comfort care rather than intensive rehabilitation. The rehabilitation takes place through a multidisciplinary team, which includes several members and is centered on the patient and the family, and each person in this team has individual roles to play. The physician plays a role in the assessment of impairments, planning of goals, setting of those goals and discussing them with the family, management of complications and preventing them, management of pain, spasticity, and the gradual weaning off of tubes, the care of bladder and bowel, and wound care and prevention. The physical therapist plays important roles in maintenance of joint flexibility, normalization of tone, graded strengthening and endurance, developing trunk control, and graded ambulation and ensuring functional mobility. The occupational therapists help the patient and their family get trained in functional mobility, bed mobility, transfers, activities of daily living, and in hand function development. Speech and swallow therapists help in dysphagia management and a graded weaning off from tube feeds to oral feeds as and when they are safe, and help with communication impairments through augmented assistive communication methods or with volitional speech training. Rehabilitation nurses play a role in positioning, tube care, health education for the patient and the family, prevention of complications, and play a great role in boosting the morale of the patients and the family. Social workers, which are rare to come by in a private setting and are mostly restricted to the government setting, help with socio-economic concerns, help in access to support services, scheduling of activities, reintegration into the community, as well as they can be important members of access to home care services. And importantly, the psychologist deals with assessment of neurobehavioral impairments, cognitive remediation, patient and caregiver counseling. An orthotist helps in the fabrication of splints as and when they may be appropriate. So here we have a kaleidoscope showing what interventions each person in the rehab team does. So we have the physical therapist who helps in mobility. The orthotist has fabricated splints to help with function. KFOs can be made to facilitate mobility for paraplegics. And the physician takes a role in planning for interventions that help with pain and spasticity and in wound care. When all of this leads to the final issue of palliation, it is important to give care with dignity while respecting the patient's autonomy, involving the patient in decision making, and dealing with issues like collusion with the family. It's important to take a note of rehabilitative measures such as maintaining basic level of function and prevention of complications. And we need to communicate the next steps of the gradual decline through active listening, breaking bad news with empathy and sensitivity, and giving the right kind of counseling. We also have to consider management of pain, dyspnea with palliative sedation and opioids as and when appropriate. Issues of raised ICP, bowel obstruction also fall within the permit of palliation. And finally, when we talk about end-of-life care, we need to prepare the patient and the family for the process of dying and to address issues such as advance directive, the will of the patient, and unmet needs. And finally, as and when feasible in different settings, we could also extend grief and bereavement support to the family. A small note on hyperbaric oxygen therapy, which we have started in the last 5 months at our institute. It is being used for radiation necrosis, and it's important to make a correct diagnosis through magnetic resonance, MRS, PET, and biopsy as and when appropriate. Only when the patient is properly diagnosed and falls within the criteria of radiation necrosis and not tumor recurrence will they be candidates for HBOT. And generally we find that 20 to 30 sessions at 2 to 2.4 atmosphere equivalents have shown benefits in patients with post-radiation necrosis. So we have treated 2 patients, about 6 to 10 sessions were given, and mild reduction in spasticity, they were both hemiplegics, were noted. Of course, these were not ideal durations for treatments and they needed to be treated longer because of logistical concerns. And that's one of the issues with HBOT, that it increases treatment burden, they need to come in daily for sessions. The cost might also be a factor in treatment. There are new centers which have got this facility, and with that the cost might also reduce. The challenges present opportunities in themselves, and there is a need to create structured, dedicated neuro-oncology rehab units while strengthening the capacity of existing rehab setups. And while we might have lofty dreams, logistical issues such as the location of the setup, where the individual members of this team are situated, will place a great deal of burden on patients. If you have the different members of the team in different floors, patients will have to roam around to get care. So combined clinics might be the way forward to address this. And there is a need for seamless integration of acute, post-acute care, rehab, and palliation within the scope of neuro-oncology. And this can happen with better communication, team needs, involvement in CMEs, and grant rounds. The very fact that I'm standing here shows that this is happening. And how do we integrate recent advances in neurorehabilitation with neuromodulation, non-invasive brain stimulation, rehab, robotics to neuro-oncology remains a challenge, but the onus is on us to take on leadership to develop institutional protocols based on evolving evidence. And once we make our rehab teams better staffed and equipped in terms of infrastructure and location, the care will obviously improve. Telemedicine, outreach, and follow-up offer exciting opportunities to help improve the quality of care. And finally, we are plagued with lack of systemic support within our settings, where a great deal of burden is placed with not much help from social support settings. And the family plays a big role to fill in this gap. They go through a lot of suffering with the patient, and it's important to us to address the caregiver burden with care and orient and guide them appropriately as based on the time-bound nature of this condition. We had a girl with primary spinal astrocytoma who was referred for rehabilitation around 3 months back. In December, she had a surgical resection of her tumor, and she had residual paraplegia localized around T12. She had a partial recovery of powers at the hips, but not below, over the next 2 months. She had sensory loss below L1, with hip flexor powers of 2 bilaterally and 0 below. She had a left ischial ulcer, which was at stage 4. She was functionally wheelchair bound, and bladder and bowel voids were done reflexively. So a neurosurgery evaluation was done, and an MRI was done to rule out recurrence, and referred for plastic surgery and PMR. So at PMR, in our first visit, we sat down with the family to plan what it's going to be like in the next 2 months. We told them that this is going to take 2 months. You first need to take care of your ulcer, and then we'll move on to rehab. Under plastic surgery, she underwent flap closure. She had 3 weeks of admission there. She lay prone so that she doesn't develop recurrence of the ulcer. And she underwent rehabilitation during this course. And she was transferred to rehab after duration of 4 weeks, where we gave her health education on ulcer prevention and prevention of contractures. She underwent upper limb strengthening, push-ups, graded mobilization, with gradual improvement in her trunk balance to be able to ambulate with KFOs and a walker. For bladder, she was started on tire voiding and double voids with twice-a-day CIC, with advice on need for further screening for upper tract changes. And bowel was regularized with dietary and behavioral measures. The family was given support to restart schooling, and support services were informed to them where they could receive care in Assam. This is what she drew for us before she left. And really there's a lot to learn here in terms of how we need to keep aside the suffering that we are facing and move on to what is important. And it's for people like this and for those who suffer that we must constantly seek to self-improve and improve the quality of our service. Thank you.
Thank you. With the advances in surgical technique, radiation, chemotherapy, what we have gone through in last, yesterday and today, cancer survivors have definitely increased, and what was a burden just on the family members has grown now into a mainstream rehabilitative care with multidisciplinary approach. Thank you very much. Any comments?
Hello. Dr. Srikanth, a very good talk. I think we all understand the importance of a good neuro rehab team in the whole setting of a Department of Neurosciences or Neurosurgery, Neurology. Just wanted you to just tell us a little bit about this HBOT therapy which you're talking about. So how does it really help in neuro regeneration, or is it mainly for wound healing which you're looking at, or how does it help in getting patients better from neuro deficits?
So hyperbaric oxygen therapy, the pathophysiology is that when you deliver pulses of oxygen at increased pressure, it increases the partial pressure of oxygen, which activates intracellular cascades that help with, acutely helps in reducing tissue edema and helps with causing vasoconstriction. So in the acute phase of inflammation in radiation necrosis helps in managing that. But chronically, it helps when tissue regeneration and repair. It helps in remodeling and migration of fibroblasts
to achieve normal tissue homeostasis and regeneration. And in that way, it has purported to help with chronic neurological conditions. In wound care, the number of settings required vary from between 2 weeks to 3 weeks, but you might need slightly longer durations to see any benefits in chronic neurological conditions. So as such, FDA has been, HBOT has been FDA approved for osteoradionecrosis, management of chronic wounds, non-healing wounds, tissue dehiscence. In terms of, recently there has been a consensus from the European Academy of Hyperbaric Medicine, where even chronic TBI stroke based on level B and C evidence has been approved for these conditions, but not for acute conditions. Now, the problem with HBOT is that you cannot really generate double-blinded RCTs because you will know whether you've been subjected to HBOT or not. And that has been exemplified in a study in 2004, where the control and the experimental group for cerebral palsy both received, the control received 1.3 atmosphere HBOT and the experimental received 1.8. Now both are actually treatments. So it's very difficult to blind. So most of the evidence is based on case series and prospective cohort studies. And so RCTs are really difficult to perform. But as such, it has been FDA approved for chronic neurological conditions. And in terms of radiation necrosis, it is an FDA approved condition, but you might need to give treatments for between 20 to 40 days. And we need to see whether the spasticity function is changing, minor changes in motor control to really see if it is having benefit. So it's a bit of a gray area over there, but has shown some promise. And as the evidence evolves, there's a great scope for doing research in this field as well, and to develop the evidence, the good quality evidence that we need to make it mainstream.
The indications at present are mainly for radiation necrosis, is it FDA approved?
Wound care, radiation necrosis.
Okay.
Yeah.
And for how long are these sessions? Each session?
So each session is about 1 hour, and the time for which there is now, the risks include oxygen toxicity. So we need to be careful of how much pure oxygen we're giving. So generally we pressurize for around 10 to 15 minutes. We maintain that pressure, and during that maintenance, we give oxygen with oxygen breaks in between. So each session is between 1 to 1.5 hours. And they need to come in for as many days as been prescribed. And then we need to make revisions as to whether it is improving, the condition is improving or not. For example, in hemorrhagic cystitis, we would see the reduction in hematuria, the reduction in the number of voids. So based on each condition, we would reassess every week or so to see if there's any positive trend. And then we would taper treatments. So generally we give treatments for between 10 to 14 days in our setting. But for neurological conditions, what evidence has shown is that they need slightly more than that.
Are there any centers, I mean, where this is available?
So we have been using it at Narayana from the last 5 months. And in Bangalore, it is available at several private setups. In the government, it's there in the Institute of Aerospace Medicine, which has been operating for the last 20 years. And it's there at Aster, Manipal, and certain other corporate hospitals. So. Yes, ma'am. So one issue with getting different modalities into treatment is that the cost concerned, it is an adjuvant. It is very much part of neurorehabilitation. Most of the challenge lies in getting the patients to receive good quality of evidence-based therapy for the right amount of time. And aquatic rehabilitation is a useful adjunct to help improve outcomes. The challenges in that are the availability, setup. You need one dedicated therapist. In some places, it has not worked because certain incidents have happened where a child has had near drowning incidents. And so one must be very careful in these settings and have appropriately trained personnel to run. But it will play a big role in the future as there is more awareness and investment in this area.
So,
Rehabilitation, neuro-rehabilitation is a very complicated model. To begin with, it is physiotherapy, occupational therapy, but also many of them would need speech, vision.
these are all part
and
of
cognitive behavior
yes.
therapy and all.
These are all part, and the one constraint is having all the members in one setting. What we do is that for those who need CVI rehab, cortical visual impairment rehabilitation, we have a setup in the Ophthalmology Institute where patients are referred on an outpatient basis. But to some extent, our occupational therapist also helps in aspects of developing visual fixation, tracking, and guiding the family. But mostly, these therapies are part of the multidisciplinary team. We do have problems with visual rehabilitation, and our ophthalmology setup helps with that.
Is such model available at NIMHANS? Because it's a neuroscience institute.
Yes, it is available, and there is a neuro rehab department which is very much part of the setup at NIMHANS. And when you have to consider added therapies such as speech therapy, neuropsychology, and cognitive remediation, that is set apart in probably around 50 meters away at NIMHANS. At NH, we also face the same PTOT, speech and swallow, are within the same setup. Neuropsychology and mental health also helps us with this. CVI rehab is a challenge. So, but most places are looking to develop integrated models of care.
Okay, thank you.
A big thanks to the neuroscience and oncology divisions here, because without excellence in patient care, rehabilitation will not be possible, and hopefully things will change for the better in the future. Thank you.
Moving on from addressing the physical health, we now move on to mental health, the most important and not so much given attention to. So how a patient goes through right from the day he is diagnosed as to be having brain tumor, the anxiety, the emotional fluctuations, the fear what he has. So all this will be addressed by Dr. Diwakar Gautam, talking to us about Mind the Mind, Open Your Eyes to Neuropsychology, Neuropsycho-Oncology. Dr. Diwakar Gautam.
Thanks, Dr. Satya. Mind is perhaps the most affected organ in any oncology patients, not just in neuro-oncology. And the condition need not be malignant to proliferate to the mind. And it not just proliferates into the minds of the patient, but it proliferates into the minds of the family member, near ones, and it proliferates into the minds of the clinicians also. So it is the most important thing. The importance of the mental health issues can't be overemphasized in any onco care. And thank you, first of all, for including this topic in this symposium, because this is one of the most important organ, one of the most important issues, and it is the most neglected issue also, as Dr. Shrikant mentioned. Now, we all are very, very good at treating the disease. Even I've learned a few things. I was just telling Dr. Shibu, being a psychiatrist, I also learned a little bit about gamma knife, SRS, and we all are very, very good at treating the disease. What about the other aspects? When we consider the management of any patients, it's extremely important to consider three aspects. One is, of course, the disease component. The patient is the one who feels, who experiences symptom, doctor diagnosis, and we know, we are very clear in this aspect. How much are we aware of the illness component? Illness is How do I perceive the symptoms I'm going through? How do I perceive the disease I'm going through and the whole treatment? And what about the community? How am I perceived in the community because of the condition that I have? And we talked so much about the compassionate care. We talked so much about the quality of life. None of them can be achieved without having the thorough knowledge of these three components, and patient is in between. And we are treating the disease components, fantastic, and we do have to treat the other aspects. And therefore, the quality of life includes not just the disease, all the other issues that are listed here and much more than that. Now, this figure is for all of oncology patients. Nearly 50 to 75% of oncology patients have psychiatric comorbidity. How much do we pick up? How much of these things do we pick up in the day-to-day practice? Especially in neuro-oncology, organic affective disorders, organic psychosis, organic delusional disorders are extremely common. Depression, anxiety, either organic or independent. Cognitive deficits, you name it. Because you have touched on the very seat of the mind, there will always be a cognitive deficit. It's a question of how much, not if. Somatization. So many patients have these symptoms which can't be explained by your investigations. Insomnia, delirium, a lot of adjustment disorders because the whole life changes after a diagnosis of a condition which is in the brain. Nothing can be more daunting for the patient when they are told that they have a brain condition, let alone a oncology, a cancer in the brain. And of course, self-harming behavior and suicidal behavior. This is a lot more we have noticed in the patients with the neuro insults, especially on the right side in women. So do we really pick up these things? Substance abuse, extremely important. Most of these patients are prescribed analgesia, opioid analgesia. You must have seen your patients carry on these medications for a longer period. Some of them might go to alcohol, many other substances. Now, what are the causes? It could be directly related to the underlying pathology or the treatment. It could be because of the chemotherapy. It could be because of radiation related complications. It could be because of the surgery. Or it can be an independent or coexisting mental health condition or a pre-existing mental health condition or the adjustment problems that they go through because of the diagnosis, because of the treatment, the prognosis, relapse, and everything. And what is the impact? This is the most important thing. Exaggeration of the symptoms, pain. Dr. Sushil was earlier talking about this. Nobody can really prove whether somebody has a pain or not. You just have to take their face value. How are you going to say that how much of this pain is because of the underlying condition? How much of it is because of the stress that they're going through? So we need to really look for these issues. Behavioral issues, cognitive problems, all of them in terms of the patient. Suicide risks is at least 3 times higher in this age, this group of people. Cost, because they have complained of all these problems, you want to keep them in the hospital for a much longer period. There is a risk of over-medication, over-investigation. Already they are drained of their resources. Because they're complaining, you have to do another scan to rule out. And only after that you're going to refer them to us. So there is an implication on their financial aspects. And of course, the non-compliance, because of these mental health conditions, many of them will not come for follow-up. Your primary management also will take a hit because of the underlying psychiatric or psychological issues. Collusion, Dr. Shrikant talked about this, conspiracy of silent, clinician burnout, moral injury to the clinician, all of them can be an impact because of these issues. Now, specifically to the neurotumors, some of these neurotumors can present primarily as a psychiatric condition. And we have seen that. Recently, we had a patient who was admitted in the emergency department, a 65 or 66-year-old lady, and she was treated as treatment-resistant schizophrenia for the previous 6 months. She was already on 3 antipsychotic medicines and 2 mood stabilizers. She was admitted in the emergency department because she had a seizure. They did a scan and they found a meningioma in the right parietal area. She wasn't responding to the treatment because the cause is something else. And therefore, she was operated and then her psychotic symptoms improved tremendously. And it can be, there can be a comorbid psychiatric condition or a substance use in addition to the tumor, especially if some of these tumors which are not giving away the neurocognitive symptoms, sometimes it can be very complicating. Manifestations with psychiatric and behavioral issues post-surgically. We do get a lot of referrals from the SICUs post-surgically because they have agitation, delirium. And what we have noticed is some of these can be prevented if we do the screening thoroughly as a part of PAC. If you pick up some of the psychiatric conditions pre-surgically, perhaps we can use some strategies, some medication to prevent post-op complications. Substance abuse is another thing. Many a times we have noticed that the alcohol history is never taken, and patients will have withdrawal symptoms post-surgically after an operation, and they will have either a seizure or even delirium tremens, which could be because of the alcohol withdrawal. Long-term sequelae, of course, as Dr. Srikanth mentioned, is extremely important and the most neglected area. Change of role and illness behavior. Illness behavior, as I said, it's how we perceive an illness, and it completely changes how a person interacts with a family member or with other people once they have any neuro condition. These are some of the examples which are documented. Primary psychiatric symptoms, they came initially to a psychiatrist, not to a neurosurgeon or a neurologist, and then later on they found to have these conditions. So I've got plenty of these examples here. All of them are presented like schizophrenia-like symptom. I think this was similar to the case that I just mentioned. I kind of quickly go through this. The important thing here is, of course, this education is required more for the mental health professionals also. Routinely, we don't do the neuro scanning. As if somebody presents with a psychotic symptom, we don't do a scan. But there are some telltale signs. If you're suspecting an organic condition, if you do a scan, perhaps you can pick up the underlying pathology. Now, as mentioned above, we're very good at doing this part. What about person-centric needs? We are very good at addressing the acute issues. The urgency is dealt with. What about the chronic issues, psychosocial issues, existential and spiritual issues? And those are the ones which give a lot of meaning to the individual. You have, when we treat anybody, we say that it is in the best interest of the patient. Do we really mean that? Have we really looked at what is in the best interest? Is it in the best interest of me, the operating surgeon? Is it in the best interest of the hospital who is encouraging me to do more and more surgeries? Or is the surgery truly in the best interest of the patient in a long-term basis? Is it truly in the best interest of the family on a long-term basis? How much incapacitated they will be, either by operating or not operating? I mean, there was a beautiful argument earlier as to there's no question of wait and watch these days. You pick up things early and you operate. What about other implications along with it? I think that factor will have to be considered thoroughly, especially in Indian context, because of the existing social and financial issues. And therefore, if this is the person's need, we are doing all of this, onco teams, unless this part is also kind of fitted in thoroughly, we can't get the full care. Then we can't call ourselves we are giving a compassionate care. We've only treated the disease, not the illness and the sickness of the patient. So why is it such a difficult issue? Why is it we're not able to implement? Exactly like what Dr. Srikanth was telling earlier, there is a skill deficit. You don't get many people who can assess the psychosocial needs. There's no time for the primary treating teams because of the volumes. And it doesn't make a business case, unfortunately. When you go to a corporate hospital or any private setup, it doesn't make a business case because you're not paying the mental health professionals adequately. You're not paying for the rehab centers adequately. And there's a huge stigma. Patients themselves don't come because of the existing stigma. And of course, there are huge issues with the manpower. So we have to invest in this. Psychosocial care is as important as doing a brain scan. It's as important as recording a blood pressure. Unless we invest in this, we cannot see a long-term kind of improvement. We can only say this many number of patients we operated and they got discharged. And if we call that as a success, I'm sorry, that's a myopic vision. So biopsychosocial and cognitive spiritual needs and risk assessment of not just the patient, but the family will have to be done. And the active input by the dedicated, psycho-oncology team is required. At least if you don't have anybody, a counselor, employ a counselor, invest in them. They can take off a lot of burden. They can be your shock absorbers, especially in the time of diagnosis. When there is a start of chemotherapy, radiotherapy, or a surgery, when there is a serious adverse event, recurrence, or palliative care, and when they are nearing the death. Now, these two I have highlighted purely because suicidal risks are much higher at these stages. So it can be picked and it can be prevented. So, of course, rehab centers, Dr. Srikanth has already talked about. In order to address the clinician burden, clinicians burnout issues, we need to have a support system. At least once a month, a group, doctors will have to sit and talk about non-clinical aspects of taking care of these difficult patients. Even venting out, even expressing how they are feeling about a case, how they, sometimes not all patients will go according to the plan. It does leave you with some kind of emotional baggage. Unless it is offloaded periodically, our doctors are at a huge risk. So this is what I was talking about. At least employ a counselor. They have to be present as a part of your team, and they can link in with the in-house mental health teams. Empower the person and the family members about the needs of the psychosocial issues. And a culture of openness is extremely important. Do not ignore the emotions of oncology doctors. Do not ignore the emotions of nurses arising from complexities, conflicts, helplessness because of systemic failures, and colleagues' mistakes, deaths, etc. Arrange a support system. Balanced group necessarily means that's exactly what I told. At least once a month. It has to be non-clinical. Sometimes, every time we talk about a case history and talk only about a clinical aspect. How did you feel about managing this? There is a unexpected death. How did it impact you? I think just by talking, you're going to absorb a lot of these emotional issues. Some of the simple things which can be employed. Yes, we need a robust or a very thorough, psychosocial assessment. If not anything, at least use a distress thermometer. This is very commonly used across the world. All it is required is they have to score in this, how much distress they are going through. It doesn't even talk about for what. How much are you struggling? A cutoff of 4 is told as a critical value, then you need to really refer them to appropriate services. And these are the specific areas which can be further. Once they say more than 4, you can go into this problem list and see where exactly the issue is. And of course, this can be modified according to neuro cases, neuro-oncology cases. We can add in things and test in our own population and validate these scales. So this is a study done in Bangalore in the tertiary center. This is in 2017 using the distress thermometer scale. And you can see pain was the most commonest cause for the distress. Again, the pain could be because of organic issues, and it could be an exaggeration of the underlying psychosocial issue. Okay, this is what the study has picked up. And unfortunately, 80% of the patients were picked up to have this distress, only about 10% of them actually came to see the psychiatrist or a psychologist. There is so much of a barrier there. And therefore, you need to have somebody to handhold them. Have somebody within your team so that you can link with them and assist them through these difficult phases. So I won't be doing justice if I don't touch on the doctor's burnout. Neurosurgeons are perhaps the most decorated and the glamorous, doctors amongst the medical fraternity. With that comes the risk also. There is a high degree of perfectionism that we have seen in neurosurgeons. There is so much of rewards that you get, particularly the younger doctors. What comes at a cost of this is if there is a setback, how do we handle that? How do we deal with it? Surgeons are at a highest risk of going into depression or substance abuse. Super specialty surgeons have much higher risk. It could be pediatric surgeons and neurosurgeons. Do not ignore your own mental health. These are the signs of burnout. If there is an emotional exhaustion, fatigue, insomnia, impaired concentration, this is over a period of time, at least for a period of 2 weeks. There is a feeling of low personal accomplishment, loss of enjoyment, pessimism, feeling isolated and detached, having suicidal thoughts, increase in substances. Many of them use alcohol or some other substances to cope, particularly the residents. Do not ignore. There is something going on and you need to evaluate and you need to seek help, and there is absolutely nothing wrong. I've told mind is another organ in the body. There is no need to feel ashamed of talking about mind. Sense of depersonalization, apathy, irritability, not having any interest to work. This is a very interesting kind of, crossroad. This is a diagram which shows about the conflicts we go through. There are all these things that we want to do good, but there are a lot of these challenges. Defensive medicine, capitation fee. Nowadays, threat from the patients. We don't know who is going to come and hit us. There's a lot of news about doctors being in danger with unruly patients and their relatives. Now, as doctors, we are thinking, I want to help this patient to the best possible. What is the treatment? What do I do? To the self, it is a thrill of walking on a tightrope. You are really thinking about yourself. I must do the best. And what is the patient and the family thinking? There is so many thoughts in the patient's mind. Stigma, change of roles, long-term what is going to happen, fear of disease, recurrence, etc. Please talk about all these aspects and break the stigma on the mental health issues. Yes, these are the very, very important bricks in the management of any patients: surgery, chemotherapy, investigation, etc. And unless, sorry, something's missing here. There was supposed to be a picture of a cement here. Okay, this is a compassion, and these are the very, very important care that you're providing. These are the important bricks. Unless we take this cement and patch it there, okay, there it is. So this is the most important thing. Unless you do that, this wall of strength for the patient and family is not complete. Compassionate care in neuro-oncology should look like this. And the weakest link, the chain is as strong as its weakest link. Psychosocial care is not the weak link, but the attitude towards that is. Let's mind the mind at all times. Thank you. Thanks for the opportunity.
Dr. Divakar, excellent talk, and I can say that this was one of the most relevant topics which you have covered, and which pertains to all of us individually as a person who is treating the patients, and from the perspective of patient, when to look at, with empathy how the patient feels when he is when he goes through this traumatic thing. Definitely you have really covered it in a very beautiful way. So many times we also feel very helpless that we do our best, and then in spite of whatever we have done, we don't get the desired results, and it might sometimes weigh very heavily on our psyche. Definitely, and as you already covered, that we need to play a role well, play well, but ultimately accept that not everything is in our hands. We can only do our duty and just hope for the best. But we need to do our job well. Thank you very much.
Absolutely, sir. I think Dr. Timappa covered these aspects yesterday in his talk on breaking the bad news. But again, how do we do? When you are empathizing with somebody, you have entered into their space. Especially if you followed them for years, it does leave you with something when they are not there. Especially when they die, when children die, when children with oncology issues die, you're so attached to them and you're expected to just move on like robots. We are human beings. We do have a lot of issues that we go through. So there has to be a culture to recognize this and talk about this. Nothing more is required. When you talk about this, you know that your colleague is also going through this. That is sufficient. Sometimes symposia like this helps more for our mental health than for the academic growth, because you do get to meet a lot of people. There is, of course, that important value, and that this has to happen on a day-to-day basis in our workplace.
Yeah, thank you, Dr. Divakar. It was an excellent talk. I think that is from a doctor's perspective. I think when we look at it from a patient perspective also, I think as neurosurgeons, when we operate and the patient comes back for follow-up, we see whether the patient is moving his limbs, is walking, and has no motor or sensory deficits. We feel we have done a great job. But I think a lot of studies are coming up where I think a lot of imaging techniques are being developed, where we are looking at various pathways which are affecting their behavior, their psychological standpoint of how the patients are and how much psychologically they're affected by interrupting these pathways also. So we are trying to, probably in the future, we will be looking in more detail in those pathways and trying to avoid damaging them, so that psychologically they'll be in a better space after surgery too. But as you said, yes, after surgery, we probably have to give more importance to neuropsychology and probably involve a psychologist, because we cannot generally send the patient to a psychiatrist directly, because as you said, stigma is definitely there. I cannot tell a patient to go meet a psychiatrist. So probably having a neuropsychologist in the team to assess him psychologically and look at those minor behavioral changes which can have a big impact on them going forward in the post-op recovery, and also managing the disease itself and dealing with the family, the patient, how he interacts with the family will go a big way in probably improving patient outcomes.
Absolutely.
Thank you for this talk.
Thank you. Thank you.
One important carry home message you gave is it is not just digital thermometer, but now on distress thermometer also is to be checked. Thank you.
We would like to invite the next speaker, Dr. Naveen Kadli, who will be talking on update in anesthesia considerations for cranial surgeries in neuro-oncology. Dr. Naveen.
Thank you, sir. So after 2 hectic days, last 15-20 minutes, so everybody can relax. So I'll be talking in next 15 minutes about airway management and neurophysiological monitoring under general anesthesia, positioning for craniotomies and their related problems, and differential emergence following craniotomy. Airway, intubating the patient is the first and foremost preference for any anesthetist. In neuro-oncology, we do come across difficult airway scenarios every time, most of the times. So more so when they are associated with head and neck cancers, tumors arising from base of the skulls extending into the cranial fossa. I would like to share my experience of dealing with one such patient in our institute. This is a case of maxillary sarcoma, highly recurrent. It's an 11-year-old child. She had undergone multiple surgeries for that. Her entire nasal cavity, oral cavity, and the right orbit was like one single compartment. So she was posted for excision of the recurrent sarcoma on the scalp with SOS craniotomy. So this is how she looked when the prosthesis was removed. She had a magnetic sockets in her right orbit. So for us, for any difficult airway, assessment and planning is the most important thing. So once that is done, we need to have a proper team to take care of the things and adequate help. So these are the key for successful airway management. In this particular case, we had two issues. One is mask ventilation was difficult. We could not achieve the proper seal. The second thing is our mouth opening was restricted. Say it was less than 1 finger. So our plan was to avoid awake fiber optic intubation, which is the gold standard for any difficult airway management. So we decided, since 11-year-old kid, we need some amount of cooperation from the patient, which is quite unusual. I mean, it's difficult to expect from her. So we plan to induce her and intubate her under general anesthesia. So we used Thrive. Thrive is a recent, technology or a new apparatus. We used it for pre-oxygenation and mask ventilation. We covered the right eye with the mops so that to establish a proper seal and there is no air leak. And we used video laryngoscope. instead of a conventional laryngoscope. The reason for that is since the mouth opening was less than 1 finger, the blade of the video laryngoscope is much thinner than the conventional laryngoscopes. We intubated her with a flexometallic tube, and one more issue we faced was while intubating, we could not guide the tube into the glottis. So we used pediatric Magel forceps through the right eye, and we could successfully intubate this patient. This is the Thrive. The full form is transnasal humidified rapid insufflation ventilatory exchange. So this is a recent phenomena where humidified temperature regulated oxygen is given at a very high rate of 70 to 100 liters per minute. So it takes care of even carbon dioxide elimination. There are many reports, and even in our institute we have tried for of apneic ventilation. Even after 45 minutes of apneic ventilation, PO2 and PCO2 are maintained within the normal range. So only thing is we need to maintain a proper unobstructed upper airway. Recently we had an emergency tracheostomy with a tracheal stenosis where ENT surgeon could not do tracheostomy also. So it was decided to do emergency thoracotomy on table. So we used this and for almost 40-45 minutes patient was the saturation was around 20-25%, not more than that. Somehow we could finish the surgery with all the effort, and the next day he was neurologically normal. So this is a very useful tool. This is how a McGrath video laryngoscope looks, and I feel these three things should be a part of difficult airway cart in the coming days. Coming to neurophysiological monitoring, it is basically done to assess the functional integrity of the nervous tissue, brain, spinal cord, and spinal and cranial nerves. It has taken out intraoperative awake test out of question, and basic goal is to alert the surgeon and to prevent damage to the normal brain tissue. So it can be done, we can monitor spontaneous brain activity like EEG or electromyography, or evoked response to a stimulus like somatosensory evoked potentials, brainstem auditory evoked potentials, visual evoked potentials. I think you people know this better than us. So I want to concentrate on the factors, intraoperative factors which affect the neuromonitoring. Anesthesia factors. First is volatile inhalational agents. All volatile inhalational agents, except to some extent sevoflurane, they cause dose-dependent suppression of the synaptic activity, and it depends upon the location of the synapses also. So most sensitive are SSEPs and MAPs, and brainstem auditory evoked potentials are resistant to the compared to the other this thing. Nitrous oxide, inhalational agents at a MAC of around 0.5 to 0.6, we still can use during monitoring. But once the MAC goes up above 1.2 or 1.5, the burst suppression and the complete electrical neutrality will be seen. So nowadays it is completely taken out of the question. Nitrous oxide has similar effects like volatile inhalation agents. It causes suppression of the synaptic activity, but along with the volatile inhalation agents, it has a synergistic action. Because of various other side effects, now we have stopped using nitrous oxide. In general, volatile inhalation agents have more suppressive, greater suppressive action compared to the intravenous agents. Among the intravenous agents, they do cause suppression of the activity, amplitude, and delay in the latency, all those things. But at clinically relevant doses, it is not seen, and they are considered as a part of the TIVA for neuromonitoring. Physiological factors include blood pressure. Any hypotension, definitely it suppresses the amplitude. So we need to monitor the blood pressure within 15 to 20% of the baseline. Ventilation, extreme changes in the PO2 and PCO2 to be taken care. Temperature, definitely hypothermia will suppress the amplitude. So we need to maintain the temperature within 2 degrees of the normal. Anemia affects the oxygen carrying capacity of the blood. So again, it will suppress the neurological activity. Patient positioning. abnormal patient positioning, shoulder lagging, excessive compression on the hands. All these things, they do affect neuromonitoring, and excessive traction applied at the surgical site. Those factors will also. Balanced anesthesia approach. Recent guidelines suggest we can use low dose inhalation agents at a MAC of less than 0.5. The reason for this is we can avoid excessive use of IV agents. I mean, mainly propofol. Propofol comes with infusion. Propofol infusion syndrome. The lactic acidosis builds up and leads to metabolic acidosis. So we can decrease the dosage of the propofol. Then propofol at a dose of 45 to 75 mics per kg per minute. So we can, fentanyl at 1 to 10 mics per kg per minute, or ramifentanil. Ramifentanil is not available in India. So along with that, along with these medications, we use dexmedetomidine. Dexmedetomidine, whatever the doses we use, we don't have enough literature to support that. What's its action on the electrical activity of the brain. But we usually don't use it at a higher dose. We use it around 0.5 mics per kg per hour infusion. So never forget to always keep the bite block in place. Whatever the motor MEPs we use, they cause masseter stimulation. So it ends up in cheek and tongue injury. So always remember to keep the bite block. Coming to the positioning, we will realize the importance of the position only when we lose the airway in the middle of the surgery. So there are various positions: supine, lateral, sitting, semi-sitting, and prone positions for craniotomies. The general concerns in these positions and their related issues are peripheral nerve injuries, skin pressure injuries, cervical spine injury, ocular injury, and most importantly, airway compromise. And specific to the sitting position are venous air embolism, hypotension, and pneumoencephalus. And in supine position, mainly anterior spinal surgeries, we should always monitor the cuff pressure and keep the cuff pressure between 20 to 30 centimeters of water. So mainly when we are using the retractors to avoid pressure related issues which can lead to dysphagia, RLN palsy, and hoarseness of the voice. Anesthesia mumps, it's a very benign condition which is seen not so frequently after the post-op. Silodinitis is mainly because of there are many reasons are there for that. One is dehydration or excessive air getting pumped into the salivary glands when we are doing the mask ventilation. But it's a benign condition. It doesn't cause anything. It just needs observation, analgesia, and anti-edema measures. But if this silodinitis or mumps is associated with other facial edema or pharyngeal edema or upper airway obstruction, then we need to be very careful with this. There are very few case reports regarding upper airway obstruction following general anesthesia. The one case report, one 70-odd-year-old lady who has undergone craniotomy for meningioma. In prone position. This lady was not extubated as a part of the hospital protocol. So, but she has developed slowly pharyngeal and facial edema, and they were not able to extubate the patient, and they took almost 6 to 7 days to extubate. So we need to be very careful with whenever we see silodinitis in the immediate post-operative period. So take-home message is we should never take the things lightly. Neck swelling and the facial swelling lightly. So we all know about delayed emergence from the general anesthesia. So there is something called differential awakening or differential emergence. So the few patients following GA, they develop a transient focal neurological deficits following sedation or general anesthesia. So which usually improve after a period of 30 minutes to several hours. The mechanism is it's unclear. Could be due to opioid or benzodiazepines. The reason for that is they have been reversed with naloxone or flumazenil. So it needs multidisciplinary evaluation along with the reason for delayed emergence from the anesthesia. Thank you.
neuro-oncology, when it comes to surgeon's point perspective, few tumors which are, on the dominant lobes, dominant in the sense motor cortex, so insular area, so where awake craniotomy is required. So
no, actually, I took 15 minutes pretty seriously. So I wanted to cover more topics. So I could not. The reason for that is
okay.
15.
One more comment is we recently had 2 of our patients with acute salinitis.
Yeah, one patient we lost.
These
Also.
things,
That's
and,
the reason I wanted to include it as a take-home message. And most of the cases are not reported. When I searched the literature, only 3 cases we saw. One of them, one patient after some colonic surgery under general anesthesia has developed upper airway obstruction. That patient succumbed. They could not intubate and they could not do even emergency tracheostomy. Our patient, it was like, so many things were happening. The monitoring was the problem. And one of our PG patient told us that, I'm not able to breathe. All those things are there. But we should have kept a strict vigil and we should have monitored the patient. We shouldn't have neglected the patient.
Okay. Thank you. Thank you very much.
Thank you.
The last session for today is a virtual one. I thank the chairpersons for conducting this session. The last talk is Managing Critically Ill Brain Tumor Patients, ICU Perspectives by Dr. Harish.
ICU perspectives. So let's see some facts about the brain tumor patient. About 15 to 20% of the patient, they need ICU admission. So if they got mechanical, it is around 20. So I have greetings from Department of Critical Care Medicine, Narayana. So in another 15 minutes, I'm going to discuss on managing a critically ill brain tumor patient. So what are the ICU perspectives? So let's see some facts about the brain tumor patient. About 15 to 20% of the patient, they need ICU admission. So if they got mechanically ventilated after getting endotracheal intubation, the mortality is around 20%. So the common indication for ICU admission is the convulsion, which happens in about 16%. So definitely, so there are particular group of patients with a background of brain tumor. They need ICU care. If they have a large space occupying hemispheric tumor, space occupying cerebellar tumor, tumor associated with multiple comorbidities, so post chemotherapy complication or in the post surgery era, so monitoring purpose, we might require intensive care unit. Or if the patient with the brain tumor had an acute drop in sensorium, so with a drop in sensorium more than 2 are like focal neurological deficits or acute changes in the pupillary picture, so they need a ICU monitoring and all. So is really an intensivist or an ICU care definitely is going to make a difference in brain tumor patient? Definitely yes. So might require some sort of airway support, clearance of the airway, protection of the airway, preventing an aspiration, providing oxygenation, preventing hypercarbia. So hypertension is a response to pain that we need to manage with a good sedation, analgesia, with a good monitoring. Avoid coughing, straining, which can kick up the intracranial pressure. So one thing we need to notice is don't compress on the jugular venous structure, which can create raised ICP by decreasing the venous return and all. Particularly if a patient developed pneumothorax or maybe a neck compression, rotate into some unilateral direction and all. So abdominal distension we need to avoid by nasogastric suctioning or decompression. Avoid fever, which kicks off the cerebral metabolic rate of oxygen consumption. Avoid hypoosmolar agent, particularly dextrose-basic fluid. Otherwise, it can also increase the cerebral edema. So one aspect in the ICU in a critically ill brain tumor patient, we need to maintain the glycemic control. Both high and that of the low sugar is bad, which may increase the size of the hemorrhage or infarct if a patient with brain tumor is associated. Maintain the sugar somewhere between 140 to 180. Both less than 110 or more than 180 to 100 is bad. Good glycemic control with the insulin infusion. So next aspect, we need to evaluate when a patient had a new onset of fever. Remember, fever may be non-infective origin or an infective origin also. So it may be because of the line drain related surgical site infection, or it may be ventilator associated pneumonia, Clostridial difficile, urinary tract infection, central line related like infection and all. Among the non-infectious causes, we have post blood transfusion, so thrombophlebitis, okay, superficial vein phlebitis, alcohol withdrawal. So even a patient with some sort of rhabdomyolysis, other connective tissue disorder with the background of brain tumor, they can manifest with the non-infectious fever. So in the same time, we need to understand the timeline of the fever. So first day of the fever in the post neurosurgery, so we need to attribute it to systemic inflammatory response syndrome, or it may be secondary to some drugs. Second day fever, it may be atelectasis related basal lung collapse. So third day may be line related infection, pneumonia, UTI in the fourth day. Fifth day is a surgical site infection. If there is an abscess, it is a seventh day fever. After the first week, we need to search for drug allergy, transfusion related fever, or if it is persistent fever, we need to search for any hidden abscesses. So in the post-neurosurgery period, we need to suspect post-neurosurgery meningitis as a source of fever also. We need to evaluate appropriately with the CSF glucose, sugar means lactate, gram stain culture with a routine complete hemogram with the markers of infection like procalcitonin, C-reactive protein and all. So depending upon the gram stain picture of the CSF, we need to choose the antibiotic based on the local antibiogram. So sometimes lack the CSF gives an idea whether it's a bacterial infection or not. If it is more than 4, so there is a strong suggestion patient might be having underlying bacterial infection. So that makes immediate idea to start the appropriate antibiotics and all. So in the same time, we need to concentrate on the central fever. So this is a non-infective fever, persistent fever, not responding to antibiotics can happen in about 5 to 50% of the patient. It is going to appear so somewhere 3 to 5 days, and it is going to persist even for several days or the weeks. So procalcitonin is normal, C-reactive protein may be marginally elevated. Therapy is bromocriptine, clonidine, baclofen. We can give to central fever, but the diagnosis is by exclusion. So next, seizure prophylaxis. Is there any evidence? Definitely no. No prophylactic anticonvulsant with the background of brain tumor. Only for the high-risk patient, we can give prophylactic anticonvulsant. There is a good data in favoring of levetiracetam as an anticonvulsant agent of choice. Patient can have the fever in about 5 to 15% of the incidence. Usually, it is going to be in the initial days of diagnosis of the brain tumor. So later, when it becomes chronic, less chance they will have the convulsion and all. So continuous EEG monitoring is needed when the sensorium is out of proportion to their brain involvement to pick up any sort of non-convulsant like status epilepticus and all. So as I told, prophylactic anticonvulsant not needed. This is the data from the meta-analysis which got published in 2019. So if at all indicated, it is levetiracetam is the option. So then giving prophylaxis is not going to be backed up by any sort of evidence in a low risk category patient. So because AED is having lots of drug interaction instead of the adverse effect that we need to keep in mind. So next, maintain the cerebral perfusion pressure somewhere around 60 to 70. Reduce the intracranial pressure if it is elevated below 20. So avoid hypotension, sudden drop in blood pressure. So modalities which reduce the ICP by reducing the blood flow should be avoided. So avoid hypovolemia, give adequate volume with a crystallite. So sometimes if it is a distributive shock like septic shock, we need to maintain the mean arterial pressure with a norepinephrine. The patient is having cardiac dysfunction, better to go for dobutamine or epinephrine to maintain the adequate cerebral perfusion pressure. What about osmotherapy? In an acute scenario, we can use intravenous mannitol of 20% 200 ml, or like hypertonic saline, whether it's a 3 or 7.5% saline of 100 ml we can give. Subacute, we can use glycerol, but there is a risk of hemolysis that we need to keep a watch. So there are negative effects of the osmotherapy, like shrinkage of the brain herniation, intracellular dehydration, rebound cerebral edema after 3-4 days of the therapy with mannitol. So mannitol can worsen the renal dysfunction that we need to keep a watch when we give osmotic therapy and all. Is there any difference between hypertonic saline and mannitol as a part and parcel of cerebral edema therapy? Definitely no. So this is the meta-analysis, don't shows any major difference, but there are small data available which showed favorism for 3% saline, which is more efficacious, but outcome in terms of reducing the mortality, both are equally efficacious. Is there any role for the steroid in brain tumor or metastatic brain tumor? So definitely when a patient is symptomatic, mild to moderate or moderate to severe, we can consider giving steroid, which is the option dexamethasone. In a mild category, we can give 4 to 8 milligram per kg, means 4 to 8 milligram per day. If a patient is severely symptomatic, 16 milligram per day. So we need to taper it over a period of 2 weeks. That is the advice from many of the guidelines in terms of using steroid in brain tumor patient, whether it's a metastatic or primary tumor, to reduce the perilesional edema. So you have to be very careful and routinely practice the ICU like care approach. Putting a central line during like intubation, they can have a rise in intracranial pressure. So don't use acetylcholine, use rocuronium for intubation. Manage and monitor analogous sedation with a bispectral index and all. So PEEP, don't be elevated in an uncontrolled way, but if that is serving in terms of improving the oxygenation, we can give the PEEP maybe up to 8 to 10. It is not absolutely contraindicated. So tracheostomy, we need to consider in an appropriately timed manner, depending upon the sensorium, is risk of aspiration, is ability to protect the airway and all. So this is a stage case approach in the treatment of intracranial pressure. First, intubate the patient. So if patient is dropped sensorium, sedate him with adequate sedation, ventricular CSF drainage, hyperosmolar therapy with mannitol or 3% saline, induced hypocapnia with hyperventilation, transient solution maybe for 30 minutes. If you prolong the hyperventilation, it may have rebound increase in cerebral vasodilatation. Maintain CO2 of around 32 to 34. No much data for hypothermia, barbiturate coma. Ultimately, we have to open the cranium if it is refractory in intracranial pressure and all. So nutrition, we need to take a call. So malnutrition definitely increases the morbidity and mortality. Consider feeding as early as possible. Calorie of around 20 to 35 kilocalories per kg per day. Protein is very, very important. They are highly catabolic. So we need to supplement the protein of 1.5 to 2 gram per kg per day. If you delay in initiating assessment for the swallowing deglutition, 1% increase in pneumonia risk because of the aspiration with each day delay in assessment. So initiate screening for the like swallowing and dysphagia as early as possible in a brain tumor patient. So patient can manifest with electrolyte disturbances in about 30%. They can have hyponatremia, either it is SIDH or cerebral salt wasting syndrome. If you see the picture, both have low sodium less than 135, high urinary osmolarity beyond like above 300, or high urinary sodium more than 40. So low serum osmolarity, but only volume status which differentiate between a high means SIDH or cerebral salt wasting syndrome. SIDH is euvolumic or hypervolumic, cerebral salt wasting is hypovolumic. Therapy is different. So in cerebral salt wasting syndrome, we need to support the volume and we can use fludrocortisone. In SIDH, so we need to restrict the volume. Sometimes we need to give the diuretic also. Very, very important. There are certain poor prognostic indicators in a brain tumor patient to predict the mortality and morbidity: fever, hypotension, hypertension, poor glycemic control, hypoxia. So if a patient had anterior circulation stroke with a brain tumor, so pontine hemorrhage, acute drop in GCS, heart failure, so acute onset of hemiparesis, these are all the poor prognostic indicator in a patient with a brain tumor. So other therapies like giving a thromboprophylaxis, head and elevation, so DVT prophylaxis, stress ulcer prophylaxis, good glycemic control, so spontaneous breathing trial to wean the patient, so avoid constipation, remove the Foley's if it is not necessary, de-escalation of antibiotic, appropriate diuresis. These are all the part and parcel of the general nursing care in a critically ill brain tumor patient that we need to practice. Thank you.
With this, we come to the end of our Neuro-Oncology Symposium. I thank everyone for being a part of this. And I call Dr. Satyanarayana to give the vote of thanks.
Now, before vote of thanks, we had a quiz competition for residents yesterday and would like to call upon the prize winners now. And I can now call upon Dr. Tejesh Shavi from Manipal Hospital, a final year resident, who has bagged first place in quiz competition. So now I call upon second prize winner, Dr. Pooja Taneja from Narayana Health City.
So with this, we come to the end of Narayana Neuro-Oncology Symposium 2022 and NVSS Oration 2022. It was a hectic day today, as it was yesterday, and we could complete the entire session as we had planned. Thank you for your patience. We overshot by maybe an hour, but it was worth it. We all enjoyed, and it was a real academic feast. And I hope each one of you would have taken sufficient to think about and utilize this in your day-to-day practice. All the residents, consultants, everybody have gotten something out of this. And I hope this will be useful for you in the days to come throughout our life. And we had a wonderful oration from Dr. Suresh Nair, which it was real demystifying the myths in vestibular schwannoma surgery. And that was the highlight of the whole program. Thank you for your attendance and coming over and all the cooperation to make this event a grand success. And I take this opportunity to thank our marketing team from Narayana Health who have strived hard to make this event possible. And I thank our event managers, Avia, for making this event see the light of the day in a wonderful way. And last but not the least, I thank our other sponsors from Pharma, the Sun Pharma and Microlabs, who have helped us in the logistics and to make this event happen. Thank you very much.